So let's start with today's topic. What is new in cardiology? We all know about the mitral valve, and mitral valve is a very unique structure in our cardiac physiology. We all know from our MBBS education that mitral valve is a bileaflet structure, anterior leaflet and posterior leaflet, and these leaflets are suspended between the atria and ventricle with the help of chordae tendineae, and these chordae tendineae are attached to the papillary muscles, and these papillary muscles are attached to the left ventricular wall. And that's how the mitral valve is present. And whenever there is a contraction, we know that mitral valve is going to be closed, and when mitral valve is not able to close properly, it is going to result in regurgitation. And we all understand that pulmonary veins, they are draining into the left atrium, and these pulmonary veins, they don't have the valves. That is very, very important thing. So whenever there is a mitral valve regurgitation, the pressure in left atrial that gets elevated, and this is going to be transmitted directly into the lung. So that physiology we must understand whenever there is a patient who has got mitral valve regurgitation, because this is what is going to affect the long-term outcome. Now, why there is a regurgitation? We know from our basic sciences that mitral valve is suspended in the left ventricle, and whenever there is a problem in the leaflets, and because of this problem in the leaflets of chordae tendineae, there is a leakage in the valve, or the valve is not able to close properly. That is what is called as a primary mitral regurgitation. And when the leaflets are fine, the functioning of leaflet is okay, but due to the problem of the left ventricle or left atrium, if left atrium is enlarged or left ventricle is getting enlarged, these valves are not able to close properly, and that is what is known as a secondary mitral regurgitation. So mitral regurgitation going to have two type of things, primary and secondary. As the mitral regurgitation progresses, there is a progressive dilatation of the left ventricle, and as there is a progressive dilatation of the left ventricle, functioning of left ventricle is going to go down, and that eventually results in the cardiac failure. Without intervention, symptomatic mitral regurgitation will have an annual mortality more than 5%. That is very high. And because of this, the guideline they have recommended, if patient has got a mitral regurgitation which is moderate or moderately severe, and patient is symptomatic of, or if there is a left ventricular dysfunction, these patients should be subjected for intervention either in the form of surgery or any other thing which is available, because we don't want mitral regurgitation to go on. So the problem is how to tackle this mitral regurgitation. Mitral regurgitation can be tackled either you repair the valve or replace the valve. We know that we cannot make anything better than God. So always we try to preserve the original or native organs as long as possible, provided there is no deterioration in the functioning of health, or in this particular case, heart. So as far as repair of mitral valve is concerned, it's a very tricky procedure and very difficult procedure. And I'm pretty sure that you all are here and you have been referring your patients to the various hospitals. Rarely you might have encountered that your patient you have referred and has come back with mitral valve repair. Majority or maximum times it is the replacement. And replacement per se is itself a disease for that particular patient. So in 1987, since it's a very difficult procedure, an Italian surgeon, he devised a technique, and with the help of that technique, the mitral regurgitation was reduced. And what he did, he approximated, or he made the single orifice mitral valve into the double orifice mitral valve, like this. He placed the one stage between the anterior mitral leaflet, mid segment of anterior mitral leaflet, and the posterior mitral leaflet. And he found that now the closing of the valve is very proper. And this was a revolution in 1987. And whenever the suitable patients are being treated with this technique, the result was very good. And I had a privilege of meeting this renowned cardiac surgeon, and it was really a privilege. But in 1990, Dr. Frederick Goer, who is an interventional cardiologist in US, he started thinking, for putting one stitch, you have to do such a big surgery. You have to open the chest, put the patient on bypass machine, and place one stitch and come out. So he, in 1990, he proposed a technique by which we can we can place a stitch without opening the chest. And from there, a development started. 1990, he put a concept of mitra clip. And that was 1990, and first patient was done in 2003, and from there the trials started. And average 2 trial was done, and it was compared this technique directly with the surgery, and they have found the surgery is better. But the important thing from this trial came that this is a feasible, safe, and effective procedure in patients of mitral regurgitation. So after this, again the trials started. Initially they thought, why not we should do a trial in which there is a secondary mitral regurgitation. I mean, the patients who have got myocardial infarction or cardiomyopathy, whose heart is dilated, and there is not a proper cooptation of the mitral valve, which is responsible for mitral regurgitation. So these subset of the patients should be taken. And on the basis of that, one landmark trial, co-op trial, was conducted, and it was presented in 2019. So see, a concept came in 1990, and first in man was done in 2003. This device got approval of European Union in 2008, and in 2013 this device got approval from FDA, and this trial was presented in 2019. And this trial clearly showed a patient who have got a severe LV dysfunction and mitral regurgitation, which are not being controlled with drugs only. If you do a device, or if you put a mitra clip in those subset of patients, the results are profound. They are very good. NNT, this is number needed to be treated, means to prevent one death or recurrent cardiac hospitalization because of heart failure. You have to treat 3.4 patients a year, going to prevent one event. That is a very, very significant result. So this trial concluded that this is a very effective modality for the treatment in mitral regurgitation because of the heart failure. And on the basis of this particular trial, the recommendation came as a 2A in the literature of cardiology. And when we say 2A, so what is class 1 recommendation? Class 1 recommendation, if anyone who has got a class 1 recommendation, means this is a recommended or indicated therapy. Class 2 is again divided into 2A and 2B. 2A should be considered, and 2B may be considered, and class 3 is this therapy is not going to be effective. So on the basis of these trial in 2019, in 2023, this device was given a 2A recommendation. But again in 24, Matterhorn trial, this was done to show non-inferiority of this device in comparison to surgery, and they found this device or this therapy is non-inferior to the surgery. And again in 24, one more trial came, that is a reshaped HF2 trial, and this trial again they have divided into two group. Control group means patients were put only on medicine, and another group patient with medicine plus mitral clip, or that is treatment of mitral regurgitation with the help of this device. And this trial was again a very successful trial, and because of these two trials, the recommendation which was 2A in 23 became class 1 and 2025. So this is a very effective therapy. Now coming to our case, 84-year-old lady who had bypass surgery in 2000, presented with heart failure. Her ejection fraction was 30%, and she was having severe mitral regurgitation. In spite of 2 years very aggressive medical management, she was requiring a repeated hospitalization due to heart failure. And this was her echo, and you can see this is aortic valve, this is a mitral valve, this is left atrium, and this color which is coming as a blue, this is a short axis view showing the functioning of heart is around 40%. And now you will see in this view, this is a tricuspid regurgitation, and now this is a mitral regurgitation. Whole LA is getting filled with mitral regurgitation. So this patient was taken for heart team approach. So should we subject this patient for isolated mitral valve replacement? And when we calculated the risk for this particular patient came out to be 47.9% for morbidity and mortality. And if you see alone mortality, operative mortality in this particular patient, it was 28.7%. This is a very, very high in 84-year-old lady. So what are the options? Should we keep the patient on medical management? However, this patient was on medical management for last 2 years, and there was a repeated hospitalization. So the best option in present scenario was to put a mitral clip. So how do we do this procedure? So we take a venous approach. The puncture is done in the right femoral or left femoral vein, and we insert our device. We go from femoral vein to IVC to right atrium. And in right atrium, there is a interatrial septum, and in the fossa ovalis, we do a puncture, and we enter from right atrium to the left atrium. Because unless you go into the left atrium, you cannot access the mitral valve. And once you reach to the left atrium, you deliver your device, and there is a clip. You place the clip acts as a suture, and our procedure is done. So this is an animation which will give you a clear indication, a clear picture of the procedure. This is a mitral regurgitation. This is what is a device which is placed, and this is a guiding catheter which goes inside the heart. The diameter of this device is 24 French, which is equal to 7.5 millimeter. So we go from interatrial septum to the left atrium. This is a cartoon of mitral valve. Now our clip is coming, and this procedure is done under the transesophageal monitoring, and we can see all these things in the echo and on the floor also. we can maneuver this device and we can open the clip. Once you open the clip, you do the echo which is continuously going on. You can see where is the regurgitation. This is a leakage which is coming from left ventricle to the left atrium. Once you see your device is directly there, you push the device down in the left ventricle, pull it and close the clip, and by doing that you will be able to place the stitch in the mitral valve. And once it is being done, you can remove this device and there will be only clip, nothing will be there, and the single orifice mitral valve has been converted into double orifice mitral valve and the closure is proper. This is what is done in patient. This is a 24 French sheath which has gone into the left atrium. This is what is a clip which is looking like. We are opening this, we are seeing this. Now we have gone into the left ventricle and we are going to pull back and we will close the clip. And now see, we are releasing the clip has been released. And once the clip is released and your echo shows that patient's the regurgitation, the leakage is not properly controlled, then you can put one more clip. We are going to place another clip in this patient, and once you do that, your transesophageal echo will show how the patient is doing. This is what is clip looking like, and now you can see the leakage has come down. So to conclude, the transcatheter repair of the mitral valve is a very good option in the indicated patient. It is safe, effective, and recommended treatment. This device was approved in 2013, and the initial trial were done with the first generation device. Now we have got a fourth generation device which is more effective, more safe, and the effect is better, and the results are phenomenal. So any patient who has got a severe mitral regurgitation, severe LV dysfunction, the placement or the control of mitral regurgitation with the help of percutaneous tracties is an effective and recommended therapy in the current era. Thank you very much.
Thank you, Dr. Rajiv Rathi, for your excellent, it was really excellent presentation, and the slides were also very, very good. Overall, I am not a cardio person, but it was very nicely presented. So this new intervention, which is a replacement of open surgery, which we have first used to take for this mitral valve regurgitation and all. These mitral clips and a way transcatheterized introduction into the heart is really, really like a dream and amazing. So I congratulate you. Just keep on doing such, go on upgrading it. And just I want to ask one thing. I think it is just the daycare, or it requires admission?
No, it's not a daycare procedure because it is done under general anesthesia.
Okay.
And usually patient has to remain in the hospital for 2 nights.
2 nights, okay.
But patient will be ambulated next day morning.
Okay.
So that's not a problem.
Achha. And sir, one more thing. What is the cost of this?
Presently the cost is high, but gradually we'll see the cost will come down.
Okay.
2 years back the cost was around 34 lakhs for one patient. Now the other devices have also come, so that is costing around 21 to 22 lakhs. So as the procedure will keep on going, so the cost will come down. At present, worldwide, around 2 lakh patients have been treated with this device. So Now the cost will come down. There is no doubt about it.
Yes. Thank you, sir. Thank you once more. That means I really appreciate that no opening of the heart. That is very, amazing for me. And you can do such a great work. It was previously a complicated one.
It's a very, to be very honest, this procedure is a very different procedure. It's a little complex procedure, but it gives enough time to the operator because there is no hurry. We can see whether we are able to close it properly. If clip is not being closed properly, we can retrieve unless we have delivered. Once you have delivered, then you cannot you cannot take out the clip. Otherwise, you can maneuver, you can take your time. On an average, we do this procedure in 45 minutes to 1 hour. But in some patients, if the procedure gets extended, there is no problem. Patient remains safe.
So it's a paradigm shift in the management of valvular heart disease, as the sir said. So I would like to invite the audience to ask few questions.
What are the complications of this procedure? Does it cause mitral stenosis and eventually complications of mitral stenosis occur?
That's a very good question, doctor. When you are converting one orifice into two, so logically we will definitely think that this will cause a stenosis of the mitral valve also. When we select the patient, the first thing is the mitral valve area should be 4 centimeters square, which is the normal. It should not be less. Any patient who has got a rheumatic heart disease should not be treated with this device. That is a contraindication. And when you place the clip, you can measure the gradient because constantly live 3D transesophageal echo is going on. If your gradient across the mitral valve, mean gradient is more than 6 or 5, then you will think that should we go ahead, deploy the clip or not. If gradient is less than 4, less than 5, you are sure that patient has not developed mitral stenosis or there is no restriction to the orifice. That is a very important thing and we should remember that thing because otherwise you are going to convert regurgitation into the stenosis. So selection of patient is important and when you are doing the procedure, you should see that there should not be gradient more than 5 across the mitral valve. Any patient who has got rheumatic mitral valve disease, this procedure is contraindicated.
Then option remains about the atherosclerotic disease then.
No, it is not atherosclerotic diseases. See, if you have got myocardial infarction or cardiomyopathy, what happens? LV function goes down, heart gets dilated. When heart is dilating, the approximation of mitral valve is not proper and there is a leakage. In that particular scenario, if you put a clip, if that regurgitation is not being controlled properly with optimal medical management, you place the clip. So then you are going to reduce the regurgitation or you are going to abolish the regurgitation. So repeated hospitalization and mortality is going to come down.
You mean to say it is a dilated cardiomyopathy which you select mostly?
It is not. It is any patient who has got severe LV dysfunction or LV dysfunction with moderate or severe mitral regurgitation after the optimal medical therapy. So if you have got now I'll give a very simple scenario. If you have got a patient who has got a LV dysfunction, ejection fraction around 30, 35%, 40%, whatever it may be, even 50% with mitral regurgitation, and you are not able to reduce the mitral regurgitation with medical management. These are the patients who are going to be benefited.
Have you come across the cases those are having slipped or dislodged that clip and having a complication? Let us know any complication. Have you faced?
Clip dislodgement is a potential complication, but to be honest, it's a very rare thing because this procedure gives enough time and there are a lot of safety mechanism. But if there is a embolization of clip, by no means we can retrieve this percutaneously. Then the patient has to go for surgery.
Are they prone for
I think we will take the next questions in the break because we are running short of time. I would like the chairperson to kindly conclude the session. Thank you, sir.
With the permission of chair, I would like to present only one thing. This is regarding the Heart app, which is now available on both the platform Android and iOS. And this platform, this is for management of INR and to assess the symptoms of myocardial infarction or angina and how to prescribe the newer oral anticoagulant, that is apixaban, rivaroxaban and dabigatran. Thank you very much.
Thank you. Thank you, Dr. Rajiv Rathi, sir, for this excellent deliberation, and thank you, audience, for active participation. Now this session is over.
Thank you, sir. Now I request our esteemed chairpersons, Dr. Rajkumar sir and Dr. Kavita Ganjre ma'am, to kindly felicitate our speaker, Dr. Rajiv Rathi sir, with a shawl and a memento. Sir, please. Ma'am, please. Sir, please. तालियों की कमी नहीं होनी चाहिए. Now I request Dr. Sanjay Kumar sir, CMO and Area Medical Officer, Hasdeo Area ACCL, to kindly felicitate our chairpersons, Dr. Rajkumar sir and Dr. Kavita Ganjre ma'am. Thank you, sir. Thank you, ma'am. Now, for the next session, I would like to invite Dr. Sushil Jain, HOD, Department of Pulmonology, Ramakrishna Care Hospital, Raipur, to present his session on recent advances in pulmonology. To chair this session, I would like to invite Dr. Vivek Khare, sir, CMS, NCL, and Dr. R.K. Pathak, sir, ex-CMS, ACCL. Sir, please.
A very good morning to all of you. Today is the first day of a new month, and since yesterday we all have been watching the explosions which have been occurring in the mines. The Middle East war is going on, but what we are worried about the explosions which are occurring in our mines, and we have to take care of that. And with the motto like "Healthy Mines, Healthy Nation," is strengthening healthcare across coal India. Now we have with us a very eminent pulmonologist, Dr. Sushil Jain, who will enlighten us about the various advancements which have been done in the field of pulmonology. In case of mines, once you think of any specialty which is most prominent or most helpful for the mining area, that is comes the topmost is the pulmonology. Whether you say it is all the statutory diseases, all the notifiable diseases, almost 90% of they deal with the pulmonology also. So I'm sure that our audience, all the GDMOs and specialists will be immensely blessed with your knowledge. And to give a brief, short CV, Dr. Jain, he is MBBS DNB from DTCD. He has done fellowship in the interventional pulmonology from the France, fellowship in the interventional pulmonology, Heidelberg, Germany. As for his current position, he is HOD Department of Pulmonology, Ramkrishna Care Hospital, Raipur. He has done steering also endoscopic ultrasound section, World Association of Bronchology, governing council member, Indian Association of Bronchology. He has also done DNB. He has been an examiner of a DNB and a teacher. He has held positions like Joint Secretary, Indian Association of Bronchology. He was immediate past chair of the award committee, head Department of Pulmonology, Koklabin Hospital, Mumbai, senior consultant pulmonologist, Global Hospital, Mumbai, consultant pulmonologist, Aditya Birla Hospital, Pune. So with all these accolades under his name, I am sure the audience, all the GDMOs and the specialists in this hall will get immensely benefited. Now I ask Dr. Sushil Jain to present this seminar.
Thank you. Yeah. Thank you, chairpersons. Thank you. That's too high. Thank you, respected chairpersons. At the outset, I'd like to thank the organizing committee for inviting me for this prestigious conference. After a very enlightening lecture by my previous speaker, Dr. Rathi, I'll try to cope up with his standards and try to make it better than the previous presentation. Now, till date, maybe say about 20 years back from now, pulmonology was nothing but four drugs and 2 inhalers. People used to call it like that. But now things have evolved. We have gone beyond pills and inhalers, and we have moved into a new era of interventional pulmonology. Before going ahead with my talk, just a brief highlight about my department, which is one of the busiest departments of pulmonology in central India. Now, why this talk? Now, pulmonology has evolved beyond inhalers, antibiotics, steroids, and oxygen therapy. Today, we offer minimally invasive procedures, diagnostic precision with advanced therapeutic interventions, and we can do faster diagnosis and quick symptom relief of our patients. After this talk, you'll be able to know the recent advances in pulmonary diagnostics and therapeutics, when to suspect patients needing interventions, which procedures are available and accessible in this part of the country, how these procedures benefit the patient, and when to refer this patient early. That's an important thing because late referrals can cause more morbidity and mortality to the patients. Now, coming to interventional pulmonology, it's almost, you have all heard about interventional cardiology. Interventional pulmonology is a relatively new subspecialty in pulmonology where we do minimally invasive diagnostic and therapeutic interventions. It covers the airways, the lungs, the pleura, and the mediastinum. Now, I'll just try to keep it more simple for the clinicians who encounter common situations in their practice. I'm not going into too much of advanced things. I'm trying to make it those common procedures and interventions which are required in day-to-day clinical practice. Now, these are the certain common clinical scenarios. Thus, is first is the mediastinal lymphadenopathy. Now, in olden days, we used to, every patient with mediastinal lymphadenopathy used to receive anti-TB drugs. But believe me, there is a significant proportion of patients who don't have tuberculosis, but they receive AKT. So now things have changed, and now we can take sampling from the mediastinal lymph nodes with minimally invasive way without any surgical intervention. So we can take sample from the mediastinal lymph nodes under real time, and this is one thing which is coming up in a very big way. We do it in our practice. Then comes the undiagnosed pleural effusion, hemoptysis, airway foreign bodies, lung mass or tracheobronchial mass, and pneumothorax with a bronchopleural fistula. These are a few common scenarios we all see in our practice, and I'll just try to summarize by showing exactly cases where we have done the relevant procedures and have benefited the patient. I have tried to make it simple and understandable for the physicians and other specialists. Now, this is the case scenario of a young male with mediastinal lymphadenopathy, a 35-year-old male presented with a history of cough, loss of appetite, and mild breathlessness on exertion since 1.5 months. His routine labs were normal, except his ESR was raised. His MAN2 test was negative. And this was the chest X-ray of this gentleman. Anyone can describe this X-ray, please? Let us try to make it interactive. So this patient is having a bilateral symmetrical hilar lymphadenopathy. So we went ahead and did a CT scan of this patient, which showed bilateral hilar and mediastinal lymphadenopathy with small nodules which were seen throughout the lungs in bilateral lung fields, and there was also a hepatosplenomegaly. So we went ahead and did a bronchoscopy. In this bronchoscopy, in the airways, you can see nodularity over the airways walls. You can see, we call it as a cobblestone appearance. They are nodular mucosa of these airways. And this is, here also you can see some nodules in the airways, and there is some stenosis of this airway. So if such a bronchoscopic finding is there, then we have a we narrow down the diagnosis on this particular case situation. Now we did a BAL, and multiple endobronchial and transbronchial lung biopsy were performed. Also, we did something called EBUS TBNA, that is endobronchial ultrasound guided transbronchial needle aspiration. This is a new technology which is now available, and we are able to do it we are doing it since last almost 9 years in Raipur. We did a subcarinal and right paratracheal lymph node sampling, and we did cytology, histopathology, and cultures. Now, before we go ahead with the further details of this case, let me describe about this new technology, which is endobronchial ultrasound. It is similar to EUS, which the gastroenterologists do. The processor is same, the scopes are different. This is the machine, the EBUS machine, and you have a specialized scope called endobronchial ultrasound scope, which has a transducer at its tip, and you can do a sonography from inside the airways. It's something like that, and you can take real-time sampling with the help of this needle, which goes into the lymph node and take a real-time sampling of the lymph node or any mass surrounding the airways. So this is a diagrammatic representation. So this is the scope inside the airways. This is scope going inside, and under real time I am taking sampling from the lymph node. So this is again a diagrammatic representation how it works. You can see this, you have put the scope there, and you are taking a real-time sampling. This is I'll just show you the video of one of our patients, in this case which I've just described. So we are doing a real-time sampling of the lymph node. You are able to see your needle going inside the lymph node and taking the sample. You can see that needle. Yeah, this is the needle which is going into your lymph node and taking a real-time sampling. So you can't have better thing than this. And then in this patient, coming back to the case, the histopathology showed non-caseating granulomas. AFB was negative, gene expert was negative, and the serum ACE level of this patient was high. So we concluded a diagnosis of sarcoidosis. So again, now there is always a confusion between sarcoidosis and TB. And Indian scenario, it's important that you try to confirm the diagnosis, because a lot of times these patients land up in receiving anti-TB drugs. So you have to make a definitive diagnosis, and this technology can help you to do that. Coming to next common case scenario, a unilateral undiagnosed pleural effusion. This is a gentleman, 68-year-old male, presenting with a history of cough, loss of appetite and weight loss since last 2 months. The X-ray chest shows left pleural effusion. There was a pleural tapping done. The pleural fluid report was suggestive of an exudative lymphocytic effusion with a low ADA and a negative cytology. So this is an undiagnosed pleural effusion. Your pleural tapping has not given you a conclusive answer. So what should be the next step? So for this, there's a new thing which has come up called flexi-rigid medical thoracoscopy. This is again something which has really given us a very good tool by which we can diagnose such cases. This is a thoracoscope which is used under local anesthesia and sedation. We go into the thoracic cavity with a 1 centimeter small hole, and we examine the pleura and the lung surfaces, and where we can take real-time sampling from these those places where you find that this is looking you can have a tissue diagnosis. If you're suspecting that this pleural surface is abnormal, a lung surface is abnormal, you can take biopsy from there. So this is something which we are using it in our day-to-day clinical practice. This thoracoscope looks almost like a bronchoscope. This is only under sedation, and if someone can put an ICD, this is similar to that. The hole is similar to the size of a chest drain. We put a thoracoscope through that single port. We go inside the pleural surfaces, inside the pleural cavity, and this is the same patient. We are seeing a lot of nodularity all over the pleural surface and the lung surface. There is still some fluid there. The lung has not completely expanded. This is like a trap lung, and I am taking multiple biopsies from the abnormal pleural surfaces. This is a day care procedure. So you can do it, the patient can go home on the same day. So we have taken a pleural biopsy, and the final diagnosis turned out to be adenocarcinoma of the lung. So we can make a definitive diagnosis. Otherwise, this would have been missed, and most of the patient land up in receiving anti-TB drugs for whatever reasons, but then you may misdiagnose and mistreat the patient. So this patient was diagnosed with adeno-CA and was referred to oncology department for further management. Coming to another common situation where we have a hemoptysis. If there's a large hemoptysis, and if the patient is becoming very hypoxic, then we can manage this patient with our bronchoscopic interventions. In this patient was in the ICU, had a deranged INR. The patient was sick on ventilator, and this patient had massive hemoptysis, and the whole lung was collapsed. We did the bronchoscopy. There was a large blood clot obstructing the left main bronchus. We removed this blood clot and achieved hemostasis with the help of local therapy. This patient had an upper lobe lesion, endobronchial mass, from where the patient was bleeding. So we coagulated that endobronchial lesion, and we opened up the airways. The X-ray post-procedure is looking normal, and this patient later was referred for surgical intervention. So this was a life-saving procedure. A similar procedure where the patient was having massive hemoptysis, was severely hypoxic, not getting ventilated, came to our emergency department in a hospital. This patient had an upper lobe cavity, tubercular cavity, from which the patient was bleeding. So we went ahead and we did a rigid bronchoscopy in the ER itself. The patient was not giving enough time, so we went ahead and did a rigid bronchoscopy, removed such large blood clots from the airways, and we achieved hemostasis with the help of local treatment in the airways, and the patient became, the hypoxia settled, the patient saturation came back to 98%. We removed all the blood clots, and then we continued with the anti-tubercular treatment. The patient survived. 20 years back, such patient would have died. We were not able to help these patients. Now we are able to salvage the lives of these patients with the help of these therapeutic interventions. Now we are doing many more interventions which we have grown over the years, and we are able to salvage the life of these patients. Coming to another interesting technology, which is called as bronchoscopic cryotherapy. This is again an interesting tool which is available for the pulmonologist. Here we have a flexible probes are there which can pass through the bronchoscope and go inside the airways, and we can do various therapeutic interventions with the help of cryotherapy. Cryotherapy is the use of extreme cold to destroy the tissue using rapid freeze-thaw cycles. It is based on the Joule-Thomson principle, whereby a liquefied gas exits through a small orifice, which is a flexible catheter. It undergoes rapid conversion and expansion to the gaseous form, causing freezing of the tissue in contact with it. So we freeze the tissue and devascularize the tissue and destroy the tissue and we remove it. So this is the concept for cryotherapy. This is the cryotherapy unit, and this is the flexible cryo probe which can go through the bronchoscope into the airways and we can do the relevant procedures with the help of it. Indications of bronchoscopic cryotherapy: it is used for doing cryobiopsy for definitive diagnosis of interstitial lung diseases. Previously we used to go ahead for the VATS biopsy. Now we can do it with the help of a cryobiopsy. No, we don't need to the patient don't need to undergo surgery for it. You can do a cryobiopsy and can give definitive diagnosis of selected cases of ILDs. Now we can bronchoscopically remove large blood clots from the airways with the help of these cryoprobes. We can resect or debulk tracheal or bronchial tumors with the help of it. We can do bronchoscopic removal of organic foreign body, certain foreign body which are impacted in the airways, and with the help of cryo you can remove organic foreign bodies, especially something like a peanut or a betel nut which is inside the airways. You can use the cryo probe and you can remove foreign bodies with the help of it. And we can take mediastinal lymph node cryobiopsy. That's the next step which we have started doing it in our center. This is the case of a 4-year-old boy who came with aspiration of a peanut. So we went ahead and used the cryo and we were able to remove this. This was an impacted in the distal airway, so it was difficult to remove with a conventional forceps. So we are using the cryo and removing it. The foreign body get attached to the tip of the cryo probe and then we remove it in toto. So we have removed it, and this is the extracted peanut, you can see that. Again, this is an interesting case of a bronchoscopic resection of an endobronchial mass. Now there are situations where the patient is not fit for surgery or the patient is not a candidate for surgery, and such cases, if they have large mass which is causing obstruction of the airways, we can resect it with the help of bronchoscopic techniques. Here we have used rigid bronchoscopy with endobronchial debulking with the help of cryo. This is a chest X-ray of a patient. Her right lung is completely collapsed. Patient is quite symptomatic. We did a CT scan. There was a right main bronchial mass. You can see in this patient, I'll just show you. There's a right main bronchial mass there. So this is the mass which is inside the right main bronchus there. So we went ahead and did a bronchoscopy, rigid bronchoscopy, and we removed it with the help of snare and cryoprobe. This is again, we are the only center in central India where do this procedure. So we are removing the mass in piecemeal. So the large pieces can be removed with the help of a cryo, and we are using the snare along with it. So such large chunk of tissue can be removed with the help of a cryoprobe. And you can see the airways opened up. The patient was referred for further management to the oncology department after that. The X-ray chest is showing complete expansion of the lung. which was initially collapsed. Another similar case of a 45-year-old female presenting with a history of gradually progressive breathlessness and cough since 4 months. This lady was diagnosed as asthma and was treated with inhalers. This was a High Court advocate. She came to us and was labeled as asthmatic. At presentation, she had stridor. On examination, urgent CT scan was performed, which showed almost 80 to 90% obstruction of the trachea. There was a large tracheal tumor sitting there, and we have to take her for urgent rigid bronchoscopic resection of the tumor. So we went ahead and we used laser here now. That's another thing which we have been using now. So this is a large tracheal tumor. We ventilated this patient under this procedure was under GA. We ablated this tumor with the help of laser. We use holmium laser here. We gradually resected it, and now this airway is opened up completely. Now the patient is safe to undergo a definitive procedure in the form of resection and anastomosis by the surgeon. But in the way the patient presented to us, this patient could have not survived if this urgent procedure was not done. So this is an important thing to understand, that such procedures can be life-saving, and if accessible and available, can really help all of us. Coming to another case of a patient with tracheoesophageal fistula. This is a patient of CA esophagus and was compressing the airway, as well as there was a tracheoesophageal fistula. The patient was having recurrent pneumonia because of aspiration through the fistula. So, and there was also compression of the airways causing breathlessness in this patient. So we did something called tracheal stenting, which is a palliative procedure, but then can help the patient. And once we have done this procedure, the patient can undergo chemotherapy and other treatment modalities. So this is a large fistula, you can see this. So there was a tracheoesophageal fistula, as well as there was a compression of the trachea by the esophageal mass. So we are putting a tracheal stent there, similar to the stent which the cardiologist put, but then there are different sizes available. We put covered metallic stents, or we can sometimes put silicon stents. So we are now putting the stent there. In our center, we do the largest number of central airway procedures in central India. So this was a stent which was placed inside the trachea, and then patient was referred to the oncology department for chemotherapy. Another interesting case of a patient with a pneumothorax. Now, pneumothorax is a very common situation which we all see in our clinical practice. This is a 28-year-old gentleman presented with a history of cough, chest pain and breathlessness in 3 days. Chest X-ray showed left-sided large pneumothorax. An ICD was closed, intercostal chest drain was pushed, 24 French ICD was placed on the left side. Despite ICD placement, the lung did not expanded on the X-ray, and there was a persistent air leak in the ICD bag on day 5. Now, this patient didn't wanted to undergo any surgical intervention, so we decided to do a bronchoscopic minimally invasive procedure in this patient. What we did was something very different. We first localized the leak from the airways. Where was the leak there? We found that it was in the upper lobe. There was a leak in the upper lobe, one of the segmental bronchi of the upper lobe where the air leak was there. So we went and did something called bronchial embolization with the help of a silicon spigot. And this procedure can be done again. It's like you can do the procedure today and send back the patient home on the next day. So we did the bronchial embolization under CIAM guidance. We are putting a silicon spigot. We localize the fistula with the help of, first we do a CT, and then bronchoscopically we localize the fistula. And then we are placing the silicon spigot from where there is a leak, air leak from the lungs. And also we use glue to close the fistula further. Again, these are simple techniques, but people are not aware that these things can be done.
We are sorry
and
to
the life
interrupt,
can
sir.
be
Please
salvaged.
kindly stick to your time.
Yeah, thank you. I'll just finishing it, sir. So to summarize, Pulmonology is much beyond pills and inhalers now. We can now offer minimally invasive procedures with diagnostic precision and very advanced and life-saving therapeutic interventions, and we can get faster diagnosis and early symptomatic relief in these patients. Thank you.
Thank you, Dr. Sushil, for a very nice and lucid presentation. Now, from the audience, if anyone, we can take few questions.
Request only 2 questions, please.
Yeah, they can raise your hands and just come forward. If no one, then it is there.
Check.
Kindly come forward so that we can all see you.
Just out of curiosity, what was the tumor that produced Trider in that High Court advocate?
Sorry?
What was the tumor, tracheal tumor?
That turned out to be, this was a adenocarcinoma. It turned out to be adenocarcinoma. We sometimes see mucoepidermoid tumors also there. So these are the common ones in the trachea, though not very common to that side, but we do see maybe 2-3 times in a year such large tracheal tumors in the airways.
Dr. Jain, are you doing pediatric bronchoscopy also?
Yeah.
Pediatric
Yes,
bronchoscopy?
pediatric, neonatal, everything.
Everything you are doing
Yes,
that?
we do it from, I've done, the smallest kid was 3 months old.
Okay, right.
So-
There's so many patients, they are coming with a recurrent URIs and you consider it's
I
like
do
you said, like a
pediatric,
bronchial
neonatal. I
asthma
have
or...
done from 3 months to 100 years.
Okay, that's
Can
great.
do it anywhere. We have all the tools for that.
Thank you. So, sir, thanks once again for a very nice presentation and hope it will benefit a lot of with your information. Thanks a lot.
you.
Thank you, sir. Now I request our chairpersons, Dr. Vivek Khare sir and Dr. R.K. Pathak sir, to kindly felicitate our speaker, Dr. Sushil Jain sir, with a shawl and a memento. Sir, please. Thank you, sir. Now I request Dr. Kalyan Sarkar sir to kindly present the mementos to our esteemed chairpersons, Dr. Vivek Khare sir and Dr. R.K. Pathak sir. Sir, please. Thank you, sir. Now, for the next session, I would like to invite Dr. Sai Lakshmi Daina, Consultant Gynecological Oncology, Apollo Hospitals, Hyderabad. The topic of her presentation is Prevention and Early Detection of Cancer in Children and Women. For chairing the session, I would like to invite Dr. Meenakshi Dev ma'am, ex-CMS ECCL, and Dr. Santosh Sharma ma'am, ex-CMS ECCL. Ma'am, please.
We would like all the speakers to kindly stick to their time. We have got the inauguration session at 12:20 noon and our esteemed CMD will be the guest of honor. So I would request all the speakers to kindly speak on time and stick to it.
A very good morning to all of you. It feels good to be here. Thank you for your hospitality. I hope you don't mind me saying you all look like very young, energetic bunch of medical students to me. I don't know, when I saw you all over the breakfast, it just reminded me of the college reunions I go to where everybody is so energetic, happy, feeling young and having a good time. So it feels like I've come back to a reunion rather than a conference. Well, that's me. I work in Apollo Cancer Institute's Hyderabad as a gynecologist, but mainly as a gyne-oncologist. Good morning, Madam Chairpersons and ladies and gentlemen.
If you would like to interrupt, me to interrupt you, I would like to give a short introduction.
Sure. Thank you, ma'am.
It's
Thanks.
a privilege for me to introduce Dr. Sai Lakshmi Dayana, MBBS, MD, MRCOG, MBBS, University of Health Sciences, Hyderabad, MD, University of Manchester, UK, MRCOG, RCOG, UK. She is RCOG approved subspecialty training in gynecological oncology, UK, former consultant gynecological oncologist, St. James University Hospital, Leeds, UK. She has expertise in open laparoscopic and robotic management of benign, precancerous and malignant gynecological conditions. She is going to enlighten us on the topic prevention and early detection of cancer in children and women.
Thank
Over
you,
to
ma'am.
you.
Thank you. Well, if I asked a question, I didn't praise you all simply for nothing. I'm going to ask a lot of questions. I want to stick to the 20-minute time, so we won't have time to take answers from you. But I do want you to think about the question and think about the answer too. Because we are all here to learn. And I left my number there because I promise if any of you ever want to ask anything related to gyne-oncology, you might refer the patient to me, you might not want to do that, you send the patient to Apollo, you don't, it doesn't matter. But when it comes to gyne-oncology and you have a question, please feel free anytime, any day to give me a call or WhatsApp me, and I genuinely mean it. Moving on to the talk. All of us are frightened of the word cancer. And if I may ask, what is the current statistic for cancer? 1 in how many people will be diagnosed with a cancer? This is from the statistics from USA. 1 in how many people in the world will be diagnosed with a cancer? The answer is 1 in 2.5. It used to be 1 in 3 before COVID, and now it is 1 in 2.5. So 2 out of 5 people will have a diagnosis of cancer. It is that common. But WHO clearly says that you see 50% of the cancers in unscreened or underscreened. So if we all, and all the patients who we are responsible for, get regular screening, then 50% of the cancers could be eliminated. So let's focus on that, and let's focus on the cancers we could prevent. 1 in 8 women in India will be diagnosed with either breast or cervical cancer. I'm sure you all understand that 1 in 8 cervical cancer means 12% of Indian women are being diagnosed with cervical cancer. And we could bring that down to, we could bring the cervical cancer incidence to what percent if we screened all Indian women? To 0. So that 12% could become 0. The 12% breast cancer might not become 0 anytime in the near future. We could pick it up early, but cervical cancer could be completely eliminated. And if so, why me, a gyne-oncologist in a city like Hyderabad, is seeing 5 or 6 advanced cervical cancer patients on a daily basis? So we need to do something, and we'll talk about what that something is. So cervical cancer, for those who have forgotten and who don't see women, obviously cervix is the bottom end of the uterus, and a cancer happening to the bottom end of the uterus is cervical cancer. 1 in 8 Indian women is diagnosed and dying with a cervical cancer. And if you then think about it, what's causing cervical cancer? It's a virus called human papilloma virus. So do other viruses cause cancers? Yes, they do, but smaller in number. We all know hepatitis B, hepatitis C causes liver cancer. That is why every newborn child is getting the 3 vaccinations soon after birth. Birth, month 1, month 2, they're getting the hepatitis B. How many parents know that when the child is receiving, when the newborn is getting a hepatitis B vaccine, it's to protect them from future liver cancer? We don't know that, still we do it. So it's time to move on to HPV cancer, and that is what I'm leading this talk to, that we know viruses cause cancer, we know vaccinating these children will stop them from getting the cancer, and we know HPV is one of the worst notorious cancer-causing viruses. And my next question to my audience, think in your mind, what cancers could HPV be causing? And I'm sure I'll leave you all shocked. You all are thinking cervix, because we are talking cervix, HPV, but there are other cancers which HPV causes, which are increasing in number dramatically, and we're going to talk about that too. How many of you have these kind of skin lesions on your palms, on your necks, on your feet? If you look at me closely, I have multiple HPV-associated lesions on my neck. I do, and I'm sure a lot of you people do. We get these HPV infections, most of these on the hands and on the feet, on the faces, when we go to dentists, when we go to dermatologists, when we walk barefoot in the temples, when we use towels in the swimming pool, when we use towels in the hotels, because skin abrasion, HPV, cutaneous virus, all of us have HPV on us. We are covered in HPV. It's under the epidermis. When there is a derm abrasion, a small abrasion to your skin, another person's HPV can enter your body. So it's so easy to get HPV. We all have these kind of cutaneous HPVs. But when the HPV enters the mouth, remember, many mothers ask me, can I kiss my child? Will that transmit HPV? No, it won't, because when you kiss your child, there is no derm abrasion. Derm abrasion means your epithelium needs to get injured. To get your epithelium injured, there needs to be some skin-to-skin rubbing, and that typically happens when people deep kiss or have sex or have fingering, etc. So HPV can cause mouth cancer due to oral sex or kissing. Of course, penis cancer we know is due to HPV. Our previous speaker so nicely described lung lesions. How many of you knew lung cancer is due to HPV? About 20% of lung cancers we are now seeing is due to HPV. When the HPV enters the mouth, then the larynx, and then goes into the bronchus. Some of the lung cancers happen in children when the child is going through a vaginal delivery through the mother's genital passages due to HPV. Of course, HPV causes laryngeal cancer, throat cancer, mouth cancer, and 100% of anal cancers are only due to HPV. There is only one cause for anal cancer, and that is HPV. I'm not talking rectal cancer, I'm talking anal cancer. So if you think about the burden of cancers due to HPV, it's shocking. Think about the number of mouth cancers, number of throat cancers, laryngeal cancers happening in women who never smoke, who never chew tobacco. Why are they getting it? Because people eventually fall into relationships and they get into physical intimacy, and this is what's doing the cancers. And look, I showed the previous picture and I said, how many of you have these kind of lesions? And I'm sure if you look at yourself with a magnifying lens, most of us do. But if I ask this question, how many of you think you have genital HPV? What percent of men and what percent of women? I don't know what number you would come up with. I don't know how many of you think you might have genital HPV or not, but Center for Disease Control says this is the number. About 50% of the men and 40% of the women have genital HPV, but you don't know about it, probably because you don't have symptoms and it is microscopic. So 50% of us have genital HPV, like it or not, and so we are at risk of genital cancers due to HPV. Can HPV be treated? There is no antiviral to treat HPV. Common culprits are these 20 types which cause cervical cancer. And every vaccine we have for HPV also covers 6 and 11, which are not cancer-causing type, but which cause warts. So sorry for the pictures if they or putting you off your breakfast, but these are genital warts on the penis and on the vulva, and only a person who has it knows how bothersome it can be and how recurrent these lesions are and how there is no cure. You can only keep treating them as and when they get it. And a problem like this completely ruins their confidence. They can't enter relationships, they can't enter a professional life, they just feel miserable. So, what makes, if 50% of us have high-risk HPV, if 50% of us have HPV on the genitals and 10% of those people will get the condition, will get the symptoms, what is it that makes these 10% get it? So that is what we as doctors need to think. You know, you can't eliminate HPV, you can't stop people from having relationships. So how do you stop these people from actually suffering due to HPV? So you need to understand what is it that makes them get these illnesses, get these lesions. 1, multiple sexual partners. 2, smoking. And 3, immunity, low immunity. And this is where I want you to focus on what causes low immunity. You know, you think hepatitis, HCV, HIV, renal transplant, being on immunosuppressants. As doctors, we think this is what lowers your immunity. But actually what lowers your immunity more than HIV or renal transplant is vitamin D deficiency, iron deficiency, zinc deficiency, magnesium deficiency. How many of us are deficient in zinc and magnesium? Do we know? Do we ever test ourselves? Do we supplement ourselves with seeds and nuts? Are we asking our patients to get these levels done? This is what is lowering the immunity. What % of Indian population has vitamin D deficiency? Can anyone, this one answer I will take. Can anyone tell me what % of Indian population is deficient in vitamin D? 97%. A study done in Delhi. And on top of it, say you have oral HPV due to kissing or whatever, and on top of it you chew tobacco or you have a tooth which is irritating your mucosa or the person smokes, then they are more likely to get. So the irritation of the part is also a reason. And how many years? This is interesting. Say you get HPV in your teenage, yeah? That is when we go around and start experimenting relationships. But the disease actually shows up 20 to 40 years later. That is the problem. This 70-year-old man with throat cancer won't remember what happened in his intermediate, yeah? So unfortunately, you do it now, and then it affects you many, many years later. And common causes of low immunity, you know, this is what is worrying us oncologists, because this is what our current Gen Z generation is going through. Our students don't sleep enough. They don't eat properly, they don't take rest, they are continuously stressed out. The parents are stressed, the students are stressed, the mothers are stressed, we are stressed, everybody is stressed, the whole world is stressed. So in this kind of stressful environment, how are we supposed to cope with all these minor infections we keep getting? How do we stop ourselves from getting cancer? And this is where we really need to focus as doctors on what we're going to advise our patients. And for those who are at risk, the dental appointments can pick up pre-cancer of the mouth. Cervix, there is a screening, a very well-established screening. In fact, in UK, for gay population, we used to do anal screening, knowing they are at risk of anal cancers due to HPV. But thankfully, now, we're all talking about the HPV vaccine. So don't even for once think, why is it necessary? Because every child of ours, we want them to marry and establish a family and lead a very happy life. People are going to be sexually active, and before they become sexually active, give them the HPV vaccine. These are the American brands. I'm terribly sorry. I'm only going to talk about 3 brands because only 3 brands are available in India. There are only 3 to remember. The 2 are American, Gardasil 4, Gardasil 9. And I want you to also realize that these 2 vaccines cover 6 and 11, which don't cause cancers, but which cause warts. So the first one is 3,550 and the second one is 11,000. This covers extra 7 viruses, which are high risk, which will also give a lot of protection from mouth, throat, laryngeal cancers, etc. And now we have the Indian vaccine. If you look at the composition of the Indian, it is ditto this. So Gardasil 4 and our Indian vaccine are ditto, ditto, ditto. The only difference is Gardasil 4 has been there for 19 years. Servovac has been there for 2 years. That's the only difference, but there's a difference in the price, 2,000 per dose versus 3,550 per dose. And this is the perfect age because this child, obviously they are not thinking about relationships. They don't have any genital or oral HPV yet. So we want these children to be vaccinated before they start thinking about relationships. And thankfully, India is now thinking, or actually started today actually, all the 14-year-old girls, before they hit their 15th birthday, they're going to get a vaccine. And surprisingly, if you think this is Indian vaccine, this is American vaccine, India is actually now decided to give free the Gardasil 4. Okay, basically because Gardasil 4 is ditto Servovac. That is 3,550, this is 2,000. So everybody is giving the 2,000 Indian vaccine. So they have a lot of Gardasil 4s in stock. So they said, fine, let's give it for free. Let's give it to Indian girls for free. Why not? Yeah, it works beautifully. So, but if you have a child and if you were to vaccinate, I suggest if you can afford, go for Gardasil 9. If you can't afford, your child is 14, let them get Gardasil 4. It could be your patients also, but what if someone is more than 14? The government is not going to give them. Then give them at least Servovac, at least one dose, which is for 2,000. So what about girls? They need it. What about boys? They need it. What about women? And what if you want a nonavalent? Go for it, pay for it, get the nonavalent Gardasil 9. One question your patients will ask, women will ask, I want to get vaccinated too. These are married women. Just remember that HPV vaccine will protect you from future infections. So if this married woman might acquire future infections through her husband or through another partner, yes, by all means, please give it to her. But if someone is in a very stable, mutually stable relationship, the vaccine might not and probably will not protect them from what they already acquired through their existing partner or partners. Okay, so a pap smear, a simple pap test. All lady doctors here, all gynecologists know how simple a pap smear is. A simple, straightforward, 1,200 rupee wala pap test will totally stop a cervical cancer from happening. 3 years before, it will tell you that this woman is going to get a cancer. I don't want anyone to raise their hands, but is there any woman in this hall who needs a pap smear once every 3 years and is not got it done yet, or is due for one and hasn't gone for a new one? I should have got mine done last year and I haven't yet got it done, and I'm here talking in a mic to you as if I'm somebody. It's just because I've been postponing, I'll get it done, but we ourselves ignore our health, and please don't do that. If you don't want a pap test, on the same sample, we can do a HPV test every 5 years. I've got 3 minutes and I will finish in 3 minutes because I haven't got much to say about breast cancer. Breast cancer is a commonest cancer in India at the moment. Breast is a very difficult organ for us because when a woman comes with a lump in the breast, it could be infection, it could be fibroadenoma, which is benign, it could be cyst due to fibroadenosis, it could be a cancer. How a doctor is supposed to just examine a breast and say this is a cancer and this is not? Then you ask for a mammogram and they say, hey, doctor, itni commercial ho gayi. You don't ask for a mammogram, then how do I know what I'm going to deal with? What if I make a mistake? So breast is a very difficult organ. 90% of the breast is fat, 10% is a milk apparatus. So many things go wrong in the fat, and that's why mistakes happen. But if you think, what are the causative factors of breast cancer? Family history comes right at the top. If a woman has a strong family history of breast cancer, please don't think too much about it. Send her for a test. Dense breasts, radiation exposure, a woman who had multiple CT scans, especially during COVID time, they are at risk. Weight is the biggest risk factor these days. Physical inactivity causes weight gain. Hormone therapy, women who have been infertile and had multiple IVF cycles, they are at risk. And lack of breastfeeding, because when a woman breastfeeds, her period stops for a while. The estrogen which a woman releases during a period is a culprit for breast cancer. So the less number of menstrual cycles, the less risk of breast cancer. Obesity not just causes breast cancer, but obesity causes so many other cancers, and most of the cancers obesity causes are centered in the abdomen. And patients are always frowning, not happy when you tell them you need to lose weight. But what happens is the truncal fat, the fat in the center of the abdomen, releases a hormone called estrone. Estrone chemically is similar to estradiol. And estradiol is a very useful hormone, while estrone is a very harmful hormone. They look alike, but estrone is a pre-cancer disposing. So weight is one of the risk factors why cancers are increasing. If I have to show you one slide today, I'll show you this. This is a woman who had a breast lump, which was very suspicious of a cancer when you touch it. Her mother had breast cancer, her sister had breast cancer. Her doctor said, I think this is a cancer, go for a mammogram. She went for a mammogram and she got a report that this is a fibroadenoma, which is a benign lump. And then she came to, the doctor was not satisfied. She said, this is not a fibroadenoma. Ye bahut hard hai, skin ko fixed hai, something is wrong. She sent her to Apollo. This is our mammo from Apollo. We called it a cancer, they called it a benign lump. What is the difference? The difference is we could pick up a speculated margin to the lesion, so our diagnosis was correct, this was a cancer. And let me tell you, an average mammogram machine in Hyderabad is 2,50,000. Our mammogram machine in Apollo Jubilee is 45 lakhs. Because we have an integrated MRI within the machine, the patient pays exactly the same amount of money, but we use a machine which is 20 times more expensive so we can pick up lesions. The other day we picked up a 1.8 millimeter cancer in a duct. Can you even see 1.8 millimeter, but we picked it up. We couldn't do a biopsy, but we removed the duct and it turned out to be a cancer. So if you're sending somebody, if you're going somewhere for health screening, choose your hospital wisely, choose the center wisely, even if it means you spend some money traveling. These are the different types of mammograms. I can't go through it now, but if any of you doctors, your wife or you want a mammogram and you want to know which of these is good for you, WhatsApp me and I'll tell you after taking a brief history about you, your periods and your family. Self-breast examination. I'm not going to touch much on PCOD because we are all burdened with PCOD, but just one bit to say that insulin resistance is the reason for obesity. Insulin resistance happens when you oversecrete insulin, and the processed food which is already semi-cooked and eaten by us from fast food centers, and sugars are digested so quickly that there is no time.
Like to end your talk.
Yes, sir. There is so much of extra insulin coming into your body that you become resistant to insulin. So you feel more hungry, you eat more, you become more fat, and this is a cycle. And we need to talk to our future generations about healthy lifestyles. And most of our packages in Apollo, we do a personalized package. We don't say 3,000 wala package, 5,000 wala package. We take your family history, personal history. We take a half-an-hour history from you to decide for that 3,500 what package we should do for you. And all ladies here know that that kind of money won't give you nothing much. And always donate health if you can. And these are my numbers. And like I said, feel free to get in touch anytime regarding gynae oncology. And thank you very much.
Thank you, madam.
We will not allow any questions now. Anybody, if have questions, can ask ma'am during the break. We are running short of time.
I request our chairpersons, Dr. Meenakshi Dev ma'am and Dr. Santosh Sharma ma'am, to kindly felicitate our speaker. Ma'am, please. I request Dr. Ashok Singh sir, CMO Gevra area, to kindly felicitate our chairpersons, Dr. Meenakshi Dev ma'am and Dr. Santosh Sharma ma'am. Sir, please. Thank you, sir. Thank you, ma'am.
Although we are moving towards artificial intelligence, but data transfer also takes sometimes times. So this 5-minute glitch is due to that. Next speaker we have, because I am also a physician and my organizing chairman is also physician. So we are really delighted to invite our honorable API president. He is leading 20,000 physician friend from, he has already arrived at our venue.
As Dr. Jain sir has already given the introduction, now I would like to invite Dr. Jyotirmay Pal sir, President API, to kindly present his topic on timeline of antibiotic discovery, resistance and future prospect. For the same session, I would like to invite Dr. Surendranath Saha, CMS ECL, and Dr. Kumudini JBR ma'am, CMS and Area Medical Officer Korba area, to kindly come on the dais to chair the session. Ma'am, please. Sir, please.
Before we proceed, please let us introduce Dr. Jyotirmay Pal.
Respected Professor Dr. Jyotirmay Pal, sir. He has galaxies of degrees and awards. So it's my privilege to introduce him in front of all gems here. Sir is Professor Medicine, College of Medicine and Sagor Datta Medical College, Kolkata. He is awarded with MD degree and FRCS London, FRCS Glasgow, FICP, FACP and WHO Fellow. He is immediate past President, Association of Physicians of India. He is past Dean, Indian College of Physicians. He is Chairman of Public Health and Benevolent Committee and International Affairs, API. He is Scientific Chairman and Organizing Secretary, EPICON 2025. He is ex-secretary and editor, Journal of Indian Medical Association. He is Joint Finance Secretary, IMA Headquarter at Kolkata. And he is council member, West Bengal University of Health Sciences. His publications are more than 120 in national and international index journal. And he is editor-in-chief, Medicine Update 2025, Progress in Medicine 2024, Clinical Compendium and McMaster Book of Internal Medicine, essay editions, Tropical Fever, Dengue, Standard Medical Practice, Mucormycosis and Clinical Methods in Respiratory Medicine. All medicines included in Dr. Professor Jyotirmay Pal, sir. Your time starts, sir. Thank you.
Thank you, madam, for your kind introduction. And I am obliged to the organizer for invite me. From morning, there is a beautiful deliberation on the mitral valve repair, then the bronchoscopy and prevention of malignancy. I have chosen this topic because for the greater awareness of our doctors' medical fraternity, because we, mankind, is at crisis. The issue is how we can save the mankind. If you see the infectious disease, so now during the independence, 2/3 of the death was due to the infectious disease, 1/3 is a non-infectious disease. But now 2000 is a reverse, 2/3 due to the non-communicable disease, 1/3 due to the infectious disease. But the scenario has something changed. Because of the pandemic, now we are at the crisis. If you see the entire world, there is a on and off. There is a emergence of the newer zoonotic diseases, epidemic, pandemic, endemic, and there is a lot of antibiotic resistance and no research on this. Though if you look after the infectious disease history, that has changed the human history. This is changed the human history of political, social, and from economic point of views. The Justinian plague, that was the main reason of the fall of Roman Empire and beginning of the Dark Age of Europe. And Europe, basically, the plague was responsible for not only the beginning of the Dark Age in Europe, also for the Renaissance. Because when 12th century, due to the plague, lot of people died. People has a faith on the church will save us. Then the Europe realized that only on depending on the religious rituals, you cannot save yourself. So you have to go in a different way, more a scientific way to combat the infectious. So Alexander the Great, he came from Greece to India, and after the victory, he was going back to the Greece. On the way in Babylon, he died. Probably he suffered from tropical fever. Such a great warrior also succumbed to death due to the infectious diseases. But in the past, when there is no antibiotic, no vaccine, basically the mankind depend on the technique that is called isolation and quarantine. The pre-independent India, there is hardly any medical facilities. Only 10% of the people was under medical cover. Whatever the British government has done, establishment of the new medical college, some research lab, whatever they have done, basically to save their people. And their basic motto was the Indian organism, Indian epidemic, endemic should not spread to their country. So people mostly was dependent on the religious rituals, Olai Chandi for the cholera, Ma Shitola for the smallpox, and so on so. First structured where against the infectious disease started with the effort of Louis Pasteur, Robert Koch. They proposed the concept of the germ theory. What is germ theory? The disease is basically the interaction between the pathogen and the host. Either host will die or there will be survival. Those who will survival, they will acquire the immunity. So based on this germ theory, subsequently the vaccine and antibiotics developed. The concept of antibiotic, the antibiosis was first proposed by Louis Pasteur, but concept of antibiotic, it was first described by the Waxman. That is why he is considered the father of antibiotics. He has written in his text, the antibiotic is a compound made by a microbe to destroy other microbes. So we have to understand what is antibiotic and what is antibiotic resistance. Basically in nature, antibiotic and antibiotic resistance basically based on the Darwin's three principles: struggle for existence, survival of the fittest, and natural selection. How? See, this is the picture. The 400 million years ago, first came the, not the vertebrate, came the plants and the microbes. So these are the soil-based microbes. The soil-based microbes, 400 million ago, their natural tendency was to localize near the roots of the plants because they will get the nutrient. So these microbes used to release some natural products, some of the proteins. What is the action of the natural products? Either they will attract their close relatives or they will destroy their opponent. So that these microorganisms, soil-based actinomyces organism, they will thrive on the nutrient from the roots of the plant. So that means some of the organisms releasing some natural product to attract these relatives or destroy their opponents. So there is a struggle for existence. These natural products is basically the today's antibiotic. So what the other organism do? They will also release some product to prevent this natural product release from his opponent organism. So this counter force is basically antibiotic resistance. That means antibiotic and antibiotic resistance is basically a natural phenomena. It's present in the earth from 400 million years ago. So based on this principle, the antibiotic evolved and antibiotic resistance also evolved. Let us see the history. 2000 years back, when there is no structured antibiotic available in the world, that time different countries, particularly Serbia and China, their literature we got, they used to use the moldy bread to treat the infection. In the Egypt literature also we have seen they use the soil to treat the infectious disease, because from the previous picture, deliberation, I have shown that the soil actinomyces, they release some natural products to destroy the other organism, their opponent organism. From that very concept, Egypt used to use the soil to treat the different infections. And antibiosis, the concept that some of the organism release some of the products that destroy the other organism, this concept was first proposed by the Louis Pasteur, even much before the discovery of the penicillin. So we know traditionally everybody, we believe the penicillin is the first antibiotic that was discovered, but it is not so. It is the Paul Ehrlich, he discovered the product that is called arsenic-based compound sulfasan 100 years back from today. That was against used the Triponoma pallidum. That is the first antibiotic that was discovered in 1910, followed by the discovery of the sulfonamide, another broad spectrum antibiotic. Penicillin came later on. In 1920, Alexander Fleming, he discovered the penicillin, and this penicillin was Norman Hatley. They purified the penicillin to use as a drug in 1940. So penicillin came into the market usually after 1940, and she basically discovered the beta-lactam nature of penicillin. So when the beta-lactam nature of penicillin was discovered, it was the breakthrough for the development of semi-synthetic derivative, because after that, when the beta-lactam nature was discovered, the chemist, they developed the antibiotic and it was produced by the pharmaceutical for the marketing. Waxman is considered the father of microbiology because he first started the systemic study on the microbes and how they generate the natural products that can be used as antibiotic. And basically soil-based streptomyces or actinomyces, he discovered they produce some natural products that is not required for the growth reproduction of that particular organism, but required for destroy the other organism. On that basis, he discovered streptomycin and neomycin, and after his discovery of the neomycin, basically the golden era of antibiotics started. So in the golden era of antibiotic, it persists from 1944 to 1960, almost near about the 20 years. And these 20 years, so many antibiotic was discovered in the world, and the humanity got a big boon to combat against the different organism and infectious diseases. So in the golden era, in this 1940 to 60, in that era, scientists, they have isolated natural product from particularly more from soil-based organism, and these natural products where chemical structure was identified, and based on this chemical structure, the semi-synthetic products was made by the chemist, and this semi-synthetic product were produced by the pharmaceutical and marketed as an antibiotic. So 1940 to 60, we see series of good antibiotics that came into the market. So mostly came from actinomyces, came from other bacteria, fungus, and some was the synthetic derivative, but mostly was the semi-synthetic derivative. But the situation worsened in 1970. So around 20 years, the golden era, so many antibiotics explode from the soil-based actinomyces. Their natural products were identified. But 1970, pharmaceutical research wing shown that almost all of the natural products were identified and explored. They are not getting any new natural product based on which they can make the new antibiotics. So what happens, some of the pharmaceutical big giants, Glaxo, AstraZeneca, they started research on the entirely synthetic derivative. Glaxo almost 5 lakhs compounded. They done the clinical study and clinical research, almost 5 lakhs new synthetic derivative. But nobody was successful to act as an antibiotic. AstraZeneca also conducted 45 studies, but without result. So in the end of the 70s, what the research and development division of the pharmaceutical scene, there is no natural product from the organisms, and synthetic planning, synthetic derivative also not working well. So most of the pharmaceutical, they closed their antibiotic development wing. So in 1980 onward, we see in the next 40 years, we see 40 to 45 years, we see only 4 new antibiotics only came into the market. This is the very scenario that OD does, because now we have no new antibiotic in the research pipeline. Only you are using the older antibiotics that was discovered before 1960, or there are some modifications, some derivatives. So regarding now coming to the antibiotic resistance, another challenge in this way. And in the beginning I told antibiotic and antibiotic resistance, both are the natural phenomena. One organism releases the natural product, that is antibiotic. Another organism releases something that is act as an antibiotic resistance. That is the anti of natural products. That means antibiotic and antibiotic resistance both coexist in the environment. So that is why Alexander Fleming in 1944, when he got the Nobel Prize, in his speech, he warned the world community about the presence of penicillin resistance. He told, if we do not use the penicillin in proper way, there is a penicillin resistance in the world. So very quickly, penicillin will lose its effectiveness, and that has happened. So this is the timeline. The antibiotic and antibiotic resistance gradually has developed in the world. The same way, when the antibiotic is developed, see, when the first drug L-Rich has developed, immediately antibiotic resistance of that drug developed. So antibiotic and antibiotic resistance simultaneously developed in the world community and threatened the mankind for their survival. In 2024 data in WHO, he has mentioned that 1 out of 3 infection in India is resistance to common antibiotic. And there are 7 lakhs deaths worldwide only due to the antibiotic resistance. So ICMR expert panels, they warn that antibiotic pipeline is running dangerously dry. So every physician have to be very aware about the antibiotic resistance and use of the antibiotic. Our Prime Minister, Honorable Minister Narendra Modi, in his Mann Ki Baat, very correctly he warned people against the misuse of the antibiotic and raised the concern about the rising level of resistance in our country. So what are the causes of antibiotic resistance and challenges? It is the overuse of antibiotic, improper dosing, more use in the agriculture field and also poultry and animals, no new class of antibiotic discovery, and least pharmaceutical interest on antibiotic research. These are the challenge. So in 20th century, late 20th century, what challenge we have? Fewer new antibiotics are discovered. In last 45 years, only 4. Resistance increasing alarmingly. Pharmaceutical focus has shifted from non-communicable to non-communicable disease. They more focus on the obesity rather than antibiotic discovery. So it is a global public health concern. That is why 2015 WHO declared that AMR is a new global emergency. So what is the future prospect? Where we are, what we can do? One aspect is preservation of the antibiotic. Whatever we have to preserve. We have to prevent the misuse and proper use by doing the repeated workshop, CME, seminar of the doctors. Cautious agriculture use. This is not in your hand, it is the government's hand. But government, our physicians community has a responsibility to warn the government about the proper agriculture and poultry and increase awareness among the common population also, because on and off they take the antibiotics, azithromycin and others on and off from the medicine shops. And definitely needs the awareness of the research, and government, non-government agency should invest more for the research and do the investment. So future research, in which direction should go, in which direction it is going. Discovery from what I told, natural product from the soil-based organism. It is almost ended. We are not getting any new natural products based on which we can decode and make the semi-synthetic derivative. So synthetic antibiotic research also failed by big 2 organization, AstraZeneca and Glaxo. So our duty, we have to discover the new organism that can have a new structure of the natural product. This is to be identified. And there are many environment, whatever we have identified from the soil, this is a soil-based actinomyces, but there are many environment which is not explored. That from that environment, we have to identify the organism and their natural product. Because from the natural product only, antibiotic structure can be identified. So this is our task, this is the focus of the future research. How it is possible? Just next 2 minutes, I will describe how from the new environment we can get. Every organism, there is a gene. From the gene, particular gene, they produce a natural product. Natural product is basically precursor of the antibiotic. But 2/3 of their gene is not exposed. They are basically remain in the switched off mode. So from the 1/3 of the gene, the natural products the organism produce, and we have identified. But 2/3 of the gene till now in the switched off mode. That means we have not explored, we have not identified. But in a suitable environment, this switched off genes can produce new natural product which is not known to me. And these new products can give a clue for the future antibiotics. So we have to stimulate the organism so that from the switched off gene, they can produce the new natural products based on which we can produce the semi-synthetic derivative of the natural product that is basically antibiotics. So we have to search for the new environment from where we can get some new natural products. From what are the environment? One is the marine environment. Marine sponge is a very rich source of noble NPs. Marine sponge already harbors so many organisms, and marine sponge till now not much discovered. So that is why in the world the big giants always fighting to get the control over the seas. That is one of the reasons. Second is the human microbiota. Nowadays, there's a lot of discussion on human microbiota because their human microbiota contain lot of organisms. They release the natural product that can act as an antibiotic. Third is the both pole of the world. The North Pole and South Pole, these are the unexplored area and they are very rich in biodiversity. What the Putin and Trump is fighting to get a control over Greenland, it is not for the land. The land is covered with the ice, practically no value. Basically, they are fighting to get the control of their rich biodiversity. Because if they can control over the rich biodiversity, they can identify so many organisms, their natural product, based on which they can produce the future antibiotics and dominate the economic world for next 100 to 200 years. That is the reason why the big giants are now fighting to get control over the seas, to control over the North Pole and South Pole. So we have to identify the new environment to get the new organism and their natural product so that we can combat the infection and can produce the new antibiotics. So current scenario, 45, that's 2 minutes, 45 newer antibiotics under trial in USA in next 25 years, but 28 belong to the known NP classes. Only seven clinical research on the new antibiotics. So 2 new classes are only in the world at present on phase 3 clinical trial. And 4 drugs among the 7, 2 in the clinical phase 3 trial, 4 in the phase 2 trial, 1 in the phase 1 trial. So this is the hopeless scenario of the world when the big US, Europe, though have a lot of funds, they are major pharmaceutical company, still they only 7 drugs are in clinical research. So our future is at stake. So large pharma, actually they have shifted their role to search new antibiotics. Most trials are conducted by the academic lab, government agencies and medium-sized pharma. So in conclusion, antibiotic resistance is a new pandemic of the century. First and foremost duty is the increased awareness and recognition of the problem. Both government and non-government agencies and individuals have to be aware. First duty is to preserve the older drugs. Then, and suitable antibiotic policy is a must for each organization, for each country, and investment in research is needed for the survival of the mankind. Let us identify the Achilles heel of the microbes and hit hard and save the mankind. Thank you.
We will not allow any questions that can be taken with sir during the break. We are running short of time.
Thank you.
Thank you,
The
Dr.
inauguration of the conference is scheduled at 12:20 p.m. and our chief guest, our esteemed CMD of SECL, is going to inaugurate our conference CIMECON 2026. So I'll request everybody to please hurry up.
Thank you, Dr. Pal, for such a nice deliberation.
Thank you,
and
sir.
Doing justice with such a great subject within the time. Thank you again, sir.
Thank you, sir. Thank you, ma'am. Now I request our esteemed chairpersons to kindly felicitate our speaker, Dr. Jyotirmoy Pal, sir, with a shawl and a memento. Sir, please, ma'am, please. Now I request Dr. VL Dhan ma'am, CMS and Area Medical Officer, Gevra area, to kindly felicitate our chairpersons. Ma'am, please. Thank you, sir. Thank you, ma'am. As we are running short of time, we have rescheduled few sessions. And for the next session, I would like to invite Lieutenant General Dr. Ashok Jindal, sir, Executive Director and CEO, AIMS Raipur, for his talk. And the topic of his presentation is Protection and Empowerment, Occupational Health and Safety. Sir, please. To chair the session, I would like to invite Dr. Shom Shubhra Gupta, sir, HOD Medical Services, CIL, and Dr. A.M. Ganjre, sir, ex-CMS ACCL. Sir, please.
इससे होगा ना स्लाइड नेक्स्ट स्लाइड इससे हो जाएगा
Hello. Thank you, organizing committee, for giving opportunity to us to chair this session. I welcome Dr. Ashok Jindal. He will be speaking the present and protection and empowerment concerned with occupational health and safety. Of course, this is the most important topic for SECL coal miners, because the health and safety is the most important part in the coal mines, and we do many preventive measures as well as curative measures. So, for introduction, I think
I am privileged to welcome Lieutenant General Ashok Jindal, who is a Ati Vishesh Seva Medal and Param Vishesh Seva Medal awardee. He is a Youth Seva Medal winner. He has passed his MBBS and MD from AFMC Pune and PhD from JNU. Nearly 40 years of service in Indian Medical Corps. First doctor awarded as Yuddha Seva Medal in Siachen Glacier or in nearby areas fighting. As I said, he is a recipient of Param Vishesh Seva Medal and Ati Vishesh Seva Medals. These are the highest and the second highest gallantry medals during peacetime. He has 50 plus publications and WHO fellowship on epidemiology. Former director and commandant of Army Hospital, Delhi. Presently, he is working as executive director and CEO, AIMS Raipur. Thank you, sir.
Very good morning, ladies and gentlemen. Thank you, Chairperson, sir, for this introduction. I bring to you compliments from the Apex Institute of Chhattisgarh, that is AIMS Raipur. I would be talking to you on an issue which I thought would be of relevance in a forum of where occupational health is very important. And I'll be taking you through a journey of protection and empowerment, occupational health and safety. Most of the issues you're all aware of. I'll be just going through that. You are already aware of this infamous rat hole coal mine explosion in Meghalaya, which happened just last month, and a fatal illegal rat hole coal mine explosion took place, and which 30 unfortunate workers died, and they were trapped in similar circumstances long ago. So regardless of occupational health legislation in India, we continue to have accidents, especially in illegal coal mines. You are also aware of the Silkaira tunnel section collapse, in which in 2023, 41 workers were trapped. And ironically, we had to use the workers who were rat mine explorers to actually extricate these people out of this after a very successful rescue of 41 workers after 17 days. And they were then transported by the Indian Air Force Chinook helicopters to AIMS Rishikesh. And this operation Silkaira has become the longest rescue operation in the country. Fortunately, everybody's life could be saved. Now coming to the industrial injuries, if you see, they take part, they contribute to almost 17% of the total deaths, total non-fatal injuries of the world, and 45% of the world's total deaths. And as far as occupational diseases are concerned, almost 17% of the total births and 17% of the deaths of the total world are due to occupational disease and injuries. So mind you, we may talk about infectious diseases, we may talk about others, but occupational diseases and health still remain very relevant today as far as the statistics are concerned. Now coming to what exactly is occupational health, the father of occupational health, as you're all aware, is a gentleman, Bernardo Ramazzini, who said that while you take a history, you must add one more question: what occupation does he follow? And this has been seen very commonly when common cases of silicosis or asbestosis are sometimes diagnosed as tuberculosis, because nobody took a history that the person worked in a mine or worked in a textile industry. And if you see the timelines that have been evolved as far as occupational health is concerned, we moved a long time since 1855, when we had the Fatal Accidents Act, when the employee's fault had to be proved. So this actually never took off, and later we have the Workmen Compensation Act, followed by the Trade Union Act, the Payment of Wages Act, and then came the World War, which led to the War Injuries Compensation Insurance Act. Then of course the Industrial Disputes Act came in 1947, followed by the two very important legislations which we are all aware of, the Employee State Insurance Act and the Factories Act and the Minimum Wages Act. Later, as you are all aware, in 1952, when the mines and most of them got nationalized later, came the famous Mines Act, which I think all of you are governed with, and of course the Employees Provident Fund Act, which provided social security. To take care of women and give them their benefits, especially when they are pregnant, came the Maternity Benefit Act. Then of course some acts to regulate contract labor, Equal Remuneration Act, and ironically the first one to follow it was the BCCI. Now your women cricketers and male cricketers get the same allowances for going everywhere else. Others have still to replicate it. Of course, we wanted our childhoods protected, so came the Child and Adolescent Labor Act. And of course, manual scavenging is something which was not to be very proud of. And so India prohibited that way back in 1900. Then came the Unorganized Workers Social Security Act, which tends to cover the gig workers, the Zomato people and all. And then came, so that women are protected in the workforce, came the very important POSH Act. So now you all have your ICC committees so that women are not, looked down upon or harassed at the workplace. Code of Wages. And now, of course, in 2020, all the codification took place, and as last year itself, all the 4 labor codes became effective from 21st November 25. So now there is a codification for all. Historically, if you see the Great Depression, earlier the workers were never looked after. In fact, when we say the 2-penny hangover, it was essentially that at night laborers used to pay to rest across a rope. And they had to pay 2 pennies to just rest at night. So that was the way when labor was looked down upon earlier. Then came the Mines Act. And of course, the evolution, the Mines Act over the period of time has evolved. You have the DGMS forming, the OSH code, and today you have plenty of protection under the Mines Act. Nonetheless, I think the Mines Act gave a fillip after the Chasnala mining disaster in Dhanbad, which later became a movie, Kala Patthar, which actually showed us that how our workers in mines could be prone when we don't take the necessary precautions. Coming to a very important legislation is the Factories Act of 1948, which actually revolutionized the legislation in India. This started in 1854, and the significant changes actually took place in the Factories Act in 1948. And the Factories Act actually gave 4 benefits: ensuring worker safety, regulating working hours, improve health and welfare standards, and control hazardous processes. But then we needed a huge tragedy to overhaul the Mines Act. When in 1984, the Bhopal gas tragedy actually told us that we could do nothing to Warren Anderson, who was actually having Union Carbide, because our legislation allowed him to actually get off scot-free. And it is actually very unfortunate that today people are still suffering the effects of the Bhopal gas tragedy. And you can see the catastrophe that took place and how this remained the largest industrial accident in India. And it actually unfortunately depicted the poor value of human life, and liability said that if this accident had taken place in their West Virginia plant, they would have compensated almost $10 billion and the Union Carbide would have been liquidated. But then it did not happen that way, and the company still operates under the ownership of Dow Chemicals. And ironically, the website of Dow Chemicals still states that the Bhopal disaster was caused by deliberate sabotage. I mean, still the lie exists. And of course, the movie was made on Netflix on Bhopal gas tragedy, which we have all seen. And you can see the difference as to why we had to overhaul our legislation. Because in the Bhopal plant, there was hardly anything that they did. And in West Virginia plant, everything was right. Right from the emergency evacuation plant to the jurisdiction, everything. And despite a warning in 1982 that the Bhopal plant had higher potential for a serious accident or more serious consequences once an accident should occur, nothing happened. Of course, post-Bhopal gas tragedy, we can say we bolted the door after the horse had bolted. There were sweeping changes. There was this definition of hazardous process. We had industrial hygiene labs, factory inspectorate. Occupier was held responsible to ensure safety. So now the occupier cannot give it away to somebody, a local manager. Now the occupier is equally responsible. You had the certifying surgeons coming in who are qualified in industrial health, and there were on-site medical facilities. Another important legislation which is slated as the largest social security legislation in South Asia is the Employee State Insurance Act. And this act has evolved over a time, and basically credit should go to the BP Adarkar committee at the time of independence, which removed the anomalies in the Workmen Compensation Act and enacted it in 1948. And we all know, we've been taught in medical schools the benefits of this act. This act is doing fairly well. However, I had done a study, my PhD thesis was on the Employees State Insurance Act, and there we found that it had a very rigid and mathematical composition model for compensation of injuries. And you will be horrified that in a place like Faridabad, only one worker got compensated for occupational disease in 5 years. And despite having an occupational health element, most cases of bisonosis were labeled as tuberculosis, hence not given compensation. And focus is more on medical care and less on occupational health, which is what happens when you combine an occupational health scheme with the normal health scheme. You know, the glamour goes to the medical scheme and the occupational health element gets sidewise and appeals on the workers in the court of law. So finally, these were some of the suggestions that we made, that the doctors in ESI should focus on correct diagnosis of occupational health. I'm sure you are doing it in SECL. And there should be accidents while commuting should be treated as employment injury, which has been done. And the temporary disabled benefit should be given as full wages. And these are some of the measures. Now coming to the labor codes, which have made all these occupational health legislation under one roof. And it's actually a bouquet wherein working conditions, equality and empowerment of women, equality, social security, labor welfare, employment and training are under one roof. Now coming to what is the latest are our labor codes. A lot has come in the press about the labor codes. There has been some opposition from the union leaders. They are saying it's a sellout. It is a way of reducing labor rights. Well, the judgment is still not out, and these debates will continue in a democracy like ours. Nonetheless, these labor codes have a legislative reform to simplify and streamline the complex structure of Indian labor laws. Earlier, we had a plethora of laws. In fact, nobody knew which law we have. India is a country which had great laws. Now, fortunately, the BNS has come in. Now, this codification was very necessary. And now we have only 4 comprehensive labor codes, and they have become effective from 21st November 2025. And the goal, obviously, is employee welfare, industrial productivity, and global label standard compliances. So now all the problems which were there in the earlier fragmented system, as you can see, have been formalized, and today the labor laws are more robust, I feel. They are more both industry friendly and labor friendly. Of course, debates will continue, but that's my view of the labor laws. And now we have all these, the Industrial Relation Code, the Code on Wages, the Code on Social Security, and Occupational Safety, Health and Working Conditions Code in one free. And now they have been implemented, and you can see that once the labor codes have come, earlier no mandatory appointment letters were issued, now mandatory appointment letters are there to workers. So there are written proofs of transparency. All workers, including your Zomato workers, will get social security coverage. They'll get PF, ESIS insurance, which is very, very important because, if somebody dies or somebody gets injured, the family is on the road. So all receive a minimum wage and timely payment, and employers must provide all workers above the age of 40 years with a free annual checkup and promote timely preventive health care. In fact, after the codes came in, even in AIMS, we have a huge source of outsourcing workers. Our security is outsourced. A lot of our housekeeping, etc. is outsourced because that's a model. Now we are ensuring that with all the post-labor codes are followed, and if we don't, then obviously the labor inspector can be at our head. Similarly, timely wages, women workforce participation, ESI, now we have a single registration, pan-India, single license and single return. Now coming to a service which is very close to my heart, where I spent 40 years of my life, I'll be just briefly, I know there's a shortage of time, I'll be briefly running around the occupational services and the specialized services like the army. The armed forces today is engaged in some of the very extreme terrains like the world's highest battlefield in Siachen. So we have taken care of our men by looking at the effects of high altitude, effects of extreme cold climate and acclimatization schedule. In fact, our acclimatization schedule is used by mountaineers and armies across the world, because when we acclimatize at each heights, we ensure that the soldier does not get high altitude pulmonary edema or is prevented from the effects of cold. So this is something which all armies across the world are emulating, and this has been developed primarily by the Indian Army Medical Services. We do a pre-induction medical examination which consists of all that, and soldiers who do not qualify these criteria are not sent to Siachen Glacier, where heights touch almost 22,000 feet. These are some of the pictures when I was there as a youngster, and you can see that, our doctors operate in very, very weird conditions. For example, this is my photograph of 1987 at -40, and this is my polyclinic, under tons and tons of snow with just a CGS sheet where patients were evacuated, and here are the Pakistani enemy cells. So our doctors operate in very, very difficult conditions. And mind you, this polyclinic is not NABH accredited, because no assessor will ever land up there. And this is, of course, my photographs, old days. Yeah, my wife says I was very smart at that point of time. This is the world's highest military post, Bana Top in the background, which is at a height of 22,500 feet. It is so bad that no soldier can stay there for more than 15 days. That's the maximum tenure, because temperatures get down to -72 degrees Celsius. And of course, we are also looking at the Air Force and the civil aviation. We talk of simulators in medicine today, the origin of simulators actually was from the Air Force. Because when you're flying those supersonic jets, Sukhois and Rafales and what have you, the pilot is actually evaluated in the Institute of Aerospace Medicine at Bangalore, which has aerospace specialists, and the effects of G, etc. are taken, because we don't want to lose, so conditions get simulated on ground, so that we know that the man is psychologically suited, physically suited to handle that aircraft at those heights, because aircrafts cost a whopping amount of money. And of course, we don't want to lose a life either. So we do a lot of preventive checks, and even for the Gaganyaan mission, if you see, Subhanshu Shaks was evaluated by doctors at the Institute of Aerospace Medicine before he went into space. And even for your, the trust is so much in the Air Force medical doctors that the annual medical examination of civil pilots, whether it's Indigo or Air India, are done by a medical committee from the Indian Air Force. And similarly for Navy and merchant ships, commercial diving, we have unique medical challenges of decompression sickness, barotrauma, gas toxicity, and we have some doctors who have qualified in the Indian Navy in marine medicine, so they look after people in submarines and ships, and they have these practical issues to handle. Of course, now Indian Navy is rescuing seafarers from modern day pirates. Now coming to our own medical field, I think at times we neglect our own occupational health. This is a slide which shows that, you know, we are one of the most sickest communities, the most sickest occupation, the most unhealthy occupation that we follow. And we kind of keep on advising people to do the right things, but unfortunately, none of the things that we do should be done the way we advise others. So it's like, you know, giving sermons and talks. And my own place, I find my residents work 12 hours, 14 hours a day. Kya kare? When your OPD is 4,000, 4,500 coming in. I mean, I admire my JRs and my SRs for the kind of outputs that they give in aims to deliver quality healthcare. But this is a problem with doctors, and things are going to be worse, you know, because this is not the way medicine is going to go forward. If you're going to increase the range of, we will actually reach very new heights very soon. So I don't know if this is the right solution. I leave it open to you to debate. And also, you know, I retired 2 years back, and this was my send-off. And pensioners have their own problems of occupational health. This is one of them which really worries me after I retired. So surprisingly, the courts also say that if your retired guy is murdered, his wife still gets the pension. I don't know on what basis the court found this judgment. So I get worried when I sleep at home. And that's why I've come alone to this conference. And sometimes you wonder if this is the solution to such things. Anyway, to conclude, ladies and gentlemen, evolution of labor laws for betterment of working conditions is as per political and social environment. Social security is improved with trade union demand. We have excellent schemes for empowerment. And generally, it has been seen that the judiciary has always taken a benevolent stand for the welfare of workers. And we need to look at all these issues. I'm running short of time. I'll just tell you the grit of an armed forces. She is the wife of a nursing assistant whom we lost in Galwan. And if you're seeing the movie which is coming up, he'll be shown there. And see the grit of this young housewife. Her husband died in the Galwan Valley, a nursing assistant. And after 1 year, she joined the armed forces as a lieutenant. So that's the kind of grit and determination that our ladies have in the armed forces, that they don't give up, they join the same service, and I salute this lady. And I leave you with images of our convocation ceremony last year when the President of India came and honored us by her gracious presence. And this is what she wrote in her book, that she's happy to have attended my convocation ceremony, and in a short span of time, our institute has made impressive strides, and she's wished us a bright future. For those of you who would like to visit AIIMS and have a look at our facilities, you're most welcome anytime. Thank you very much, ladies and gentlemen.
Thank you, Dr. Ashok Jindal. We are proud to have you with us, a man who worked at such a height for protection of our country, and of course not having NABH standards there. It was a very good talk, and in fact our coal industry needs services to protect our workers and promote workers' health. And you have explained it.
There's an important
very nicely.
announcement. We will like to conclude this session here, and we are extremely sorry
Jindal.
for changing the schedule.
Thank you, Dr. Jindal. If there are any questions, you may ask during the lunch time, because we have short of time here.
Thank you, sir. Now I request our esteemed chairpersons, Dr. Shom Shubhra Gupta, sir, and Dr. M. Ganjre, sir, to kindly felicitate our today's speaker, Lieutenant General Dr. Ashok Jindal, sir. Sir, please. Now I request Dr. Ashok Biraji, sir, Area Medical Officer, Chirmiri area, to kindly felicitate our esteemed chairpersons, Dr. Ganjre, sir, and Dr. Shom Shubhra Gupta, sir. Sir, please. Thank you, sir. Thank you, sir. Now we'll be having a short tea break of 10 minutes as we'll be rearranging the stage area for our inaugural function. Everyone is requested to kindly be present and kindly be seated here by 12:10 because we'll be starting with our inaugural functions by 12:15, 12:20. Thank you.
A small announcement. Participants and dignitaries who are sitting in the front row of sofa, they are requested to kindly shift to the second one. Our inauguration will be starting very soon. Participants and delegates who are sitting in the front row of sofas are requested to sit in the second one. Inconvenience caused is regretted. सभी से निवेदन है अपना अपना स्थान ग्रहण कर ले। हमारे आज के कार्यक्रम के मुख्य अतिथि माननीय श्री B.K. त्रिपाठी सर, CVO CIL, साथ ही साथ गेस्ट ऑफ ऑनर हमारे SECL के CMD श्री हरीश दुहन सर और उनके साथ हमारे निदेशक मंडल के सदस्य सभी उपस्थित हो रहे हैं। आप सभी से निवेदन है, कृपया टी ब्रेक खत्म हो चुका है, आके तुरंत अपना अपना स्थान ले लें। I would like to request dignitaries to leave the front row vacant. I would like to request all the dignitaries to keep the front row vacant. All the participants are requested to kindly take their seats. All the participants are once again requested to kindly take their seats. Volunteers are requested to request the guests and dignitaries to sit, please. Our chief guest for the event has arrived. You all are requested to kindly take their seats, please. All the participants are requested to keep their mobile phone on silent or switch off mode. The participants taking their tea are requested to kindly come forward and sit in their seats so that we can proceed with the inaugural session. All the participants are once again requested to kindly take their seats for inaugural session. Our chief guest of the event has arrived. Please leave the front row vacant. We welcome our CMD SECL, Shri Harish Duhan sir. Our Director HR, Shri Birenchi Das sir. Our Director Finance, Kumar sir. All the participants are once again requested to kindly take their seats. We welcome our CMD SECL, Shri Harish Duhan sir. Director HR SECL, Shri Birenchi Das sir. Director Finance, Shri Dalla Sunil Kumar sir. And our guest, Shri B.K. Tripathi sir, CVO CIL will be arriving shortly. And Shri Ramesh Chandra Mohapatra sir, Director Technical, PNP, will be arriving shortly. welcome Shri B.K. Tripathi, sir, CVO, CIL. Sir, please take your seats at the stage. We request you to take. We also welcome Shri Himanshu Jain, sir, CVO, SECL. Now I would like to request Dr. Sanjeevni to take over the mic for further sessions.
A very good afternoon to all of you. Respected today's chief guest, Chairman cum Managing Director, ACCL, Shri Harish Chauhan sir, Guest of Honor, CVO CIL, Shri Brajesh Kumar Tripathi sir, Director HR, ACCL, Shri Biranji Das sir, Director Finance, Shri Darla Sunil Kumar sir, CVO ACCL, Shri Himanshu Jain sir, Organizing Chairman, CIMECON 2026, Dr. Shruti Dev Mishra sir, Organizing Secretary, Dr. Arihan Jain sir, CMSs from all other subsidiaries, our ex-CMSs of ACCL, distinguished delegates, esteemed faculty members, and dear participants. I, Dr. Sanjeevni Panigrahi, Coordinator, CIMECON 2026, take immense privilege and honor in welcoming you all to the inaugural ceremony of CIMECON 2026. This year, we gather under a powerful and a purposeful theme, Healthy Minds, Healthy Nation, Strengthening Healthcare Across Coal India, which reflects our collective commitment towards advancing occupational health services and safeguarding the well-being of our workforce. To invoke the blessings of the Almighty and mark the auspicious beginning of the scientific congregation, may I now request our esteemed dignitaries to kindly proceed for the lighting of the ceremonial lamp. I request all the dignitaries on the dais to kindly join us for the lamp lighting ceremony. Sir, please.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत्.
Thank you, sir. The light we kindle today symbolizes knowledge, wisdom, clarity, and our shared commitment towards occupational health excellence. We shall now proceed with the Coal India Corporate Geet, celebrating the spirit, strength, and unity of our great organization. May I request everyone to kindly rise for the Corporate Geet.
खोद लाते हम उजाले खुशियों के, चट्टाने फोड़ जुटाते हम ईंधन लाखों के। हम हैं कोल इंडिया हम। कदम मिले चले ताल मिलाकर साथ पकड़ कर बाहें, हम लाए काला हीरा हमसे उज्जवल देश की राहें। हम हैं आग हम हैं बिजली हम एकता की खान, हम हैं कोल इंडिया हम।
Thank you everyone. Kindly be seated. Now, I request our organizing chairman, Dr. Shrutidev Mishra sir, to kindly welcome our CVO CIL sir with a shawl, flower bouquet and a memento. Sir, please. Thank you, sir. Now I request our organizing secretary, Dr. Arihan Jain, sir, to kindly welcome our CMT ACCL, sir, with a shawl, flower bouquet and a memento. Sir, please. Now I request Dr. Kalyan Sarkar sir, Chairman Scientific Committee, to kindly welcome our Director HR sir with a shawl, flower bouquet and a memento. Sir, please. Dr. VL Dhan ma'am, AMO Gevra area, to kindly welcome our Director Finance sir with a shawl, flower bouquet and a memento. Ma'am, please. Thank you, ma'am. Now I request Dr. Kumudini JBR ma'am, AMO Korba area, to kindly welcome our CVO sir with a flower bouquet, shawl, shrifle and a memento. Ma'am, please. Thank you, ma'am. It is now my privilege to invite our organizing chairman of CIMECON 2026, Dr. Shrutidev Mishra, sir, to deliver the welcome address. Sir, may I request you to kindly address the gathering. Sir, please.
Thank you, Dr. Sanjeevani. Good afternoon, all. Respected Chief Guest, CMD SECL, respected Guest of Honor, CVO CIL, respected Director HR Das, respected CVO, respected DF Sir, distinguished dignitaries, ex-CMSS, esteemed faculty members, delegates from various subsidiaries of Coal India, ladies and gentlemen. A very warm and heartfelt welcome to all of you at the inaugural ceremony of CIMECON 2026. It is indeed a moment of great pride and honor for us to host this prestigious conference under the theme Healthy Minds, Healthy Nation, Strengthening Healthcare Across India. This theme reflects our shared vision that the health of our workforce is fundamental to the strength, safety, and sustainability of our mining operations. We are deeply privileged by the gracious presence of our respected Chief Guest, CMD Sir, whose visionary leadership continues to guide us towards excellence and progressive growth. We are equally honored by the presence of our esteemed Guest of Honor, CVO CIL Tripathi Sir, whose commitment to integrity and transparency strengthens the institutional framework within which we function. I also heartily welcome all our respected functional directors whose presence adds strength and dignity to the august gathering. CIMECON 2026 has brought together nearly 200 delegates from across the country representing diverse subsidiaries and institutions. This gathering is a testimony to our collective commitment to academic excellence, collaboration, and continuous professional development. The scientific program has been thoughtfully designed to cover broad spectrum, contemporary, and relevant topics in occupational health. From preventive strategies to emerging diagnostic tools, from policy perspectives to clinical case discussions, we aim to foster meaningful deliberations that translate into improved healthcare delivery across Coal India. Special academic highlights include the Chairman's paper on occupational health and the DNB case presentation sessions, reflecting the depth of talent and dedication within our medical fraternity. As we inaugurate CIMECON 2026 today, let us reaffirm our commitment to safeguard not only the physical health of our workers, but also the ethical and institutional strength of our organization. I once again extend my sincere welcome to our Chief Guest, Guest of Honor, all directors, CVO SECL, and every distinguished participant. I wish conference a great success. Jai SECL. Thank you.
Thank you, sir, for your inspiring words. Now, I request our organizing secretary of CIMECON 2026, Dr. Arhan Sharan Jain, sir, to kindly present the briefing of CIMECON 2026. Sir, please.
परम श्रद्धेय CBO CIL सर, आदरणीय CMD सर, DHR सर, CBO SECL sir, DF Finance sir, I welcome you all to Coal India's Small Medical Fraternities Big Annual Conference, CIMECON 2026 at Bilaspur, Chhattisgarh. If I got a chance, I will change the word allopathy with EBM, that is evidence-based medicine. That is what we all doctors practice. And implementing evidence-based medicine requires three components: the best medical evidence, the skill of provider, and the value of patients. The CIMECON is designed to enrich this evidence-based medicine. Sir, we have 5 pre-conferences workshop on subjects which every doctor should know if he is working in Coal India Limited. That is on ECG, on spirometry, on chest X-ray, on pneumoconiosis, IME and PME. We have also invited 22 eminent national speakers who has shared or going to share their expertise from basic antibiotics to artificial intelligence in medicine to robotics in surgery. Dear delegates, not only our DNB students are participating it, but they are also showing their clinical work in case of case presentations. CIMECON has around 32 speakers from our own Coal India medical fraternity who has showing their work or clinical research divided in 32 speakers in various sessions. Work done in fields of occupational disease is also incorporated in this CIMECON in form of Chairman's Award. This huge scientific program is acknowledged by Chhattisgarh State Medical Council, and they have approved 6 credit hour of learning for each delegate who are attending this conference, and it is really a great pride, which is equivalent to any national conference happening in India. And with all this, the venue of this academic feast is chosen by keeping a quote from Charak Samhita that Prata Kal ki Vayu Nit Sevan Kare Sujan और कभू रोग व्यापे नहीं बुद्धि होए बलवान. So this magnificent venue. So we thank you all for coming this conference and making this event great. Thank you. Thank you, sir. Thank you, sir.
Thank you, sir, for your inspiring words. We are deeply privileged to have a special video message from our respected CEO Coal India, Shri B. Sai Ram sir, for CIMECON 2026. Our respected Chairman Coal India sir, Shri B. Sai Ram sir, for CIMECON 2026, which will now be played for this August gathering.
एक नॉलेज शेयरिंग, इनोवेशन और बेस्ट प्रैक्टिसेस के आदान प्रदान का महत्वपूर्ण प्लेटफॉर्म बनेगा। मैं इस सम्मेलन की सफलता के लिए अपनी शुभकामनाएं देता हूं। नमस्कार।
Thank you, sir. May I now request all our dignitaries on the dais to kindly unveil the CIMECON 2026 souvenir, which captures the scientific spirit and collective wisdom of this conference. This souvenir also has a special picture which was captured by our organizing chairman, Dr. Shrutidev Mishra sir, who is also a wildlife photographer. And a beautiful poem written by our organizing secretary, Dr. Arihan Jain sir. Thank you, sir. This souvenir stands as a testament to the dedication and scholarly contributions of our medical fraternity. It is now my proud privilege to invite our esteemed chief guest, respected CMD ACCL, Shri Harish Duhan sir, to address the gathering. Sir, please.
सभी को नमस्कार। CIMECON 2026 के उपलक्ष्य में मंच पर उपस्थित हमारे सबके प्रिय CVO CIL श्री ब्रिजेश त्रिपाठी सर, हमारे साथी FDs, CVO SECL एंड जिनके कंधों पर ये भार था कि इस CIMECON 26 एक दशक के बाद SECL में हो, जिन्होंने ये जवाबदारी ली, डॉक्टर श्रुतिदेव मिश्रा साहब, भारत के कोने कोने से यहाँ पर उपस्थित सभी प्रतिष्ठित मेडिकल फ्रेटर्निटी के उपस्थित सभी डॉक्टर्स, पूरा कोल इंडिया से उपस्थित मैं देख रहा हूँ कि काफ़ी संख्या में हमारे डिफरेंट सब्सिडरीज से यहाँ पे डॉक्टर्स आए हैं, एंड स्पेशली यहाँ पर प्रेजेंट SECL के हेल्थ एंड टोटल हेल्थ केयर सिस्टम के हमारे सभी डॉक्टर्स, यहाँ पर उपस्थित हमारे SECL और बाहर से आए हुए सभी सम्मानित महिलाएं और मीडिया के सभी सम्मानित साथीगण, वाकई ये ओकेजन मैं पुनः बधाई देना चाहता हूँ हमारे डायरेक्टर HR ब्रिंची दास साहब, डॉक्टर श्रुतिदेव मिश्रा, उनका पूरा टीम, जिन्होंने ये जवाबदारी ली और बड़े ही शानदार ढंग से इसको कॉन्फ्रेंस को ऑर्गेनाइज करवा रहे हैं। हमारे चेयरमैन सर का भी मैसेज हमने सबने सुना है। The theme of this conference, Healthy Minds, Healthy Nation, Strengthening Healthcare Across Coal India। वाकई ये शानदार थीम चुना गया है और ये हमारी मूल मंत्र भी है कि हम ना सिर्फ कोल इंडिया में, हमारे आसपास से जो भी सोसाइटीज़ में जितने भी साथी जुड़े हुए हैं उनका भी हम लोग केयर लेते हैं। रिसेंटली एक इंसिडेंट बताना चाहता हूँ, वो सब के लिए, हमारे डॉक्टर फ्रेटर्निटी के लिए एक गर्व की बात है और कोल इंडिया के लिए, स्पेशली SECL के लिए, कि हम लोग कैसे अपने परिवारों का, हमसे जुड़े हुए जितने भी कर्मचारी हैं, साथी हैं, हम कैसे केयर लेते हैं। रायपुर में एक प्रतिष्ठित ऑर्गेनाइजेशन है जो कि इंटरव्यू के लिए मुझे बुलाया था अपने स्टूडियो में। वहाँ पर जो एंकर थी पूरा इंटरव्यू अच्छे से लिया। उन्होंने स्पेसिफिक वो क्वेश्चन पूछे कि आप कैसे अपने कर्मियों का क्या मैसेज है या क्या केयर लेते हैं। वो तो ठीक है, हमने बताया कि हम क्या केयर लेते हैं, कैसे हम लोग अपने एक एक साथी की पूरी जवाबदारी लेते हैं कि वंस दे हैव ज्वाइंड आवर ऑर्गेनाइजेशन, तो उनके परिवार की हर तरह से हमारी जवाबदारी हो जाती है। और स्पेशली अगर हेल्थ केयर में किसी भी लेवल तक हमें जाना पड़े तो हम जाने के लिए पूरी तरह कमिटेड हैं और करते हैं। शी शेयर्ड एन एग्जाम्पल कि मैं भी कोल इंडिया परिवार से जुड़ी हूँ। मेरे पिताजी SECL में CIC कोलफील्ड में वर्क करते थे और मुझे अपने टीनेज में रीढ़ की हड्डी से संबंधित एक गंभीर बीमारी हुई थी और वो इस लेवल की थी कि अगर क्योर नहीं होती तो पूरा बेड रिडन हो सकते थे या और भी कुछ उसके साइड इफ़ेक्ट सीवियर हो सकते थे। पर उन्होंने पूरे खुशी से, गर्व से बताया कि कैसे SECL ने उस समय पे हमारे जो डॉक्टर्स थे उन्होंने कैसे हमारा केयर किया और मुझे बेस्ट ऑफ द बेस्ट ट्रीटमेंट दिया और आज वो बहुत ही शानदार तरीके से अपना जीवन आगे बढ़ा रही हैं। मैं कल का एक एग्जाम्पल और देना चाहता हूँ। कल हमारा लास्ट वर्किंग डे था फरवरी का, तो कुछ साथी उसमें रिटायर हुए थे। एक हमारे इंटरनल ऑडिट के जनरल मैनेजर HOD भी रिटायर हुए। उन्होंने बहुत ही इमोशनल होकर बताया कि उनके जीवन में भी एक ऐसा समय आया था जब ब्रेन ट्यूमर उनको हो गया था और काफ़ी उनको शायद लेटर स्टेज में वो पता चला तो काफ़ी बड़ा साइज था। डॉक्टर्स भी बोले जिन्होंने एग्जामिनेशन किया, दे वर आल्सो वरीड कि स्थिति थोड़ी सी नाजुक है। बट उसके बाद जो भी डॉक्टर फर्टिनिटी है, कृपया तालियां बजाइए जोरदार इन सबके लिए। इन्होंने केयर लिया एंड वो उसके जो भी ट्रीटमेंट हुआ 5-6 महीने के बाद ही इज़ लिविंग एन हेल्दी लाइफ। तो ये कुछ एग्जाम्पल हैं कि कैसे हम लोग अपने कर्मियों का, हमसे जुड़े हुए साथियों का हेल्थ केयर कैसे करते हैं यहाँ पर। सिमिलरली मैंने बताया कि हम सिर्फ अपने साथियों का नहीं, अपने कर्मियों का ही नहीं, हम आसपास की कम्युनिटीज़ के लिए भी कमिटेड हैं। हमारे जितने आसपास गवर्नमेंट कॉलेज हैं उनकी जो भी रिक्वायरमेंट्स है, जितने भी इंस्ट्रूमेंट्स या लेटेस्ट टेक्नोलॉजी उनको चाहिए, SECL उनको प्रोवाइड कर रहा है। चाहे MRI मशीन हो, चाहे CT स्कैन हो, मॉड्यूलर ऑपरेशन थिएटर हो या और भी। हम लोग एक और SECL प्रोग्राम चला रहा है जो हमारे यंग बच्चे जिनको हार्ट डिजीज़ का कुछ इश्यूज़ हैं उनका फ्री ऑफ कॉस्ट ट्रीटमेंट करवाते हैं, SECL की धड़कन। और जब उनसे आप मिलते हैं, उनके परिवारों से, माता पिता से मिलते हैं, तो जो खुशी उनके चेहरे पे दिखाई देती है वो हमारे साथियों का, आपकी सबकी मेहनत का ही प्रतिफल होता है। तो डॉक्टर फ्रेटर्निटी को भगवान का दर्जा हमारी सोसाइटी में दिया है और वही कार्य आज यहाँ पर इस कॉन्फ्रेंस के ज़रिए उसको और आगे बढ़ाने का आप सभी कर रहे हैं। मेरा पर्सनली मानना है कोल इंडिया जो कि राष्ट्र की ऊर्जा की रीढ़ है, हमारा आज भी मोर देन 70% जो बिजली उत्पादन हो रहा है वो कोयले के द्वारा हो रहा है और कोल इंडिया का शेयर इसमें 3/4 है। आने वाले समय में जिस गति से राष्ट्र प्रगति कर रहा है, हमारे प्रधानमंत्री जी ने जो सबको एक सपना दिखाया है कि 2047 में हम एक विकसित राष्ट्र बनना है, उसकी कड़ी में हमारी जवाबदारियां आने वाले समय में और बढ़ती जाएंगी। जो आवश्यकता है कि कोयला हम लोग कुछ बाहर से लेते हैं, उसको भी हमें सब्स्टिट्यूट करना होगा। इन सब को केयर लेते हुए हमारा जो लक्ष्य है कोयला उत्पादन का आने वाले समय में और बढ़ने वाला है। और जब ये जवाबदारी बढ़ेगी, चाहे वो अंडरग्राउंड माइंस के थ्रू हो, चाहे ओपन कास्ट माइंस के थ्रू हो, तो हमारे साथियों को और बेहतर स्वास्थ्य की तरफ अपने कदम बढ़ाने होंगे। वो बेटर हेल्थ अगर उनकी होगी, बेटर उनकी मानसिक स्थिति होगी, तो वो सुरक्षा के साथ अपना योगदान राष्ट्र की प्रगति में दे पाएंगे। तो ये जवाबदारी के साथ हम सबको इस कॉन्फ्रेंस से वो अमृत निकालना है कि जिससे हमारे सभी साथी जो कर्मी हैं, जो आसपास के लोग हैं, वो स्वस्थ रह सकें। मैं पर्सनली बिलीव करता हूँ हॉलिस्टिक हेल्थ में। सिर्फ बीमारी हो और उसके बाद ट्रीटमेंट हो, ये सेकेंडरी पार्ट है। अभी हमारे पूर्व वक्ता डॉक्टर अरिहंत जैन, डॉक्टर श्रुतिदेव मिश्रा, उनका भी यही मैसेज था। हम लोग प्रिवेंटिव केयर लें। अभी मेरे बाद हम सुनेंगे हमारे CVO CIL साहब को, उनको कोल इंडिया में 3 वर्ष से अधिक हुआ है और उन्होंने विजिलेंस का एक चेहरा ही बदल दिया है। आज उनका जो कंसेप्ट है वो सभी सब्सिडीज पूरे कोल इंडिया में चारों तरफ स्प्रेड है और एक ही मंत्र है, प्रिवेंटिव विजिलेंस। हमारे CVO SECL हिमांशु मिश्रा साहब, हिमांशु जैन साहब, उनका भी सेम लक्ष्य है कि कैसे हम लोग प्रिवेंटिव विजिलेंस के जरिए हमारे साथियों को सेंसिटाइज करते हुए, उनका कैपेसिटी बिल्डिंग करते हुए, कैसे प्रिवेंटिव विजिलेंस से हम लोग अपनी जो आवश्यकता है, हमारे जो कमिटमेंट्स हैं, हमारे जो लक्ष्य हैं, उनको अचीव कर सकते हैं। मेरा भी आप सबसे यही अनुरोध है कि हम प्रिवेंटिव हेल्थ केयर पे ज़्यादा ध्यान दें। हम लोग स्वस्थ कैसे रहें, बीमार ही ना पड़ें, वो लक्ष्य के साथ हमारे डॉक्टर फ्रेटर्निटी को आगे बढ़ना होगा। उसी कमिटमेंट के साथ हमें एक होलिस्टिक हेल्थ हमारे पूरे ऑर्गेनाइजेशन की, हमारे कर्मियों की, उनके परिवारों से जुड़े हुए लोगों की कैसे हो सकती है, ये हम केयर लें। इस पे हमारा फोकस ज़्यादा होना चाहिए और यही फोकस हमारा जो आने वाला समय है, हमारे जो लक्ष्य हैं, उसको सुरक्षा के साथ प्राप्त करने में हेल्प करेगा। और यही मुझे पूर्ण विश्वास है कि जो भी आप मंथन कर रहे हैं, उससे यही अमृत निकलेगा कि कैसे एक स्वस्थ और समृद्ध कोल इंडिया बने, SECL बने, हमारा राष्ट्र कैसे उन्नति करे। इसी डायरेक्शन में हमारे सभी साथियों का यहाँ पे कमिटमेंट आएगा और उसी डायरेक्शन में आने वाले समय में हम लोग अपना पूरा योगदान दे पाएंगे। अंत में मैं आपको सभी को एक संकल्प के साथ यहाँ पर आगे बढ़ने के लिए छोड़ना चाहता हूँ। स्वस्थ कर्मचारी, सुरक्षित खदान, सशक्त राष्ट्र। ये कॉन्फ्रेंस पूर्ण रीति से इसमें सफल हो। जय हिंद, जय SECL।
Thank you very much, sir, for your motivating address. Your visionary leadership continues to strengthen ACCL and inspire all of us. Thank you again, sir. May I now invite our guest of honor, respected CVO CIL, Shri Brajesh Kumar Tripathi, sir, to kindly share his valuable thoughts with us. Sir, please.
Respected CMD SECL हरीश धवन साहब, हमारे डायरेक्टर HR बिरंची दास साहब, मास्टर माइंड ऑफ दिस फंक्शन, डायरेक्टर फाइनेंस सुनील कुमार साहब, हिमांशु जैन CVO SECL, CMD साहब ने बहुत सारे एग्जाम्पल बताए कि डॉक्टर्स को कैसे लोग याद करता है, जब तक जीवन रहता है तब तक याद रहता है। मैं आज SECL की धरती से मैं भी एग्जाम्पल देना चाहता हूँ। 1-1.5 साल पहले एक हमारे CVO SECL थे, स्वर्गीय श्री जयंत कुमार खमारी। उनका रोड एक्सीडेंट हो गया था और जिस तरह का, अब कुछ एक्सीडेंट होना तो आपके हाथ में, हमारे हाथ में नहीं है, लेकिन उस घटना होने के बाद SECL या हमारी डॉक्टर्स किस तरह से रिएक्ट किए, उनको न केवल एयरलिफ्ट किया गया बल्कि भारत की सबसे जो बेस्ट हॉस्पिटल है वहाँ हमको एयरलिफ्ट करके उनको भिजवाया गया। अलग बात है कि भगवान की मर्जी कुछ और थी। तो मैं आज उस डिसीजन को, वो जो आपने निर्णय लिया अपने ऑफिसर के लिए, अपने अधिकारी, अपने कर्मचारी के लिए, उस डिसीजन को मैं नमन करना चाहता हूँ कि इतना बड़ा डिसीजन आपने लिया। मैं SECL के डॉक्टर्स को और SECL के मैनेजमेंट को भी धन्यवाद बोलना चाहता हूँ कि आप इतना आगे तक सोच लेते हैं। माय डियर फ्रेंड्स, उस डिसीजंस का जब पता चला ऑनरेबल CBC को, पूरे CBO फैटर्निटी में ऑल ओवर इंडिया में पता चला, इवन बाकी लोगों को जब पता चला, तो लोगों ने वास्तव में आश्चर्य किया कि योर कोल इंडिया इज ट्रीटिंग योर एम्प्लॉइज ऑफिसर्स लाइक दिस। तो हम इतना आगे बढ़ कर के ऐसा निर्णय लेते हैं, इतना बड़े बड़े डिसीजन लेते हैं। एक और मैं एग्जांपल दूंगा। 2020 में कोविड की महामारी थी, उसके आगे पीछे भी चलता रहा। वो ऐसी बीमारी थी कि जब आदमी से आदमी डरता था, मतलब हर आदमी अपने घर में दुबका हुआ था, बैठा हुआ था। यानी कौन कल जिंदा रहेगा नहीं रहेगा, सबके दिमाग में ये दहशत फैला हुआ था। दहशत इस तरह की थी कि फादर का डेड बॉडी पड़ा हुआ है और बेटा लेने से मना कर रहा है। ऐसी मुसीबत समय में जरा आप लोग नज़र दौड़ाइएगा, हिंदुस्तान के किसी भी कोने में क्या एक कोई स्ट्रीट लाइट ऑफ हुआ? क्या कोई भी मेडिकल फैसिलिटी या कोई लिफ्ट चलना बंद हुआ? आपको कहीं से कोई ऐसा न्यूज़ नहीं आया होगा। उस मुसीबत के समय में भी हम, जब देश में, पूरे विश्व में मुसीबत था, तो हमारा हर कोल इंडियन अपनी जान के परवाह नहीं किया। वो घर से बाहर निकला, अपने फैमिली का जान का परवाह नहीं किया, जा कर के उसने कोल का प्रोडक्शन कराया, उसको लोडिंग कराया, पावर प्लांट में भिजवाया। इस तरह का आप काम किए। लेकिन इतना साहस, इतना बोल्ड डिसीजन लेने का हर एक कोल इंडियन का हिम्मत कहाँ से आता है? वो माय डियर फ्रेंड्स, वो आपके चलते आया है। आपके चलते मैं बोलता हूँ, हमारे डॉक्टर्स जीवन दाता हैं। हर एक कोल इंडियंस के लिए, फ्रॉम हायर टू रिटायर एंड इवन टिल एक्सपायर, आपकी सर्विसेज रहती है। जब तक जान है तब तक आप उसके साथ रहते हैं। आप जीवन दाता हैं। मेरे सामने पूरे कोल इंडिया के इतने जीवन दाता हैं। मैं ईश्वर का दूसरा रूप यदि मानता हूँ तो मैं डॉक्टर्स को मानता हूँ। माय डियर फ्रेंड्स, जिस तरह का हमारा चैलेंजेज है, कभी अंडरग्राउंड माइन में जाके हमको ऑक्सीजन से जुड़ना पड़ता है, तो कभी पॉल्यूशन, कभी स्वास्थ्य के प्रति कितना डेंजर वे में जाकर काम करना पड़ता है। आपका जब सहयोग होता है तो हर कोल इंडियन उसी भरोसे से आगे बढ़ता है। मैं तो आपके सर्विसेज को बोलता हूँ कि जिस तरह से कठिनाई है कोयले खान में जाके काम करना, वो काजल के पर्वत पे चढ़ने की जैसी बात है। काजल के पर्वत पे चढ़ना और चढ़कर पार उतरना, काजल के पर्वत पर चढ़ना और चढ़कर पार उतरना बहुत कठिन है। निष्कलंक रह कर के ये सब करना, पर जब जब आप सहारा देते, उनका मान बढ़ाते, जब जब उनको अपना कहकर अपने गले लगाते, तब तब मुझको लगता है वो यह जीवन जी लेंगे। नीलकंठ की तरह यहाँ का सारा विष पी लेंगे। नीलकंठ की तरह यहाँ का सारा विष पी लेंगे। आपका सहयोग, अपनापन ऐसी बनी रहे ताकि बोल्ड डिसीजन, रिस्की डिसीजन हमारा हर कोल इंडियंस लें। उनका परिवार का आप केयर करते हैं, इस तरह से था। एक और मैं विजिलेंस से रिलेटेड केस स्टडी के बारे में यहाँ पर मैं सारे डॉक्टर्स के सामने बताना चाहता हूँ। कोविड पीरियड में ही हमारे सरकार की तरफ से आया था कि आपको एक ऑक्सीजन प्लांट लगाना है। उस पीरियड में एक ऑक्सीजन प्लांट आपको लगाना है, जब बिल्कुल पीक पे थे, सब कुछ मूवमेंट, सब कुछ सारा मूवमेंट, सारा कुछ जीवन अस्त व्यस्त था, रुका हुआ था, तब बोला गया कि आपको ऑक्सीजन प्लांट लगाना है। डॉक्टर्स और पूरी टीम कोल इंडिया की लगी और उसका टेंडर किए और उन्होंने 16 मई को उसका उद्घाटन करना था। 11 मई तक पूरा ऑक्सीजन प्लांट रेडी हो गया था। उसमें कुछ पाइपलाइन का फिटिंग्स को लगाना था जो कि बॉम्बे से आना था। अब वो इम्पॉसिबल टास्क था कि एक तो मिलना मुश्किल था उस समय, दूसरा वहाँ से लाना मुश्किल था। तो हमारे CMD और बाकी ऑफिसर्स लोग बैठे और मीटिंग किए कैसे होगा इस विपत्ति काल में, कैसे आएगा बॉम्बे से वो फिटिंग। तो ऑक्सीजन का एक पाइप होता है। तो मीटिंग में डिस्कशन पता चला कि जो सिविल इंजीनियरिंग का जो क्लोरिनेशन प्लांट वाला पाइप है, वो पाइप ऑक्सीजन प्लांट में भी लग सकता है। तो डॉक्टर साहब ने वहाँ से लोकल में वही ऑक्सीजन प्लांट का जो पाइप, क्लोरिनेशन प्लांट का पाइप लाए और ला करके उन्होंने ऑक्सीजन प्लांट में लगा दिया। वो ऑक्सीजन प्लांट 33,000 लोगों का जान बचाया। यानी उस मुसीबत में आपका उस निर्णय ने एक बहुत ही बड़ा ह्यूमन वाला काम किया और सरकार की आप पर भरोसा बढ़ा। उसके बाद सब कुछ ठीक हो जाता है। किसी बंधु ने कंप्लेन कर दिया कि उस ऑक्सीजन प्लांट में लोकल मटेरियल लगा है। वो कंप्लेन में जब विजिलेंस चेक किया, वो दुर्भाग्य की बात है कि कोल इंडिया लेवल में ही उसको चेक किया गया था, तो पाया गया कि हाँ, वो जो लोकल मटेरियल उन्होंने यूज़ किया है उसका एक्चुअल प्राइस था 5,40,000 रुपया, लेकिन डॉक्टर साहब ने जो वहाँ से लोग खरीदा था वो 5,30,000 दाम था और डॉक्टर साहब ने उसको खरीदा था 3,40,000 में, जो एक्चुअल प्राइस से वही खरीदा था। माय डियर फ्रेंड्स, डॉक्टर्स टेंडरिंग मैटर में बड़ा कमज़ोर होते हैं। उसमें कहीं रिकॉर्डेड नहीं था कि हम ये लगा रहे हैं, हमारा पर्पस सॉल्व हो रहा है, और क्यों लगा रहे हैं वो जो मीटिंग का डिस्कशन नहीं हुआ था वो कहीं था नहीं। और वो चूँकि सीनियर डॉक्टर का भी इन्वॉल्वमेंट था तो उसको CBC भेज दिया गया। उस घटना के कुछ दिन बाद मैं ज्वाइन किया तो CBC से हमसे कुछ क्लैरिफिकेशन मांगा गया, किसका क्लैरिफिकेशन दे दीजिए। तो मेरी ये एक आदत होती है कि जिसको मैं कुछ क्वेश्चन करता हूँ ना तो उससे पूछ लेता हूँ। तो चूँकि सारा इन्वेस्टिगेशन हो चुका था तो मैं लिख कर नहीं दे सकता था, मैंने फ़ोन घुमा दिया। तो वो डॉक्टर साहब को मैंने जब फ़ोन किया कि आपका ये केस है ऑक्सीजन प्लांट का, उसमें ऐसा था, तो डॉक्टर साहब बोल रहे हैं कि हाँ, एक आपके यहाँ केस चल रहा है, लेकिन मुझको कोई आत्मग्लानि नहीं है, जो मैं किया ठीक किया। ये पूरा सेंटेंस था, फ़ोन काट दिया डॉक्टर साहब ने। मुझको कोई आत्मग्लानि नहीं है, जो मैंने किया ठीक किया। आपके यहाँ केस चल रहा है, हमको पता है पनिशमेंट होगा। और उन्होंने फ़ोन काट दिया। अब मैं पूरा डिटेल केस मंगाया, देखा, जो बातें मैं आपको बताया कि 33,000 लोगों को जान बचाई और जो भी सिचुएशन था वो सारा तो मुझको पता चला। तो सीबीसी को तो मैं और कुछ नहीं लिख सकता था, लेकिन सीबीसी में बताया कि हमारे डॉक्टर्स के उस डिसीजन के चलते उसने ऐसा एक्शन लिया है। और एक और मैं बताया कि सर, बीइंग सीबीओ, हमको उन्होंने एक तरह से डांटा है कि हमने जो किया ठीक किया है। मैं पहली बार आत्मग्लानि वर्ड सुना था, हिंदी में ये वर्ड होता है आत्मग्लानि। फिर सीबीसी का आपका वो टॉप लेवल में वहाँ मीटिंग हुआ, हम लोग आपस में सब बैठे, लोगों ने बोला कि आपके कोल इंडियंस इस तरह से डिसीजन लेते हैं क्या? वैसे पीरियड में जब सब कुछ नहीं है, कुछ नहीं मिल रहा है, सब कुछ हो रहा है, तब भी आप ऐसा डिसीजन, इतना बोल्ड डिसीजन लेते हैं क्या? उस केस में कुछ नहीं हुआ, वो बाइज्जत बरी कर दिए गए। लेकिन आपके उस डिसीजन से कोल इंडिया का नेम एंड फेम बढ़ा, कोल इंडिया का वर्किंग कल्चर बढ़ा। और आज मैं शान से बोल सकता हूँ कि हमारे डॉक्टर्स ऐसा बोल्ड डिसीजन लेते हैं, आग पे चलते हैं। अब उसको मैंने, जो आत्मग्लानि शब्द है उसको मैंने चुना। आत्मग्लानि का मतलब हो गया कि कोई आप ऐसा काम कर रहे हैं जो आपका आत्मा आवाज़ देता है कि हाँ सही है, लेकिन बाकी आपको कहीं से इन्फॉर्मेशन कुछ मिल नहीं पा रहा है। हम जब हिस्ट्री देखेंगे, पहले कभी रूल्स रेगुलेशन नहीं था, कोई मैनुअल एसओपी नहीं था, तो हम लोग अंतरात्मा की आवाज़ सुनते थे और उसी को मानते थे कि वही सही है। तो मैं इस फोरम का, हमारे सामने सारे जीवनदाता हैं, आप सबसे मैं बोलना चाहूँगा कि आप भी बोल्ड डिसीजन लीजिए। आपके कलीग बोल्ड डिसीजन लेते हैं, आप भी लीजिए। हमारे कोल इंडिया के डॉक्टर्स ऐसे ऐसे डिसीजन लेते हैं, आग पे चलिए। हम आपके साथ हैं, विजिलेंस आपके साथ है। मैं कोट बना के चल रहा हूँ कि विजिलेंस इज बाई यू, विजिलेंस इज फॉर यू, विजिलेंस इज विथ यू ऑलवेज। कोई भी डिसीजन लेने के लिए हमको क्या चाहिए? इन्फॉर्मेशन चाहिए, इनपुट चाहिए, ट्रेनिंग चाहिए, कॉन्फिडेंस चाहिए, और सबसे बड़ा इम्पोर्टेंट है कि हमको वैसा माहौल चाहिए जहाँ पर हम भयमुक्त होकर के डिसीजन ले सकें, यानी करप्शन फ्री माहौल होना चाहिए। आपको कोल इंडिया में भरपूर हम लोगों ने ट्रेनिंग दिया, ऐसा मेगा सेमिनार करा रहे हैं, आपको हर तरह का फैसिलिटी दिया जा रहा है। आप आगे चलिए, आग पे चलिए, सोच समझ के डिसीजन लीजिए, रूल देख करके डिसीजन लीजिए, डिस्कस करके लीजिए डिसीजन। और जो डिसीजन ले रहे हैं मेरे जीवनदाता, जो डिसीजन ले रहे हैं उसको फाइल में रिकॉर्ड कर दीजिए। वो फाइल में रिकॉर्ड कर देंगे तो कोई आपको बॉस भी नहीं पूछने जाएगा, चाहे बिजनेस वाला भी पूछने नहीं जाएगा। और हो सकता है वो डिसीजन गलत हो जाए, डिसीजन लेना गलत भी तो हो सकता है। यदि वो डिसीजन भी हो गया गलत, तो माय डियर फ्रेंड, आपको मैं बता दूं, चाहे आपसे मैंने सुना है, भले डिसीजन गलत हो गया तो क्या हुआ, आपको आत्मग्लानि नहीं होगी, आपको आत्मग्लानि नहीं होगी। मैंने आपसे सीखा, मैं सारे कोल इंडियंस की बात बोलता हूँ, बोल्ड डिसीजन लो, आगे चलो। हम अभी फॉर्म और ट्रांसफॉर्म कर रहे हैं, कोल इंडिया में पूरी तरह से रिफॉर्म लाना है, पूरी तरह से ट्रांसफॉर्म लाना है। आज मैं बिलासपुर में हूँ, छत्तीसगढ़ की धरती पर हूँ, हमारे सीएमडी साहब यहाँ पर हैं। मैं एक मिशन लेके चल रहा हूँ कि हम आपको एक टास्क दे रहे हैं, ईयर 2030 में बिलासपुर में SECL का हॉस्पिटल इतना बड़ा हो, इतना भव्य हो, इंटरनेशनल स्टैंडर्ड का हो, ऐसा हम सपना देखें। बेस्ट डॉक्टर, बेस्ट फैसिलिटी, सब कुछ बेस्ट रहे, हम क्यों नहीं कर सकते हैं? हमारे पास दीपिका है, गेवरा है, कुसमुंडा है, जो इंटरनेशनल स्टैंडर्ड के हमारे माइंस है। यदि इंटरनेशनल स्टैंडर्ड के माइन हमारे पास हो सकता है, हम विश्व की नंबर 1 कोल प्रोड्यूसिंग कंपनी हैं, तो हमारा बिलासपुर में एक मिशन बनाएं कि अगले 4-5 साल में हम एक वर्ल्ड क्लास इंटरनेशनल स्टैंडर्ड का हॉस्पिटल बनाएं, और वो बिलासपुर में बनाएं, वो SECL का हो जाए, ताकि बाकी लोग हमारे यहाँ रिफ़र करें। इस मिशन में हमको काम करना है, ऐसा बोल्ड डिसीजन लेके चलना है। आप भी कर सकते हैं, आप कर सकते हैं। जब इस तरह से मेगा सेमिनार हम लोग कर रहे हैं तो आप लोग इसमें कर सकते हैं। दूसरा, मैं डॉक्टर्स को, इवन सारे कोल इंडियंस को बोलना चाहता हूँ कि जब भी कोई डिसीजन लेना हो ना तो रोकना नहीं है। डिले करने से डिसीजन नहीं रुकता है, डिसीजन नहीं होता है। डिले नहीं करना, आपको काम कर लेना है। वो भागवत गीता में लिखा हुआ है, नियतम कुरु कर्मत्वम कर्म जायो यो कर्म। अपना नियमित काम करो, क्योंकि काम करना, काम न करने से हमेशा श्रेष्ठ होता है। तो जो आपकी अंतरात्मा है, जो आपका मन चाहता है वो काम करो, डरो मत, किसी से डरने की जरूरत नहीं है। मैं शुरू से बोलता आया हूँ कि जब इस तरह का डिलेमा में फंसे हैं, डॉक्टर लोगों को तो ऐसे ही बहुत सारा डिलेमा होना पड़ता है, कहाँ भेजें, कहाँ रिफ़र करें, ट्रीटमेंट करें, इंजेक्शन दें, ऑपरेशन करें, क्या क्या डिलेमा होता रहता है। यदि इस तरह का कुछ भी डिलेमा है तो वहीं पर अंतरात्मा की आवाज़ आती है। जब सच झूठ में फ़र्क न हो, जब सच झूठ में फ़र्क न हो, जब गलत सही में घिर जाओ, तुम नज़र में अपनी गिर जाओ, इस बात पे थोड़ी देर तक तुम अपनी आंखें बंद करना और अंतर मन से पूछ लेना, मुमकिन है हम तुम झूठ कहें पर अंतर मन सच बोलेगा, पर अंतर मन सच बोलेगा। ये हम लोग जिस तरह से AI ML टेक्नोलॉजी का यूज कर रहे हैं, तो मेडिकल फील्ड में भी AI ML के जाएं। AI देखिएगा राज करेगा, जो लोग AI जानते हैं वो लोग राज करेगा आने वाले दिनों पर, उन पर जिसको AI का कोई नॉलेज नहीं है। बहुत सारे तेज़ी से लोग बढ़ रहा है, हमको भी उसी फील्ड में आगे बढ़ना पड़ेगा। CMD साहब ने बताया प्रिवेंटिव विजिलेंस। कोल इंडिया पिछले 3 साल से हम लोग 6P पर काम कर रहे हैं। पॉजिटिव विजिलेंस, प्रेडिक्टिव विजिलेंस, प्रिवेंटिव विजिलेंस, प्रोएक्टिव विजिलेंस, पार्टिसिपेटिव विजिलेंस और पनिटिव विजिलेंस। पनिटिव विजिलेंस लास्ट में होता है। जिस तरह से आपका क्यूरेटिव यानी ऑपरेशन लास्ट में होता है, वैसे ही हमारा विजिलेंस का भी पुनिटिव लास्ट में होता है। समाज में, कंपनी में, हर जगह कुछ लोग ऐसे होते हैं, कुछ बीमारियां ऐसी होती हैं कि बिना ऑपरेशन का वो ठीक नहीं होता है। ठीक उसी तरह से हमारे सोसाइटी में कुछ लोग हैं, वो बिना पनिशमेंट के ठीक नहीं होते हैं। आप जो काम कर रहे हैं, विजिलेंस डिपार्टमेंट भी वही काम कर रहा है। आप भी पॉजिटिव मेडिसिन की तरफ चलिए। साहब ने बताया कि इसके पहले कि उस बीमार पड़े, ऐसा हम बनाएं कि उसको बीमारी पहले ही डिटेक्ट कर सकें, प्रिवेंट कर सकें, अवेयरनेस लाएं, लोगों को पॉजिटिव वे में काम कराएं। पहले से जिस तरह से आपका सोसाइटी में और जिस तरह से लोगों के आप जा करके सब टेस्ट कर रहे हैं, जिस तरह से स्कीम हम ह्यूमनिटी के लिए चला रहे हैं, वो सारा एक्टिविटी को और आगे बढ़ाया जाए। प्रिवेंटिव विजिलेंस, पार्टिसिपेटिव विजिलेंस, सब लोगों को बताएं कि हम मेडिकल अवेयरनेस हमको चाहिए। और क्यूरेटिव तो है ही, हमारे पास पनिटिव है, आपके पास क्यूरेटिव है, तो उसका भी यूज करना है। ऐसे लोगों को जिनको ऑपरेशन की ज़रूरत है उसको ऑपरेशन करना पड़ेगा, नहीं तो आदमी मर जाएगा। ठीक उसी तरह से जो आदमी करप्ट है उसको हम पनिशमेंट नहीं देंगे तो वो हमारे सिस्टम को नुकसान करेगा। माय डियर फ्रेंड्स, हमारा मैं कुछ दिन पहले कहीं किसी कोर्ट का ऑर्डर से देख रहा था कि मेडिकल प्रिस्क्रिप्शन को कैपिटल में लिखना है। यदि हाथ से लिखें तो कैपिटल में लिखना है, या यदि उसको आप कंप्यूटर जनरेटेड कर सकते हैं तो अच्छी बात है, अदरवाइज हाथ कैपिटल लिखना है। क्योंकि कई बार ऐसा हुआ कि डॉक्टर जो लिखता है परफॉर्मेंस खाली समझता है, वो पता नहीं क्या समझेगा क्या नहीं समझेगा, कभी कभी लाइफ रिस्क हो जाती है। एक और, मैं विजिलेंस से जब कंपेयर करता हूँ तो हमारी जो लाइफ है, हमारा जो कर्म है, वो साधु वाला है। मैं अपने सारे विजिलेंस ऑफिसर को बोलता हूँ, इवन कोल इंडियंस को बोलना शुरू कर दिया हूँ कि कोल इंडिया इतना अच्छा हो चुका है कि आप थोड़ी भी गलती करेंगे तो बहुत बड़ी गलती मानी जाएगी। एक साधु कोई छोटी सी भी गलती करेगा तो उसकी बड़ी गलती मानी जाती है। वैसे ही विजिलेंस वाला कोई छोटी गलती करेगा तो उसको बड़ी गलती मानी जाती है। ठीक उसी तरह से मेरे जीवन दाता, आपकी छोटी गलती भी बहुत बड़ी गलती मानी जाती है, क्योंकि जीवन रक्षा से आपका है। तो हम एक ध्यान रखें, जैसे कोई पैसा लेते हुए पकड़ा गया तो उसकी सर्विस रिमूवल हो जाता है, ठीक ही उसी तरह से कोई फर्जी मेडिकल बिल जमा कर रहा है, मेडिकल रिकॉर्ड कुछ फर्जी कर रहा है, कुछ ऐसा फेक डॉक्यूमेंट हो रहा है, हम लोग अनवांटेड का दवा दे रहे हैं, अनवांटेड हम उसका ट्रीटमेंट करवा रहे हैं, अनवांटेड चेक करा रहे हैं। यदि कहीं से भी कुछ फ्रॉड दिखता है तो माय डियर फ्रेंड, वो रिमूवल फ्रॉम द सर्विस का पनिशमेंट है CVC मैनुअल में। तो आप भी साधु हैं, हम भी साधु हैं, कोई ऐसा गलती ना करें जिससे हमारे किसी का लाइफ या किसी कंपनी का, हम लोग ब्रांडेड कंपनी में काम कर रहे हैं, ये भी मैं आज बोलना चाहता हूँ कि हम क्यों ना ऐसा जजमेंट लो जो हमारा अंतरात्मा करता है, अलाउ करता है। कोई हाई कॉस्टली मेडिसिन रिफ़र कर देगा या एक ही पर्टिकुलर हॉस्पिटल को हम रिफ़र कर रहे हैं, या पता चला उसको एक डॉक्टर ने किसी का पेशेंट के बारे में जो मेडिसिन लिखा, मेरा ब्रदर भी डॉक्टर है, उसको मैंने भिजवाया तो बोला इतना दवा खा लेगा तो ऐसे ही मर जाएगा। मतलब हंसने की बात नहीं है, सत्य ये है कि हम ऐसा करते क्यों हैं। माय डियर फ्रेंड, अब कोल इंडिया बदल चुका है, हमारे डॉक्टर्स बदल चुके हैं। ऐसे हमारे टीम में कोई ऐसा है तो उसको मैं बोलना चाहूँगा कि आप भी बदल जाइए, ज़माने को बदलते हुए ज़माने के साथ चलना है। आज के डेट में यदि कोई पॉजिटिव ग्रोथ में जा रहा है या पॉजिटिव प्रॉफिट में जा रहा है तो SECL है, हम उसी धरती से बोल रहे हैं। फर्स्ट टाइम, इसके पहले हमेशा CCL ने ये मेडिकल कॉन्फ्रेंस कराया, फर्स्ट टाइम SECL कराया है। तो हम इस धरती से फिर बोलना चाहते हैं कि नया कोल इंडिया में अपने नया पुरुष के साथ काम करें, अपना एटीट्यूड चेंज कर दें हम। इस सेमिनार का पर्पस क्या है? आपने जो कोल इंडिया के बेस्ट स्पीकर हैं उनको बुलाया, आपने इंडिया के जो बेस्ट स्पीकर हैं उनको बुलाया, हमारे एक से एक जेम हैं हमारे पास। इस तरह से बड़ा बड़ा प्रोग्राम हम कर रहे हैं, इतना खर्चा कर रहे हैं, अपना सारा फैसिलिटी दे रहे हैं। तो मैं भी बोलना चाहता हूँ माय डियर फ्रेंड्स, अब आपको जगने की ज़रूरत है, अपना एटीट्यूड चेंज करें, अपना मेंटलिटी चेंज करें। हम कब तक रिफरल के भरोसे रहेंगे? हम अपना खुद हॉस्पिटल इतना अच्छा बनाए कि हम हमारे यहाँ लोग रिफ़र करें, हमको रिफ़र करने की जरूरत नहीं पड़े। यदि कहीं बेस्ट मेडिकल फैसिलिटी है तो वो हमारे कोल इंडिया में है, ऐसा हम काम ना करें। आप जगें, अपना एटीट्यूड को चेंज करें। इस तरह का सबका आपका साथ है, आपके DHR साहब पूरा लगे हुए हैं कि किस तरह से हम अपने लोगों को ट्रेंड करें, अच्छा करें। आपके CMD साहब इस तरह से लगे हुए हैं, इतना पैसा खर्चा हो रहा है तो कमी कहाँ है? सबका सपोर्ट है। फिर भी तुम अधूरे नहीं, तुम अभागे नहीं, बात इतनी सी है आप जागे नहीं, बात इतनी सी है आप जागे नहीं। माय डियर फ्रेंड्स, यही टाइम है कि हमको अपने आप को चेंज करना है। हम मिशन लेके चल रहे हैं, रिफॉर्म, ट्रांसफॉर्म, परफॉर्म एंड इन्फॉर्म। ये टाइम है हमको रिफॉर्म करना है, टाइम है हमको परफॉर्म करना है। और आप पर भरोसा बनी रहे, लोगों का भरोसा बना रहे, समाज का भरोसा बना रहे। आप जीवनदाता हैं। आई विश सक्सेस ऑफ दिस कॉन्फ्रेंस एंड थैंक यू SECL के मैनेजमेंट को और ऑर्गेनाइजिंग कमेटी को। आई विश ऑल द बेस्ट। थैंक यू।
Thank you, sir, for your insightful address and for emphasizing how integrity and transparency are important for a sustainable healthcare system. Thank you again, sir. Our Director Technical Project and Planning, ACCL, Shri Ramesh Chandra Mahapatra sir, has also joined us. I request our organizing chairman, Dr. Shrutidev Mishra sir, to kindly welcome respected DTPP sir with a shawl, flower bouquet, shriffle and a memento. Sir, please. Thank you, sir. We had our DNB session yesterday in which PG medical students who are pursuing DNB courses in our company hospitals in CCL and BCCL had participated. So I request respected CVO CIL, Shri BK Tripathi sir, to kindly present the awards for the same competition, sir. The third prize for the DNB session goes to Dr. Ganesh Sapkar, DNB Medicine, JR1, Gandhinagar Central Hospital, Ranchi, CCL. Second prize goes to Dr. Indra Bhushan Singh, DNB Medicine, JR1 and Senior Medical Officer, BNK Area, CCL. And the first prize goes to Dr. Shweta Singh, MS, DNB Medicine, JR3, Central Hospital, Dhanbad, Department of Internal Medicine, BCCL, from BCCL. Topic of her presentation was HOCM in young adults, why early diagnosis matters. Thank you, sir. With this, we conclude the inaugural session of CIMECON 2026. Once again, on behalf of the organizing committee, I extend my heartfelt gratitude to all our dignitaries and participants for gracing this occasion. Let us work together towards our shared vision, healthy minds and healthy nation. Thank you.
there's an important announcement. We are going to begin our session. We are running behind schedule, so kindly all be seated. We are continuing with our sessions. Lunch is not yet open. We are continuing with the sessions.
Everyone is requested to kindly take their seats. For the next session, I would like to invite Dr. Raka Shiore, Director, Madhumeet Diabetes Hospital, Raipur. The topic of his presentation is gut microbiota and its endometabolic orchestra. Chairpersons for the same session will be Dr. Anil Kumar, CMS MCL, and Dr. Suman Pal, sir, Deputy CMO CHM, Marendragarh. Sir, please. I request the chairpersons, Dr. Anil Kumar, sir, CMS MCL, and Dr. Suman Pal, sir, Deputy CMO CHM, Hasdev area, to kindly come on the dais to chair the session. Sir, please.
I request all the delegates to be seated. We are starting our session. We'll soon announce for the lunch. Kindly have little patience. I request all the delegates to kindly be seated for the sessions to start.
Yeah, it's prudent to listen about gut microbes before you go for lunch.
And maintain silence.
Please run the video.
दुनिया का सबसे धनी आदमी कौन है? टेस्ला का मालिक या अपने अदानी अंबानी? आप भी हो सकते हो। क्यों? मैं ऐसा क्यों कह रहा हूँ? अरे भाई पूछो तो। दुनिया का असली धनी आदमी वो नहीं है जिसके पास खूब दौलत है। दुनिया का सबसे धनी आदमी वो है जिसके पास रिचेस्ट बैक्टीरिया है, जिसके पेट में रिचेस्ट बैक्टीरिया, धनी बैक्टीरिया। दोस्तों, आपको पता है हमारे पेट में 10 ट्रिलियन बैक्टीरिया है जो धरती को 2-4 बार लपेट सकते हैं। अब आप सोचोगे कि इतने बैक्टीरिया को लेकर हम कर क्या रहे हैं? दोस्तों, सारी बीमारियों की एंट्री और एग्जिट पॉइंट यहीं से डिसाइड होती है। इसको बोलते हैं गट माइक्रोबायोटा। तो गट माइक्रोबायोम के बारे में मैं आज बात करने वाला हूँ। हमारी बॉडी में इतने अच्छे बैक्टीरिया हैं जिनको हम हेल्दी बैक्टीरिया बोलते हैं, और जो हमारी बीमारियाँ आती हैं वो होती हैं बैड बैक्टीरिया से। डाइजेशन के सुपर हीरोज़ हैं ये। हमारा पूरा डाइजेशन अगर कोई चीज़ कंट्रोल करती है तो ये गुड बैक्टीरिया कंट्रोल करती है। विटामिन की फैक्ट्री है ये। B12, विटामिन K, बायोटिन, सारे हॉर्मोन्स इनके द्वारा संतुलित होते हैं। आपको पता है गट ब्रेन एक्सिस, हमारा एंजाइटी, हमारा ब्रेन फॉग, हमको कभी भी कुछ खाने के बाद अच्छा लगता है, कहते हैं ना पेट खुश तो दिल खुश, मन खुश। सारा काम अंदर इन बैक्टीरियाज की फैक्ट्री में हो रहा होता है। इनमें से जो हार्मोन्स निकलते हैं वो हमारी एंजाइटी को कम करते हैं। बचपन से लेकर आज तक किसी भी चीज़ को खा के हमें अच्छा लगता है, वो क्यों लगता है? क्योंकि सेरोटोनिन बहुत ज़्यादा मात्रा में इनके द्वारा ही प्रोड्यूस होता है। हमारे सारे काम हमारे एब्सेंस में अंदर चुपचाप अगर कोई कर रहा होता है तो ये गुड बैक्टीरिया और बैड बैक्टीरिया के बीच में जंग हो रही होती है। अगर गुड बैक्टीरिया अच्छे हैं तो हम अच्छे हैं, हम हेल्दी हैं, और अगर हमारे बैक्टीरिया वीक हैं तो हमारी बीमारियां स्ट्रांग होती हैं। तो दोस्तों, ये मैटर नहीं करता कि हम क्या खा रहे हैं, सबसे ज़्यादा ये मैटर करता है कि हमारे बैक्टीरिया क्या खा रहे हैं, और वो ही डिसाइड करते हैं कि हमारा पेट, हमारी हेल्थ कैसी होगी।
तो दोस्तों, ये डिसाइड नहीं करता कि हम क्या खा रहे हैं, उससे भी ज़्यादा इम्पॉर्टेंट है कि हमारे बैक्टीरिया क्या खा रहे हैं। तो बिफोर दिस लंच सेशन, लेट्स हैव ए गुड डीप डाइव इन गट माइक्रोबायोटा। सो गट माइक्रोब एंड एंडोमेटाबॉलिक ऑर्केस्ट्रा, प्रोबेबली मैं एक शेर से शुरू करता हूँ। हम अपने उन डॉक्टर्स को भूल गए हैं जो हमारे अंदर आराम से काम कर रहे हैं। नाजिश अजीब है मगर वाकया तो है, दिल्ली पहुंचकर लोग वतन से बिछड़ गए। हम दिल्ली तो पहुंच गए लेकिन अपने अंदर के बैक्टीरिया को नहीं जानते। तो मैं ये इस शेर के साथ शुरू करता हूं। शुड ए डॉक्टर कंसीडर ए पेशेंट ए सिंगल ह्यूमन बीइंग और ए कम्युनिटी ऑफ ऑर्गेनिजम्स, बिकॉज वी आर मोर बैक्टीरिया देन ए ह्यूमन बीइंग। From bacteria like firmicutes, bacteroides, actinobacteria, proteobacteria, almost 10 to the power 14 times number of human cells, we are more of bacteria. So if we don't care of our bacteria, probably we are not caring of anything. Where on the healthy human is the microbe located? Most of the time, it is our GI, and they have largest diversity of abundance of bacteria from stomach to colon. So composition of gut flora depends upon type of delivery, type of food, and more environmental factors. If you go with the data and science, you'll see humongous data coming from metagenomics health claim surveys, and they say, मैंने जैसा कहा था, अडानी, अंबानी और टेस्ला का मालिक नहीं है सबसे rich. The richest person on earth will be having highest richest diversity of bacteria. So our microbiome changes as we mature with age, with puberty, pregnancy. Our diet changes with this kind of CMEs, medical conditions, treatment, pets in the home. Many more factors are being investigated, and probably we can lead to many more things by that kind of diversity, even only by our stool examination. So conventional bacteriological analysis of fecal flora, aerobic and anaerobic. Anaerobic bacteria are outnumbering the aerobic bacteria by a factor of 100 to 1000. And here the data which shows that potentially harmful bacteria and potentially helpful bacteria, and there are some gray zones of bacteria which are either of the times, depending on the condition, they become helpful and they become harmful. To address doctors' community about that bacteria is, I think it's a more prudent work, because most of the times it's an iatrogenic deficit and iatrogenic damage we are giving by unjudicious antibiotics to our patients. Even with the PPIs which we are giving to every of our patient is unjudicious. Why? I'll tell you. Because each human complex system, ecosystem with microbe plays ecological roles. Some microbes are functions to destroy, some are predators, some are prey for others, and some are producers of vitamin K factory, what I told, biotin. Vitamin D, every patient is coming with low vitamin D. Why? It's a lab error, or it's just because of your lack of biodiversity of your bacteria. So gut microbes, the neglected endocrine hormone, that's why I named it endometabolic orchestra, short chain fatty acids. The persons, the old patients who are coming and farting most of the time, do you know, the more you fart, the better is your heart. This is a dictum. Because short chain fatty acids, they accumulate, they produce acetyl, burite and propionate, and probably the energy source of host metabolism and changing of diversity, but the bad smell in fat is dangerous. So neurotransmitters, precursors to neuroactive compounds, bile acids, choline metabolites, HPA-axis hormones, GI hormones, all are wonderful, wonderful, doing so many things besides you, and these are the wonderful doctors inside you, which gives the brain behavior, tackles immune system, tackles cardiovascular system, give endothelial response, host metabolism is altered, and in stress, they have a good gut-brain axis. All our anxiety, all our serotonin axis. So gut dysbiosis is between the jang hai, हमेशा एक सुर और असुर के बीच. सुर देवता ये good bacteria हैं, and asur they are the bad bacteria. And whenever who wins will the fate of the patient. So effects of healthy gut microbiota and dysbiosis goes on, and on the gut and metabolic health of the cause, the disease is the fate of the person. So diabetes and gut microbiota, by degree data, a moderate degree of gut microbial dysbiosis is going on inside our body, and there is decrease in abundance of universal butyrate producing bacteria, which lends to the patient to a diabetic. Even they have data of 23,000 patients where they have just taken the stool sample and they have categorized which type of diabetes the patient can have before having diabetes. So interaction between host genetics and gut microbiomes in diabetes can give you what is, where is that? So the development of obesity, insulin resistance, type 2 diabetes and metabolic syndrome in general are the consequent and multi-directional interaction between host genetics, environment, diet and gut. Even in type 1 diabetes, they have shown that dietary exposure to gliadin, intestinal flora changes, inflammation increase, and Treg cells, we have to take them as a T regulator cells, they cause the ability of first aid of intestine permeability. The antigens are produced, and probably the patient lands in self-autoimmune destruction of pancreas and type 1 diabetes. So genetic predisposition of type 1 diabetes is also postulated with the loss of gut microbiome. So therapeutic consideration to reverse the gut dysbiosis. How can you reverse? You have listened, all diabetologists and physicians working here have been giving acarbose, a wonderful molecule, AGI, to reduce sugar levels, and probably they have been postulated when you give acarbose, they push polysaccharide to colon and increase colonic bacteria mass, which facilitates production of short chain fatty acids. That's why whenever you give acarbose with the first major meal or every meal, patient has more of bloating and more of gas formation in the body, and that probably suppress the pro-inflammatory cycle, and that's why they attribute to CV benefits. So there are very less molecules in diabetology which have more CV benefits, and probably the more wonderful molecule which we are talking, the talk of the day, drug of the day, Ozempic, GLP-1RA, Zepbound, Monzero, probably they all are also acting with GLP-1 axis because of this gut microbiota eliminations and moderation. So these all attribute to CV benefits. And what about metformin? I don't think in the earth anybody who has not received metformin in diabetes. Metformin has a wonderful role because some patients are metformin sensitive. They can't tolerate metformin even at 250 milligram of metformin. But who the patients who are the tolerating metformin, they are the wonderful molecule because they increase the abundance of Akkermansia, a mucus degrading gram-negative bacteria in the gut, which is associated with the restoration of Treg cells and amelioration of low-grade tissue inflammation in the adipose tissue. So that's why metformin helps in tackling the gut microbiota, and probably they helps. The effect of gut microbiota on the host, what I was telling them about GLP-1R axis, which is Monzero and Ozempic and other injections are giving, they have also the role because gut microbes, when changes, the suppression of AGTP and GLP-1, alteration of insulin levels and sensitivity, and that's why they help indirectly and directly for these compounds. So what is the bacteriotherapy? Comprises of 3 different compounds. One is probiotic. Probiotics are the living bacteria, all fermented food, dahi, chach, kanji, everything. So we need to go for every day such kind of food to improve our probiotics in. And the non-digestible compounds lead to favorable changes in the intestinal microbiota. Prebiotic means हमारे live bacteria जिनको खाते हैं, that's a prebiotic, and there are something which is symbiotic, probiotic and prebiotics. So these should be altered and given in almost every diet. And what about our ancient diet? They say our vegetarian diet is a good diet. They have certain postulations, and we have also certain scientific data that animal-based diet significantly impacts gut microbiota more than the plant-based diet. And the persons who are on plant-based diet have a less diverse genetic flora, but because of so many things in animal-based diet, there are something harmful also, and there are something beneficial also. So animal-based diet associated with increased expression of key genes for vitamin biothesis, but degradation of polyachromatic hydrocarbons. Diet alters microbial activity, gene expression. That's why diet induces changes to gut microbiota, and they contribute to irritable bowel disease. These are the pesticides. We are in long use of using pesticides, heavy metals, and this microplastic. Everything is coming in microplastic. Everything which is served to your home by any commercial pharma marketing or marketing, all are coming with packed with nanomaterials, and these changes your gut microbiome. Induce gut microbiota dysbiosis, and they have a multiple potential adverse effect on health. So PPI, we are in fashion of giving PPI on demand or by own. They block gastric acid secretions, change the microbiota, and this is imprudent to talk at this forum that we should not give PPIs to everyone. Avoid using PPI voraciously, indefinitely, like an umbrella treatment. Clindamycin. Clindamycin reduces resistance to coronavirus pathogens. High risk of pseudomembranous colitis have been reported due to Clostridium difficile. And smoking, alcohol, and gut microbiota. Any conference can't be without alcohol, and that's why what they do like what we have done in Corona period. Most of the time sanitization. They used to go to the gut and sanitize the gut microbes, and probably alcohol and smoking deeply modify the microbiome from both upper and lower gastrointestinal tract. So modulating this gut microbiota like LGG or mucinephalia may alter the course of liver disease, IBD, and other disorders. To our great expression, we are in habit of treating H. pylori infection. But H. pylori infection is not always to be treated, because H. pylori has a different pathology, and probably H. pylori is generally regarded as human pathogen, but it can act as a commensal symbiont. And H. pylori conjugation can benefit the host by regulating gut microbiota. Most of the time we are giving anti-H. pylori treatment, probably sometimes it is wrong. So be aware of that. Too much use of antibiotics can lead a bad life with a bad microbiota. Gut dysbiosis associated with CKD. If you talk about CKD and altered gut microbiota, then antibiotic use, low sodium, potassium, and phosphate diets in CKD, patients exhibit gut dysbiosis risk. And as CKD progresses, renal function declines, links to uremic toxic retention. So we should be very conscious. And how to restoration of gut microbiota, because if I am discussing about a problem, I should also discuss about the solution. So probiotics, prebiotics, gut microbiota, even they have a poop therapy we call as fecal microbiota transplant. What they have done in ICU patient, chronic debilitated patient, they have done poop therapy. They have installed healthy gut microbes from a good patient, and they have inserted per rectally gut microbe transplant, and this has done wonder in some patients who are not responding to anything. So probiotics can be a supplement to good bacteria levels in the gut. Prebiotic fibers promote resident probiotic growth in the gut. Fecal microbiota transplantation can introduce a new set of microbes in the gut. So summary, dysbiosis of gut microbiota is increasingly appreciated as a mechanism of accounting for diabetes and many endometabolic disorders. Gut bacteria use polysaccharide substrate as a fuel for growth and conversion into short-chain fatty acids. Short-chain fatty acids have beneficial effects on the host energy metabolism and inflammatory responses. And there are humongous papers which have shown that definitely even in our India, when we used to go for street food, probably we are exposed to most of the time. If the water is good, the proper masala is good, then probably we are having a good biodiversity of bacteria in us. That's why it has saved many of us in COVID times, while our European and Caucasian counterparts who have not been exposed to such kind of rough street diets, they have no such gut biodiversity, and that's why they succumb to such kind of environment, which is automatically taken as a catastrophe in the whole globe. So acarbose treatment, metformin treatment, and many other treatment, including probiotic and prebiotic, we should take care of our gut, because gut is the biggest doctor inside all of us, and we should have healthy diets which our parents were taking, which our ancestors were taking. Thank you so much.
Sir,
I have saved the time also.
any question from audience?
No questions will be entertained.
Okay, sir.
Our next speaker has got flight, so we have to hurry up.
Okay, thank you, sir.
Okay, thank you, sir. Very nice presentation. Okay, thank you.
Thank you, sir. I request our esteemed chairpersons to kindly felicitate our speaker. Thank you, sir. Now I request our organizing secretary, Dr. Arihan Jain, sir, to kindly felicitate our chairpersons. Dr. Anil Kumar, sir, and Dr. Suman Pal, sir. Thank you, sir. For the next topic, I would like to request Dr. Rakesh Gupta, sir, Consultant ENT Surgeon and President AOI CG Chapter, Raipur, to kindly come on the stage for the topic of his presentation is noise pollution beyond social nuisance. I also request the chairpersons, Dr. A.R. Mudgal ma'am, ex-CMS ACCL, and Dr. Kaushik Sutradhat, sir, to kindly chair the session.
I invite Dr. Rakesh Gupta, a well-known ENT surgeon, doing practice in the Raipur for last 30 years. He had his graduation and post-graduation from Raipur Medical College. He was president of IMA, Raipur, 2022 to 24, and he was a organizing secretary of 67th AOI Con 2015. Now his topic is noise pollution beyond social nuisance. Please start.
I am grateful for the invitation, and one of the chairmen is my senior and one is junior. I am grateful for the invitation to the organizing committee and Dr. Arihan Jain and Dr. Kaushik Sutradhar. This topic is close to my heart, not as a being in the profession, but as the social commitment also. Since the noise pollution is a social menace and hidden health crisis in the developing and the developed countries, I like to put upon some glaring things which we have come across during the social campaign. The urban noise pollution has emerged as one of the most neglected public health crises of our time across Indian cities. Decibel level routinely exceed the permissible human limit near school, hospitals, residential areas and administrative premises. There is National Ambient Noise Monitoring Network established in 2011. Central Pollution Control Board has established. It is real-time noise data platform. Around 15 years of its existence, it is acting merely as a tool of passive repository rather than tool of reform for correcting the noise pollution. Meaningful enforcement remains elusive, which must have been used for the noise pollution correction in the urban cities. Data is the key, as we all know. Problem lies not only in the faulty noise sensor level placement in the ambient cities levels. It is almost 20 to 30 feet higher in the poles. It is violation of the Central Pollution Control Board violation. We must put the sensor in the noisy area close to the noise level or the originating in the noise level, but it is biased or the faultily collecting the data. All the welfare policies have the myopic vision towards the correcting the noise monitoring data actively. Statistics protects the living rights of the affected urban and the noise prone pollution. Since all the officers here are connected to the industrial safety noise rules, but we have another problem in the city levels. European Environment Agency recently estimated the annual economic cost of noise pollution disease around 100 million euros. This forms the policy redesign in the speed zones and the zoning European levels, but looking into the Indian scenario, it is lacking. We have the constitutional right to live with dignity. Article 21 guarantees in the right to life with dignity encompassing the mental and the environmental well-being, and Article 48A mandates the proactive environmental protection. Many public representatives and the policy makers have a neglected sense of responsibility towards the more needy noisy levels. Sometimes the silent zone becomes the epicenter of noise, raising serious questions about the state capacity and civic respect. The Noise Pollution Control Rules 2000 offer robust legal framework, but enforcement has neglected responsibility towards the cause. There is invisible social and health element. Noise is just not a technical issue, but it is political absence of sustained outrage stems from normalization of sonic aggression. Heavy machinery, construction activity, drilling and loudspeakers have become ambient irritants that has never been challenged. The civic fatigue towards the responsibility is another source of irritant. Unlike smog, garbage, the noise leaves no residues, so it is never addressed. Serious ailment of silent ailment suffers utter neglect. Only frayed minds, disturbed sleep cycles are among the targeted population among children, elderly and those with pre-existing morbidities. India's legal framework is robust on paper only, but it suffers from fragmented execution. The noise pollution rule 2000 rarely updated to reflect the urban realities in our times. There is little coordination between district administration, municipal bodies, traffic police and pollution control boards. As we see the global standards, India has first 3 cities among the most noise pollutant cities. Mumbai, Calcutta and Delhi remains among first 7 cities across from 2000 onwards. As I said, number 1 is Delhi, number 2 is Mumbai. 3 metro cities among first 7 cities among the most noisy cities. Bangalore, Hyderabad and Chennai among these cities. As per WHO data, 27% of overall population in India suffers disabling hearing loss against 11% in high income group and 3% in North African countries. Nearly 48% Indians over 65 years suffer debilitating hearing loss compared to only 18% in high income countries. 12.3 billion children and 18.8 million adults of the region including India, Pakistan, Nepal, Bangladesh, Afghanistan and Bhutan suffer disabling hearing loss due to noise or other correctable deafness diseases. Noise pollution rules are very simple but is mostly on paper. Residential area 55 decibel, it is approximately equal to classroom noise. Silence doors 45 decibel, small group conversation as 2 people are talking from 3 meters distance. In night from 10 p.m. to 6 a.m. residential area comes to 50 decibel and silence doors come to 40 decibel. These are the guidelines which are comfortable guidelines. Day and night noise levels from 35 to 75 decibel. More than 65 decibel comes to the discomfort noise levels. For classroom it is 35 decibel, but looking into the size of classroom nowadays, in our times when we were going through school, it was classroom size of 45 students. Now it is around 65 students. This is standard data, but for a classroom we can consider 55 decibel is the approximate noise levels. Noise pollution is a serious health hazard affecting all the citizens in a country which is one of the most noisiest country in the world. It's a myth. Everybody should come across this fact that horn is noisier than firecrackers. So the noisy cities must be prevented from the honking. The social organizations are making awareness for the horn, for the heart. Hearing is the most challenging thing nowadays. Pediatric hearing has to be suffered because it is the next generation hearing. Stress is one of the most causative factor due to high noise levels. Vehicular traffic is the most important culprit in having noisy surroundings. These are the comparable noise atmosphere. Washing machine creates 70 decibel. Traffic noise is 80 decibel inside the car. The leaf generator or the what we call dust cleaner is 90 decibel. Sporting event, heavy crowded stadium is having 100 decibel, and more than 110 decibel is rock concert or the music shows. More than 10 minutes can create the deafness. These are the loud noise can cause high blood pressure, heart disease, permanent deafness. Even if you realize beforehand, you can get the permanent deafness, irritability, behavioral changes, headache. The intrauterine growth retardation is linked to the higher noisy levels in the ladies living in the noisiest surroundings. Poor school performance is the key factor in children having noisy housing societies. Cardiologist opinion, we all know cardiologists propagate the sound level below 60 decibel in heart patients. Psychiatric opinion says that there is change in the behavior due to noisy surroundings. Public awareness campaign is most important to create the safe sound initiatives. We have seen irritability, short angers, blood pressure elevation, stretching of the muscles, hyperacidity, indigestion, and ability to do minute work is related to the noisy surroundings. As the custom goes, for all health hazards, we celebrate Noise Awareness Day on 30th April, and India, we have 26th April is the No Horn Day. It is initiative of Indian Medical Association and AOI, Association of Otolaryngologists of India. It started when I was secretary from 2015 onwards. These are the most noisy culprit sources: heavy machinery, rock concerts, and the industrial safety things are the city generators. We have to educate the society that only in emergency we have to use the horns. This is very important judgment of Bombay High Court. Use of loudspeaker is not crucial for any religion, and the loudspeaker must face the devotees, not outside the religious premises. The loudspeaker is not essential for any religious activity. This is another High Court decision, and living in quiet condition is our basic right. This is 40 years old law, Madhya Pradesh Kolahal Niyantran Adhiniyam 1985, which governs our noisy surroundings. Now it is being amended in Madhya Pradesh, Chhattisgarh. The High Court, Honorable High Court Bilaspur has made the committee, and sooner or later we will have new laws regarding the noisy surrounding, city surroundings. During festival, it is on average it is 113 decibel, more than a rock concert. Social initiatives are very essential to educate the public and the layman. No honking drive from 15 to 22nd August is celebrated from 2015 onwards in Bombay. Affected population needs protection, patronage and counseling. Traffic police and city vendors working around the highways, or the drivers working in the roadside must be protected and subject to health screening. Duty shift and places provide them the, as per law, we should shift the duties from 8 to 6 hours, or they must change their place of duty to protect their hearing. This is very important for the Motor Vehicle Act. No Motor Vehicle Act allows you to change the structure, basic structure of the vehicle. It is punishable offense. Police can find the vehicle laden with the sound box like this. It attracts penalty up to the 25,000. First time it has to be released by the city magistrate. If it is caught twice, the registration has to be cancelled. It is Honorable High Court order. While preparing the talk, I could trace this piece of news. It is 50 years back news of the Hindu. Just last week I traced. In a busy Chennai chowk, they measured the decibel, noise decibel. This is just for the awareness, and it was initiated by the ENT Surgeons Forum, AOI. This is a twin weapon. We prevent the air and noise pollution by preventing the atishbaji during festival. We have made a group in Raipur, and law enforcing agencies has to be sensitized through repeated reminders and the delegation going to them. The delegation of handful of people sensitized by the noise has to go to collector and tell them that what is going on in the city. We met SP to force the Honorable High Court order given before last year. We have to do social interaction, and public resistance is needed to force the laws, existing laws. High noisy level is violation of basic right. We can protest to the district administration that high noise loudspeaker not to be allowed in the housing society. The loudspeaker noise more than 75 decibel beyond 10 p.m. is not allowed, and it attracts 5 years imprisonment and up to 1 lakh penalty. Ultimately, law of the land prevails. The Honorable High Court has taken suo motu cognizance of a news item and called Chief Secretary of Chhattisgarh State to be answerable. Without giving permission from a district administrator, even pandal in the common road is not allowed. DJ of more than 20 decibel beyond 120 decibel cannot be allowed. This is the very funny example. In the busy road, the colony has installed the shades to prevent the noise coming into their housing society. Late night festivities has their side effects. The green pataka is prevented is allowed for the sale. And recently, Honorable High Court has given decision. All the CCTV footage during the festival should be protected so that they can give the decision later on whether the pandals and the DJ vans were allowed by the district administration, were allowed or not. This was a late 2022 order, but it had not been installed, although they have purchased the sound limit. All the DJ van has to install the sound limiter so that sound limit can be monitored. Provision of to register FIR against the erring element. This FIR has been lodged in Raipur also. He was using DJ after 12 late night. In the silence zone, police cannot allow the loudspeaker. This is another High Court decision. Designated silence zones are hospitals, schools, district administration premises and the all the government buildings, even police cannot allow. This is a joint social effort from AOI and Indian Medical Association. We had Mayor of Raipur, Pramod Dubey, coming hand to hand with us. Dalai Lama ji came with AOI and IMA effort in Delhi, and the lady holding the hand of Dalai Lama ji is Sumaira Abdul Ali. She is pioneer of anti-noise campaign in Bombay. We have requested all the concerned citizens to install the city noise meters in their mobiles so that they can document the noise in the surroundings and send to us. These evidences can be used in the court hearing. Noise spares none. This is study by European study that noisy human birds, there is change of behavior in the birds also. There are so many laws, but whistleblowers from media are needed. This is Sumaira Abdul Ali having study in jungles, rivers and birds. This is article by me regarding noise pollution. This is Chief Justice of India, who has given that firecrackers should not be banned not only in Delhi but other cities as well.
We'll request sir to conclude, please.
Thank you so much. This is wide topic. To do justice in 20 minutes is not possible. Thank you very much.
Thank you, sir. Thank you for the informative and wonderful talk. I know this topic is very close to your heart, being your junior, and I follow it regularly. I know that you have been actively doing work in Raipur and around in India. Thank you so much, sir. Thank you so much for the talk.
We are extremely sorry for the delay. We'll have one more speaker to speak before we conclude the morning session, and then we proceed for lunch. We are very sorry for the delay, but...
Thank you, sir. Now I request our esteemed chairpersons to kindly felicitate our speaker, Dr. Rakesh Gupta, sir. Sir, please. Ma'am, please. Thank you, sir. Thank you, ma'am. Now I request Dr. Ramlal, sir, Senior Medical Specialist from ACCL, to kindly felicitate our esteemed chairpersons, Dr. Kaushik Sutradhar, sir, and Dr. A.R. Mudgal, ma'am. Sir, please. Thank you, sir. Thank you, sir. Thank you, ma'am. Now I request our next speaker, Dr. Sandeep Gurram, Consultant Neurologist, Apollo Hospital, Secunderabad, to kindly come on the stage to present his topic on utility of botulinum toxin and deep brain stimulation in movement disorders. To chair this session, I would like to request Dr. Shushila Khunte, Deputy CMO WCL, and Dr. Pratibha Pathak, ma'am, ex-CMS ACCL. Ma'am, please.
A very good afternoon to all of you. The next topic of discussion is utility of botulinum toxin and deep brain stimulation in movement disorder. This is a very important topic related to neurology, and this is going to be presented by Dr. Sandeep Guram, consultant neurologist and movement disorder specialist, Apollo Hospital, Secunderabad. I will briefly introduce him. He has done MBBS and MD Internal Medicine and DM Neurology from Kasturba Medical College, Manipal University, and postdoctoral fellowship in Parkinson's disease and movement disorder from NIMHANS, Bengaluru. And he has over 8 years experience in clinical neurology with special focus on movement disorders. And he has expertise in botulinum toxin therapy and deep brain stimulation for Parkinson's disease and dystonia. Approximately 15 national and international publicity in neurology he has. So, sir, the stage is over to you. Please continue.
Thank you, chairpersons, for the kind introductions. So I am Dr. Sandeep Guram, consultant neurologist and movement disorder specialist, working at Apollo Hospital, Secunderabad. So I'll be talking on the utility of botulinum toxin and deep brain stimulation in movement disorders. So just to start with, so what are movement disorders? So these are neurological conditions that affect the speed, fluency, quality, and ease of the movement. So they are broadly classified into two types. The first one is hypokinetic movement disorders. Second one is the hyperkinetic movement disorders. Again, there are many subdivisions in both hypokinetic as well as hyperkinetic, but by and large, hypokinetic movement disorders indicate less movement or slow movement, whereas hyperkinetic movement disorders indicate excess of movement. So these are the common movement disorders that we encounter in common OPD practice. So under hyperkinetic movement disorders, we have dystonia, tremor, chorea, myoclonus, tics, and ataxia. And under hypokinetic movement disorders, we have one and only Parkinsonism, which is the most common. So coming to what is botulinum toxin. So we all know that botulinum toxin is an exotoxin which is secreted by the bacterium Clostridium botulinum. So it is known to cause botulism, which is a life-threatening neuroparalytic syndrome. Around 8 serotypes have been described, starting from A to alphabet H. So how do they act actually? So how can we use them in the clinical practice? So on the right side of the slide, you can just see the neuromuscular junction. So the top one is the normal neuromuscular junction. So you can just see that the yellow one, the top one is the nerve terminal, whereas the down one is the muscle cell, and the gap in between is the synaptic cleft to the neuromuscular junction. So for a nerve impulse to So for the nerve impulse to traverse the synaptic cleft and go to initially there has to be calcium influx. So after the calcium influx, we have the synaptic vesicles which contain acetylcholine, which needs to fuse with the cell membrane of the nerve, and then it needs to release the acetylcholine receptor. So once the acetylcholine releases in the synaptic cleft, it goes and binds to the acetylcholine receptor here, which leads to the muscle contractions. So what happens here, there are a group of proteins called as snare proteins, again, which are namely synaptobrovin, SNAP25, syntaxin, and there are so many others also. So which help in the fusion of this synaptic vesicle with the cell membrane, leading to the release of acetylcholine. So what happens when you just administer botulinum toxin, or the patient is suffering from botulism, the botulinum toxin contains two, which you can see here. It contains two components, the heavy chain as well as the light chain. With the help of heavy chain, it enters into the nerve terminal, and then the light chain blocks this snare group of proteins, thereby not allowing this synaptic vesicle to fuse, and then acetylcholine is not released, so the muscle doesn't contract, leading to the weakness of the muscle. So this is how the muscle is paralyzed, and that causes both the botulism as well as the clinical effect of botulinum toxin injection. So coming to the various types of botulinum toxin that are used. So out of all the 8 types which we have known, only 2 types are used predominantly. In that also, botulinum toxin A is the one which is predominantly used. Again, there are various companies which produce botulinum toxins, but the most common or the most commonly available company is the Botox. The first one, that is Ono botulinum toxin A. Then we also have Dysport, Xeomin again, but then they are very rare to get. So only one company produces botulinum toxin B, that is Rima botulinum toxin B, which is Myoblock. All have almost the same efficacy, no much difference between them. So coming to the utility of botulinum toxin in movement disorders. So as we have discussed already, that botulinum toxin actually causes the muscle to temporarily get paralyzed for a particular duration, which leads to the improvement of the symptoms. So it's predominantly used in the hypokinetic movement disorders rather than hypokinetic movement disorders. So you can just see it can be used in spasticity as well as blepharospasm, which is a form of dystonia, oromandibular dystonia, bruxism, laryngeal dystonia, cervical dystonia, limb dystonia, hemifacial spasm, tremors, tics, and myoclonus. See, even in I've also mentioned that it can be used in Parkinson's disease also. That's because Parkinson's disease is known to be associated with dystonia, so which we can use it. Or Parkinson's disease patients usually have a sialuria, excess salivation. So decrease those salivation, again we can use botulinum toxin. And very rarely we can also inject into the destrosal muscle for any urinary urgency or bladder overactive symptoms. So coming to the efficacy and duration of effect of botulinum toxin. So how efficacious is it? So by and large, I've just mentioned all the efficacious percentages in various dystonia cells. But by and large, around 70 to 90% of the people who have been injected with a particular right dose into the right muscle will improve. And the duration of effect usually lasts for around 3 months. But then the patient is lucky, the effect might go up to 6 months also. But that's rare. So coming to the assistive techniques, most commonly botulinum toxin will be injected with the help of palpating the right muscle and then rightly activating the muscle and then injecting directly. But in some cases, the muscles that you have to inject may be deep, for example, inside the neck, or maybe into the larynx, or maybe for injection into the small muscles of the hand. So for that, you need assistive techniques such as EMG guided as well as ultrasound guided. So what happens is in EMG guided on the left hand side of the slide, you can see that you need to put the needle into the muscle and ask the patient to contract the muscle. So whenever when a person contacts the muscle, you can hear a sound, characteristic EMG sound. So by then you will know that you are into the muscle and then you can inject it into the right muscle. Similarly, with the help of ultrasound guided, you can just localize the muscle visually and you will be sure that you have injected into the correct muscle. So this is a video which I'll be showing. Not playing. That's why I asked you. Okay, sorry for the interruption. So I'll just be continuing my talk. So here is a patient of writer's camp. You can just see that the thumb, so that the thumb is extending. As he writes, the thumb is getting extended, and he has also very mild extension of the index finger as well. So what we have done, so we have injected Botox into two muscles. One is the extension, the extensor of the indices finger as well as the extensor of the thumb. So you can just see in this video that we inject and ask him to extend the finger. So once he extends his finger, you can hear the contraction and then you can inject it. Similarly for the thumb also. So you ask them to extend the finger as shown in the video here. So when he does that, so you hear a sound and then you can inject like how he's injecting. So this is one way of assistive technique while injecting botulinum toxin. So what are the complications of botulinum toxin? So by and large, we don't have any major complications with botulinum toxin. So very rarely we can have some local injection site reactions such as pain, erythema, edema and bruising and all. And headache and flu-like symptoms are also rare. And we can have muscle weakness, again, but that is temporary, which we usually get back over a period of 2 to 3 weeks. and very, very rarely you can have allergic reactions or systemic spread. Again, we can have some site-specific complications, such as when you inject Botox into the face, you might have a facial deviation, or you can have an ectropion of the eyelid, or you can have a ptosis, again, if the dose is slightly more. But then that is also reversible. So no major complications that you can expect with botulinum toxin injection. So here I'll be showing you a few videos, the pre and post Botox injections. So here is a case of hemifacial. This lady is in her mid-50s. She has left hemifacial spasm, as you can see. So you can just see that her left eye is getting closed, as well as there is deviation of the angle of mouth to the left side with intermittent twitching of the whole face. So she has a left hemifacial spasm, and this is around 2 weeks post botulinum toxin injection. You can see her that the spasm has relieved, and she has developed mild, very minimal left facial palsy as well. So we can just adjust the dose later by giving a less dose. But then you can see that it's almost 95% of the spasm has gone with her. Similarly, this is a case of Bell's palsy. Again, post Bell's palsy, there might be facial synkinesis which leads to the contraction of the eye. So right side, and you can see the facial deviation also. Similarly, after Botox, and you can just see his deviation of angle of mouth is gone and eyes is opening better. So this is one example of botulinum toxin injection and hemifacial spasm. So again, this is another example. So this young lady, again, she is suffering from cervical dystonia. You can see her head is turned towards the left side. This is called as laterocolis. And so when you just inject botulinum toxin, you can just see almost the whole cervical dystonia has improved a lot. So this is another case of oromandibular dystonia which I wanted to show. So here you can just see this person. He is having difficulty in chewing food as well as drinking water. So he has severe orofacial dystonia as well as some part of mandibular dystonia as well. So he is unable to drink water properly. And then this is post botulinum toxin. Though he has humans, but then around a 50% improvement is noted. He's able to swallow the food properly now when compared to earlier. And he's able to drink water also properly. At least his day-to-day activities of living, daily living have improved better. Similarly, we have another case here. This lady, again, she had severe orofacial dystonia, as you can just observe in this video. She has continuous movements as such, and this is post botulinum toxin injection. You can just see almost the whole oral movements have vanished. So this one is another case. So of lingual dystonia. You can just see the tongue protruding while he speaks. So he can't speak properly. And then this is 2 weeks later. You can just see that the tongue is inside. It's not even coming out. And his quality of life has. And this is a case of spasticity. See, this elderly gentleman is suffering from Parkinson's disease as well as dystonia with spasticity of both lower limb. So you can just see his heels are lifted from the ground while he walks. So he walks on the toes. This is called as toe walking. So he had this toe walking, and then we've given botulinum toxin into the calf muscles. Now you can just see that both his feet are on the ground. I mean, the heels are on the ground. So he was able to walk better. And this is an interesting case again. This is a case of functional tic disorder. So you can just see his shoulders having tic-like movements. This is a psychogenic tic disorders. So he had very continuous movements of both shoulders, I mean both scapular muscles, so which led to significant disability. And he could hear some sound also coming from his shoulder, and he was worried that he might get a shoulder dislocation or something like that. You can just see on the right side he had very severe tics. So these movements are continuous, and they were painful too. And this is post botulinum toxin injection. Around 2 weeks later, you can just see that his movements have vanished. So there were no movements. His pain also has become better. So botulinum toxin can also be used in tic disorder. So that completes my talk on botulinum toxin and its utility in movement disorders. So then I'll be starting with deep brain stimulation. So basically what is deep brain stimulation? It's just a reversible and adjustable surgical treatment used for the treatment of advanced movement disorders. So it has been tried in various disorders, but then the primary diseases where deep brain stimulation is used are these three. The first one being the Parkinson disease, second one dystonia, third one essential tremor. So the large amount of evidence lies in treatment of these three conditions. So what is DBS? So in deep brain stimulation, what we have is, we have 4 parts. The first part is the IPG or the neurostimulator. It's also called as implantable pulse generator. So it's just implanted in the chest under the skin, either on the right side or on the left side. And then it contains a wire called as extension wire, through which again the extension wire is there till the scalp part. From there, 2 burr holes are made during the surgery, and then electrode is introduced into the target area where you want to stimulate. So the tip is called the electrode, and this one is called the lead. So, and the tip or the electrode contains again 4 contacts, vertically oriented. So we can stimulate any one of the contact based on the clinical response. So these 4 parts are there in the deep brain stimulation. So even the connection, the extension wire is under the skin, it's not visible, it's just like a pacemaker, like how a pacemaker is put for the cardiac cases. Similarly, we put the battery here for the case of deep brain stimulation. So what is the mechanism of action of DBS? I mean, how does it act? So nobody knows actually how DBS acts again, but then there are various proposed mechanisms of how deep brain stimulation works. So it could be inhibition, or it could be excitation, or both inhibition and excitation, or disruption of pathological oscillation. So what happens is, if, for example, in the case of dystonia, you have an overactive neurons which are functioning, then probably by inhibiting those overactive neurons, either with the help of decreasing the excitated neurotransmitter or maybe increasing the neurotransmitter levels, I mean inhibitory neurotransmitter, it can cause that inhibition. Similarly, the same with the excitation, or sometimes it might be both inhibition and excitation that might be occurring. And there is an interesting thing called as disruption of pathological oscillations. Actually, there are neuronal oscillations which occur in the deep part of the brain, especially near the basal ganglia, which are usually called as local field potentials. So these local field potentials, actually they oscillate in a particular frequency. And like many studies have noticed that there is a particular rhythm called as beta rhythm, where the frequency lasts from 13 to 30 hertz, where this frequency is associated with symptoms of rigidity, bradykinesia, and Parkinson's disease. Again, abolition of these beta bands is known to improve the symptoms of Parkinson's disease. So that is also one mechanism of action of DBS. And sometimes there may be irregular bursting of these neuronal oscillations, which again can be regularized with the help of DBS. And that is also one proposed mechanism of actions, but nobody exactly knows how the DBS works. So the DBS surgery is done, but where do you put the target? I mean, where do you put the lead, and how do you select the targets? So I'll not be dealing with the psychiatric and cognitive disorder, because evidence is still required for cognitive disorders, and for depression and OCD, even DBS is being used. But for the movement disorders, so for Parkinson's disease, the target will be subthalamic nucleus or the globus pallidus interni. But subthalamic nucleus is the most commonly used target for Parkinson's disease, whereas thalamus, that is the VIM nucleus of thalamus, that is ventro-intermediate nucleus of thalamus, is where you put a lead when you treat patients with essential tremor. And you select GPA or the globus pallidus in case of generalized dystonias. So this is the target for dystonias. So these 3 are the primary targets that you use while doing the deep brain stimulation surgery. So how do you select a candidate? So these are the selection criteria. I don't know whether you're able to see those criteria, but I'll just read out to you the most important ones. So how do you select a candidate for the DBS in Parkinson's disease? So by and large, it has to be Parkinson's disease first. So we should be clear that the diagnosis is Parkinson's disease and not atypical Parkinsonism. And if it is Parkinson's disease, and it should be responsive to levodopa. At least 30% of the response to levodopa is required criteria for selecting a candidate for DBS. And the disease duration should at least be greater than 4 years, and the patient should be usually having motor fluctuations or dyskinesias, And only one symptom which is like need not be levodopa resistant is the tremor dominant. Meaning patient can have tremors which are not responsive to levodopa drug. Yes, they can still be treated with DBS, especially if they are drug resistant. And you need to have few contraindications to DBS in these patients. So any patient with a very severe neuropsychiatric disorder such as hallucination, psychosis, if they are not controlled, you're not going to take them. Or if the patient has dementia, severe cognitive impairment, you don't take it. Or the patient has high cardiovascular risk. For example, he has some heart failure with ejection fraction 30%, and that's a contraindication. Or if the patient has excessive cortical atrophy, or you are not sure what the diagnosis is, especially if it is an atypical Parkinsonism, please don't do DBS. So coming to the candidate selection for DBS in essential tremor, this is very simple. So essential tremor, if it is disabling or interfering with the quality of life of the patient, and it is refractory to all the medications that you have tried, beta blocker, primidone, and then possibly a benzodiazepine, then you can just select the candidate for DBS. But most of the essential tremors that we see usually are mild, which can be left alone. Only if it impairs with the quality of the life, then you can go with the WIM DBS. Again, you will have to have the same contraindications. Again, the cognitive impairment or the dementia being the most common one, which needs to be excluded. So coming to the candidate selection for DBS in dystonia. So any patient with a primary generalized dystonia, especially with or without the positive DIT1. DIT1 is a monogenic mutation which is known to respond very well to DBS. So even without DIT1 mutation also, if it is a primary generalized dystonia, they can be best candidates, especially if they have failed the standard treatment with medications as well as botulinum toxin injection. And a younger age, less severe symptoms of surgery, and a shorter duration of disease usually predicts a better outcome. So what is the therapeutic efficacy of doing a DBS? So you have done a DBS, so what do you expect? So we expect around 60 to 80% improvement in the symptoms, both in Parkinson's disease as well as dystonia, if you select the right patient and do the right job. So the effect is not immediate, as you can see in this picture. See, there is a latency towards the improvement that occurs. For example, in the case of Parkinson's disease or an essential tremor, you can just see the tremor, it improves within seconds. So on table, you can just put it in the right place, you can just check if the tremor abolishes or not, especially if it is continuous. If it's an intermittent one, then it's a bit difficult. Then the rigidity takes few minutes, and the bradykinesia a few minutes to pass, and the axial symptoms, that is the neck rigidity, the bending that you see, the camptochomia and the Parkinson's disease will take some time, few days or few months. Whereas in dystonia, you can just observe it is not immediate. There are two types, the phasic and tonic dystonia. So tonic one is a fixed dystonia, where the body doesn't move, it's fixed. Whereas the phasic dystonia is the one which is mobile. The patient will be having dystonic spasms, and I'll be showing a video of phasic dystonia later. So that improves first, whereas tonic dystonia, it takes some time. And coming to the complications of DBS surgery, so regarding the surgical or hardware complications, you might have an intracerebral hemorrhage. That again, the risk is very less than 2% or so. Then you can have anesthetic complication, venous infarct, pneumocephalus, all these are there. DBS specific or DBS hardware related complications would be lead malposition or the dislocation or the fracture. And post-DBS, few people can develop reduced verbal fluency, dysarthria, and then some mood changes or mild cognitive infection. Again, these are not very common, and they are rare actually. By and large, people do well after DBS surgery. So coming to a few videos which I just want to show. This is the case of tremor dominant PD. This is pre-DBS in the off state. You can just see the head tremor as well as very severe tremors in both the hands, right hand, left hand, and both the legs also. You can see the postural component also. He has asymmetry, again favoring idiopathic Parkinson's disease. And you can see post-DBS, almost there are no tremors at all. You can just zoom in and see also, you don't have any tremors. So I'll be finished. And this is another case. This patient has akinetic rigid PD, so you can just see the slowness of the movements. Very slow, requires short steps, and is tube posture. And he has occasional freezing of gait rather. So the same person, post-DBS, you can just see, he walks alone. His speed has increased.
We'll request Dr. Sandeep to kindly conclude.
Yes, sir. I'll just take a minute. So I'll not be showing this. This is another case But this one I'll be just showing. This is a case of dystonia. So this is pre-DPS. This child, you can just see how disabling he is. He's suffering with DIT1 mutation, that is TOSIN1 mutation dystonia. So he's unable to stand with support. Okay, he's not able to do any of his activities. Just an 8-year-old child. Yes. This patient post DBS, this is 3 months later. He's able to do all his activities. He's like almost a normal kid. You can see that significant improvement you can see with DBS in dystonia, especially if the case is selected right. So you can just see how his quality of life has changed for life. Thank you.
Thank you for sharing your valuable insight. You covered each topic from the starting, from classification to the utility of toxin, how it is utilized. Thank you for sharing. And all the videos are very excellent.
Thank you, sir, for this insightful session. I request our chairperson to felicitate Dr. Sandeep Guram, sir.
An important announcement. We break for a very short lunch of only 10 minutes. We are extremely sorry as we are running behind schedule by 2 hours. It will be a lunch break of only 10 minutes. Our Chairman's Award, the most awaited inter-subsidiary competition, the Chairman's Award is scheduled next and we will start by 3:15 sharp.
I now request Dr. Arihan Jain, sir, to felicitate our chairpersons.
All the participants for the Chairman's Award and the judges, please be ready near the podium. At 3:15, we will sharply start our Chairman's Award competition. All the participants.
And even after Chairman's Awards, we have a very, very exciting session. We all know that artificial intelligence is going to replace human brain. Whether it is replacing or not, to get the answer, we have an excellent speaker from Chennai, from Apollo Group. Also, we have a very excellent talk. We all know that we are eating a lot and fatty liver disease is getting, every other person is affecting with this. On this also, we are having an excellent talk by Dr. Devinder Singh sir, senior consultant from Apollo Hospital, Bilaspur. We also have lot of about robotics in surgery. We have what doctors should do beyond their surgical skills and lot more to come. So don't think post-meal session is going to be really very interesting. So please stay with us. Thank you. Thank you.
बिलासपुर छोड़ के चले
एडवाइजरी की पोस्ट निकालना
नहीं निकालना आएंगे
निकालो है क्या सुनो ना एडवाइजरी की पोस्ट निकाल दो आ जाओ
बोलता हूँ स्पेशलिस्ट कोई नहीं है एडवाइजरी की पोस्ट निकाल
मेरे बैर में है ना कोई आया है ना
अरे चली गई आई नहीं सस्पेंड हो गई क्यों आई नहीं ज्वाइन ही नहीं जब ज्वाइन करके चली गई
वहाँ देखो हेडक्वार्टर देखो जो भी होगा जारी होगा कुछ एडवाइजरी की पोस्ट एक साल कितना 80 है ना कितना दे रहे
90 की 95 दे रहा
आ जाता क्वार्टर दिला दो आपका है ना ऊपर में उसमें रह जाओ नहीं क्या
पहले क्यों नहीं बोले सर अभी बोल रहे हैं
आप बोल रहे हैं गया करके अभी हम सुबह जाके जाके सीढ़ी मारेंगे
आप आएंगे जीडी मार चालू और संडे को जाते हैं नहीं जेडी तो खाई ना खाई बात हेलो हेलो कौन बोल रहे हैं हेलो ओ कहाँ से आप कहाँ हैं मैं तो हॉल में हूँ दिन रखे हो ना इसलिए हम 2017 में 2 ही दिन का था सैटरडे तक
সালা 20 বছর ফেলে রেখে দিয়েছি, এখন এবার জায়ান্ট হবে সব এরা। এই যে পবন জায়ান্ট হবে। না না হয়ে যাবে, সব ঠিক হয়ে যাবে। পবন এক্সপার্ট স্পেশালিস্ট। পবন ডিজি ফার্স্টে চলে যাবে, পালিয়ে যাবে বলছে। হয়ে যাবে, হয়ে যাবে। যেটা ফ্যাক্টরি এক দেখে ফ্যাক্টরিতে
Now we will be having the prestigious Chairman's Award session for occupational health, for which the first speaker is Dr. Kartik Thokla, Medical Superintendent, Nodal Officer, OHS, CIL Kolkata. To judge this competition, I would like to request Dr. Kalyan Sarkar sir, CMS Sohagpur, Dr. Devashish Niyogi sir, retired CMO from WCL, and Dr. A.M. Mohan sir, ex-CMS ACCL, to kindly come on the stage to judge the session. Sir, please. The first topic of the presentation by Dr. Kartik Thokla is Transforming Occupational Health in Coal India Limited, a shift from statutory compliance to preventive excellence. Sir, please.
Hello. Hello. Hello.
प्रोग्राम बहुत अच्छा हुआ और जब वो इनॉग्रेशन को पूरा देखा वहाँ तक फुल था, हाँ एकदम भरा हुआ था, एकदम भरा हुआ था। उससे और पता चलता ना कि भाई यार हाँ ऐसा नहीं कि इतना बड़ा हॉल किया। और नहीं नहीं गैप रहता था।
I would like to make one clarification. The 2 minutes questionnaires will be only from the judges. No audience questions will be taken. The 2 minutes questionnaires will only from the judges.
Hello. 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 Welcome to the post-lunch session where we are going to hear the Chairman Award session. This is. And in this session, actually, mostly they will be presenting occupational health related subjects mostly. And here, under Chairman's Award, for the speaker, it is actually 8+2. That will be 8 minutes for your presentation and 2 minutes for the questions. So please look into the time factor and accordingly this can be produced. Okay?
Yes, sir.
The first speaker is Dr. Kartik Thokla. Okay? Please.
Thank you, sir. Good afternoon, everyone, and the jury. I am Dr. Kartik from Coal India Limited, and my topic today is Transforming Occupational Health in Coal India, a shift from statutory compliance to preventive excellence. So, Coal India is operating at an extraordinary scale with the largest coal producing company in the globally and operating across 9 subsidiaries with more than 3.5 lakh employees. Occupational health, managing occupational health is not merely a clinical responsibility, but it's a global it's a governance challenges for us. Actually, we are facing much challenges in this because of the varied and vast manpower, and this is the first step for our thinking in transforming occupational health. Traditionally, occupational health is merely a statutory requirement. Only PME is considered to be done for complying our statutory requirement. With most of the documents are being physical and being recorded, but not systematically analyzed. And this led to our transformation towards preventive and predictive OHS model. These issues made us to take strategic decisions for establishing occupational health wing at CIL headquarters and all other subsidiaries, naming all the PME centers and OHS coordination meeting. And this is a move from fragmented medical activities to structured OHS governance. And the new OHS code, OHS working condition code, is catalyzing our transformation. And this is a backbone of our structure of occupational health. This is a governance transformation with a defined reporting structure with accountability and uniformity across our subsidiaries. And we are talking about a model OHCs. This model OHCs will be our plan for with a simple PME room to dedicated medical examination with fully equipped and fully automated and digital X-ray with compliant with ILO and USGs, ECOs, and advanced lab facilities with IT-enabled digital recording system. And we are now strengthening our medical surveillance with simple PME, just PME, to annual medical examination or master health checkup with approximately 50 investigation parameters in line with OHS rules. This will lead to early detection of occupational and also the lifestyle diseases. And regarding occupational disease or notifiable disease, this is a nightmare for all of us. Diagnosing this as a notifiable disease is a diagnostic dilemma for all of us. We are moving with an occupational disease governance with SOPs for occupational disease survey and structured referral protocols and annexure-based documentation and ILO diagnostic criteria. With this decision-making will be scientific, transparent, and uniform all across the subsidiaries. And we are not just limited to our hospital walls. We should reach out with a proactive and preventive surveillance protocols with the pit head camps, awareness initiatives, and also we should care for not only our employees but also the project affected populations. And transformation is transformation is just not a movement, but also it requires people. For this, we are building capacities of our doctors with an occupational training or AFIH training for almost 45 doctors has been trained in the last 2 years. And ILO classification of chest radiographs is around 180 people are working in our CIL. We are planning for an orientation workshops in the near future, very near future I can say. And this capacity building of technical staff and paramedical staff is also being organized, and we are also making SOPs for standardized equipment handling protocols for all these technicians. And this is a big shift, the digital transformation, as with a unified medical portal with automated scheduling and digital recording. We are moving from the registers to the real-time surveillance and reactive detection from predictive analysis. I am showing a glance of the model which we are working on for digitalization. This is a glance model, and this is a safety officers module, and this is a medical examination officer, medical officer's dashboard. Occupational health, we are planning for integrating occupational health with national programs like NTP, mental health, and also industrial hygiene for implementation of hierarchy of control. Our dispensaries, we are planning for integration of dispensaries for proactive, preventive, and review protocols at the dispensaries. And we, Coal India, are moving from only compliance to preventive excellence with these components like structured OHS wing at CIL headquarters or all other subsidiaries, with standardization across all the subsidiaries, with a AI-enabled disease prediction, model OHCs, and fully digitalized system. We are shifting from statutory obligation to preventive excellence. Our vision is clear. This is zero preventable disease progression and uniform standards across all the subsidiaries. Our worker-centric occupational model can be scalable to whole India in a national level. This is my motto and our vision. We are not just following the regulations, we are just setting the benchmark for occupational health in India. Thank you, Ven.
Dr. Karthik,
Yes, sir.
Since Coal India has adopted an approach from a reactive one to a proactive one.
Yes, sir.
Now, does Coal India have any plans for upgrading our healthcare infrastructure?
Yes, sir.
And the healthcare manpower required for this change?
Yes, sir. I just want to explain, sir, these things. Actually, there is a comprehensive hospital audit being done in 2025 from January to November, which we have recently on 26th of this month, February, we have submitted the report to Ministry of Coal. And I am presented myself on the audit report. So we have a committee actually with all the DHRs of Coal India and its subsidiaries and all the CMS of the subsidiaries. They are deliberating on the audit report and they are finalizing the recommendations for upgradation of medical services in terms of all these parameters, sir.
And one more thing. Yes. By the figures which has been reflected here, there are, I think, 45 OH doctors across different subsidiaries of Coal India and 180 ILO trained doctors.
Yes, sir.
Now, for the ILO trained doctors, are you planning any refresher courses in the near future? Because once it has been observed that ILO training, to acquire ILO training, it's easy. But you need to regularly practice by going through your X-ray plates. Now, is Coal India planning any such measures?
Sir, we have an actual schedule of ILO training at CIL headquarters, Kolkata, every year in the month of April or May. Sir, this will be a regular practice for us, and all the doctors who are already trained will be reviewed, will be asked for refresher training also. Yes, sir.
There was actually occupational health committees.
Yes, sir.
You know that part?
Occupational disease board.
Not disease board.
Committee, yes.
Occupational health committee.
Yes, sir.
These occupational committees are actually from the root level. That is actually mines level, at the sub-area level, at the area level, at the company level, subsidiary level, and at the Coal India headquarters level. Whether these things are being now continuing or not?
Sir, actually, recently we have formulated these things. That was being practiced previously. Now we are reinventing and reviewing these things. And we are planning for a pit-head occupational health committee. Means at the unit level and area level, there is whoever the occupational health physicians are, they are being asked, and we have an official order to include these doctors in the tripartite and bipartite meetings also. And in every level, that means in the company level, in the subsidiary level tripartite, the OH in charge, like that.
Thank you. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Our next speaker is Dr. Satyajit Roy, Deputy Chief Medical Officer, Sanctoria Eastern Coalfields Limited. The topic of his presentation is Role of Continuous Glucose Monitoring in Glycemic Control of Diabetes Patients in Primary Care. Sir, please.
Good afternoon, respected chairperson and delegates. My topic is role of the CGM in the glycemic control of the diabetes patients in the primary care, a study conducted in the coalfield area of the Asansol and Raniganj. First of all, my gratitude to the SECL organizing committee for giving me the opportunity. Now, before going into my study, there should be brief knowledge about the continuous glucose monitoring. If we go to the history of the glucose testing, it was started in the mid-1800 by the testing of urine glucose, thereby development of the glucometers and thereby developments of the CGMs in the early 90s. And nowadays we are using Libre, Libre Pro and so many versions of the glucose monitoring. What is CGM? It's a method to track the blood glucose throughout the day and night. How it works? It actually, a tiny sensor is just put under the skin, which actually measures the interstitial fluids glucose level. And it is actually compatible with your smartphone devices, and there is another option that doctor can see the results of the glucose monitoring. This is the schematic diagram, how the CGM is inserted in our body. The benefits of CGM, actually the SMBG, conventional SMBG, provides the snapshot of our blood glucose, where CGM provides the trend or streaming of the blood glucose level. So, is it SMBG is obsolete? No, SMBG is still relevant nowadays, but CGM is the most relevant diagnostic modality of diabetes nowadays. There are several studies that is showing the differences between CGM and SMBG, where we will do the CGM and where we will do the SMBG. During the interpretation of the CGM, two things is most important. One is the time in range, TIR, which is 70 to 180, TAR, which is more than 180, and TBR, less than 70%. So in a nutshell, TIR is very good, your glucose control is very good. TAR is very good, up, your glucose control is very bad. And TBR less, that means patient is feeling or facing the hypoglycemia frequently. There are different types of metrics. These metrics is very important when we are interpreting a CGM reports. These are the different types of CGM devices available in India. Now the question in Indian perspective, in whom we will use this CGM? Actually all type 1 patient, type 2 patients who are on multiple OHA or OHA plus insulin, and in the gestational diabetes patient, we can use this CGM. Now what study? The role of the CGM in the glycemic control of the diabetes in the primary care, a study conducted in the Asansol Raniganj coalfield belt. I have presented the study in the IDF Bangkok 2025. Now the research methodology to assess the effectiveness of the continuous glucose monitoring system, improving the glycemic control among the diabetes patient in the primary care setting compared to the traditional SMBG. To determine the impact of CGM on the frequency and severity of the hypoglycemic episode in the patient with type 1 and type 2.
and evaluate the patient-reported outcome, related quality of life satisfaction with diabetes management, overall health improvement among the users of CGM systems. Now method, it's a randomized control trial conducted on the 100 patients with type 1 and type 2 diabetes across the 10 primary care centers in the Asansol and Raniganj. Ethical clearance was taken. Participants was randomly assigned to the CGM group and SMBG group. With group baseline measurement include HbA1c level, frequency of the hypoglycemic episodes, and patient reported outcome on the quality of life. Follow-up assessments were done at 3, 6, and 12 months. So 4th time SMBG was done. The selection of the participant, the study involved 100 patients, I have already mentioned, with the 10 primary care clinics. It includes both type 1, type 2 patients. Participants are randomly assigned to the CGM and SMBG group. The baseline measurement was HbA1c, episodes of hypoglycemic event, and the patient reported outcome of the quality of life. Now the follow-up assessment. These were done in the 3 months, 6 months, and 12 months gap. Now what is the result? Patients in the CGM group demonstrated a notable reduction in the HbA1c level compared to those in the SMBG group. Especially CGM group experienced reduction of 1.2% HbA1c level compared to the 0.6% in the SMBG group. The fewer hypoglycemic episodes were reported in the CGM group compared to the SMBG group. The CGM had 1.8 hypoglycemic episodes per month, whereas in the SMBG group it was 3.2 episodes per month. Now the improved quality of life, patient reported outcome from the trial revealed a higher satisfaction and improved quality of the life among the CGM users compared to those in the SMBG group. This qualitative improvement suggests that CGM can positively impact the daily lives of the patient, providing more reliable and less intrusive monitoring, thereby enhancing their overall satisfaction and quality of life. This is the comparison of the mean HbA1c level and hypoglycemic episode between CGM and the SMBG groups. Now the conclusion, the CGM system signifies the improved glycemic control to reduce the hypoglycemic episodes in the primary care settings. There are several evidences, like evidence in the Diamond study, several meta-analyses published in the New England Journal of Medicine. But there are few areas like in the critical care, it is not 100% reliable. We should care of the different types of patient is in shock or in the vasopressor, etc. There are different types of recommendations from ADA, both in type 1, type 2, patient with CGM, GDMs. We can use this. There is recommendations from the RSSDI 2024-23 guideline, even 2025. I am the part of the CGM clinics. There's a type 1 diabetes, all patient, type 2 diabetes on MDI or insulin pump, we can use the CGM techniques. So the take-home message is valuable beyond the specialty care and can be initiated in the primary care, strongly recommended for type 1 and insulin-treated type 2 diabetes or the patient on the multiple OHA, detect silent and nocturnal hypoglycemia and improve patient safety. TIR is the key metric complementing the HbA1c, guides insulin titration and personalized lifestyle modification. And this is, for your reference, it was published in the IGTD journal, January 2025. Thank you everybody for your patience hearing.
Very nice, Doctor. Actually, one thing is that regarding your
Hello.
Your 100 cases.
Yes.
100 cases you have been studied.
Yes.
Among them, how many were type 1 diabetes?
Sir, type 1 diabetes patients was 11 patients. 11 patients were type 1 diabetes.
So what was the result, in comparatively, what was the result of this part? Because the number of cases, and that means what you were saying that. So the same results were found over here also, that part reflects it? The CGM is definitely...
CGM is reflecting the hypoglycemic episodes is more in the type 1 diabetes patients, those who are on multiple dose of insulins, compared to those patients on the single or insulin and OHA in type 2 diabetes.
Sir, how do you correlate with our OH, occupational health, how it is correlating this subject with this?
Definitely, sir. Now diabetes mellitus is very much related to the occupational health because the patients living in the coalfield area, their lifestyle, their work pattern is such, this is very much precipitating factor for the type 2 diabetes. And if they are developing type 2 diabetes, we see lots of patients, they are unaware of how to manage the diabetes. They develop the long-term complications of diabetes, heart attack, renal failure, that leads to a significant mortality, morbidity and expenditures to the Coal India or any subsidiary also.
Have you studied their work profile? What is
Yes,
their
sir,
job?
definitely. Once the patient was selected, their questionnaires were studied. What is their occupation? Is they sedentary or they are working? Whether they are diabetes for how long duration? What medicines are they are taking? What insulin they are taking or not? All the history was taken. The pro forma was given.
Thank you.
Thank you, sir.
Now, Dr. Arijit Banerjee, you are invited for your topic.
So may I start? Respected judges, seniors and my dear colleagues, today I'll present a paper on evaluation of utilization of hospital management system among healthcare workers and patient experience at Sanctoria Hospital. So hospital management system are increasingly being deployed to enhance the efficiency, continuity of care and patient experience across public sector hospitals. Sanctoria Hospital implemented it in 2022 October. However, systemic evaluation of its utilization among healthcare personnel and experience of the patient remains limited after 3 years. So if you see digital transformation at Sanctoria Hospital between 2022 to 2025, where it started as a meager number of 239 in the fag end years of 2022, we picked up to register patient visits of 32,000 in 2023, and that kept on going at a steady rate. Amongst that, OPD patients were 72% and the rest were emergency and inpatient. So there was a total imbibing of the system we had picked up between 2023 and 2025. So my objective was to assess the overall usability using a system usability score and to compare it across the different stakeholders and identify the key facilitators and barriers influencing the use of HMS system. Also, the patients who receive care through this HMS-enabled outpatient and inpatient processes were also evaluated using a patient satisfaction questionnaire. So it was a cross-sectional observation study spanning 3 months, and the sample size was 120 participants. Statistical analysis was done accordingly, and ethical consideration was totally voluntary with informed consent. So over the last 3 months of 2025, few stakeholders like doctors, nurses, healthcare personnel, and pharmacists were enrolled. Also, the patients' feedback were taken, and they were analyzed using the 2 different questionnaires for healthcare personnel and patients, and they were analyzed qualitatively as well as quantitatively. Coming to the baseline characteristics, doctors made up 40% of the respondents, nurses 42.6, pharmacists 10.6, and the registration personnel made up of 4% accordingly. Overall, the SUS score was in the good range of 71.9, and 45% of the users rated it as excellent, which is very much acceptable and at a good rate. Coming to the comparison of the stakeholders, the registration staff registered it as 100%. Usability, the pharmacist was healthy at 82%. Nurses said that the usability was satisfactory at 76.8%, whereas the doctors reported the usability of the HMS system as 64.6%. When I compared it between the stakeholders, and there was a significant difference between what the registration and the pharmacist was using it and the satisfaction of the doctors, indicating that it is highly effective for modular tasks like dispensing medicines and registering of the patients, but when doctors spent so much time in the clinical modules, it was giving some disruptions. Then we evaluated whether the clinical experience was impacting the HMS use, whether the old veteran, highly experienced clinicians was not adapting to use the HMS, and this myth was totally broken. What we found was more than 66% of the workforce of the healthcare personnel were experienced more than 10 years at Sanctoria Hospital, and there was no statistical differences between those who are low experience or a newly entrant compared to a veteran doctor. Coming to the HMS use, it was well imbibed in the system, and the usability scores climbed as the user spent more time with the system, indicating that 93% of the personnel had used HMS for more than 1 year. Coming to the frequency of use of the HMS system and its impact. People used the HMS frequently and training part. So overall, on-the-job training was 57%. Formal classroom training was given at 16% of the participants, and 11% received no training at all. When I compared with the SUS score of the training received, it was not statistically significant. However, the formal classroom training was 82%. Satisfaction was very high compared to those who did not receive any training of formal kind. This 22.5% gap is correlates with the success. Then coming to the qualitative analysis, when asked about what are the advantages of the HMS system, they easily told that 15 frequency measurements were regarding the documentation. It reduced paperwork, reduced manual work, the record keeping improved, documentation improved, efficiency and time saving was there, and it was very user friendly, and accountability and transparency was maintained. So the core benefits centers on the documentation and the speed, as evident from this word cloud. Few challenges were faced. 21 times the healthcare personnel reported network and server down issues, site lag not running smoothly, system lag, slow performance. There were 4 instances of mention of technical complexity, and data loss and auto logout was one of the highlights that doctors mentioned, especially in the past illness section, where the information was auto-deleted due to refreshing of the network. There are also a few issues regarding the suggestions. When we asked the personnel regarding what suggestions were there for improvement, majority was infrastructure and stability were the top priorities. Few mentioned more regular trainings were required, and better integration with the lab and radiology, and better fixing of the bugs in the system. Next, from the healthcare personnel, we come to those who actually receive healthcare. Those are the patients. So patients and patient attenders were asked to give a feedback using the patient satisfaction questionnaire, and they gave that the process was smooth and quick for them. The details were entered correctly because it was integrated well into the system, and there was waiting time was also reduced. Coming to the care and transparency, especially consultation and billing part, even complex interactions like billing are being handled very smoothly by the digital interface. So the verdict, they enjoyed the digital system, the patient satisfied regarding the reduced paperwork, and they were preferring the system for future such visits. One of the patients mentioned that the hospital staff appeared comfortable using the system, corroborating with the high adoption rate in Sakhtari Hospital of the HMS. So apart from need for new equipments, the patients appreciated the communication of the doctors and the registration process of the HMS system. Thus concluding that the HMS system has a high institutional adoption of 91%, strong usability by pharmacists and registration staff, and better workflows. However, critical issues like fixing the clinical bugs, stabilizing the infrastructure, formal training, and optimization for the doctors are necessary. Thank you, sir.
Dr. Satyajit, Dr. Arijit, yeah. You are from ECL?
Yes, sir.
Now, in HMS, there is a module, the PME module. Is the PME module being utilized in your subsidiary?
No, sir.
Okay.
Not yet.
And what steps you have taken for addressing the issue of system lag?
Sir, we proposed a local system cache or a memory so that the refreshing or restoring of the memories are available in case of some lag is there and there is no data loss. Imagine a doctor collecting data from multiple charts and investigation reports and entering in the past history, and suddenly the system lags or it refreshes automatically, there is this data loss. So regarding that, there is a restore option or a local system cache memory so that it can be integrated with the center, with the system whenever the internet connectivity resumes.
Sir, do you have the statistics of your hospital management system? Every week we get a chart from CIL. Do you have it? I want to see.
No, sir. The chart from CIL?
As per chart, I have seen that in Saktoria, the registration is very low in compared to the inpatient or why this discrepancy? That's why I am asking you.
So there were more than 94,000 registration in the last 3 years. And on an average, yearly 30,000 registration visits occur every year. So it is one of the topmost hospitals, apart from few others, who are using HMS daily from day-to-day use. And I think it is one of the best institution where the HMS was incorporated and being used in day-to-day basis.
Thank you. Thank you. Dr. China, Surya Narayan.
Hello, good afternoon everyone and respected chairpersons. Today my topic for presentation is retrospective analysis of prevalence of non-communicable diseases among coal mine workers of my area, Vani North area, that is in WCL. I am going to explain through these points: introduction, background, objectives, methodology, outcomes, way forward and discussion. Coming to the introduction, occupational health is the promotion and maintenance of the highest degree of physical, mental, social well-being of the workers in all occupations. Non-communicable diseases are chronic diseases, non-transmissible, and chronic diseases like hypertension, cardiovascular disease, stroke, cancers, and diabetes, etc. What is the global burden of NCDs? NCD is responsible for 41 millions of world's annual deaths, out of which 17 millions deaths are due to premature. And cardiovascular diseases and cancers were the majority of the NCDs. Coming to the Indian scenario, WHO in 2018, NCDs were estimated 63% of all deaths in the country, among which cardiovascular disease is the leading cause, followed by the National Cancer Registry Program 2020, which tells that in males, lung cancer, mouth cancer, and esophagus, stomach cancers are more common, and among females, breast cancer, and followed by cervical cancer. Key non-NCDs among the Indian coal miners. Coming to the respiratory part, pneumoconiosis, silicosis, and COPD, and asthma. And cardiovascular, hypertension, diabetes, and ischemic heart disease. And musculoskeletal, most of our workers were affected with musculoskeletal disorders like chronic low backache and myalgia, etc. And other NCDs like NIHL, visual impairments, and cancers. Background. Mining is very old occupation. Our miners are exposed to fuels, chemicals, coal dust, silica, etc. They were exposed to the most of traumatic injuries, exposure to dust, noise, and mechanical vibrations, out of which the coal workers' pneumoconiosis, silicosis, and NIHL are the notifiable diseases according to the Mines Act. These risk factors like use of tobacco, alcohol, unhealthy diet, and physical inactivity will lead to the overweight, raised blood pressure, raised blood sugar levels, raised cholesterols. In turn leads to cardiovascular disease, cancer, chronic respiratory disease, COPD, etc. These are the modifiable and non-modifiable risk factors. My objective is to assess the prevalence of NCDs among the minors of my area, health promotion, screening, early diagnosis and management. Methodology. I have taken the data from last 2 years, 24-25, from PME and PTED camps which we have conducted. Coming to the periodical medical examination, as per the statutes Mines Act 1952, initial and periodical medical examination and notifies 8 diseases as a notifiable disease. And as per the new OSH code, 29 of such diseases should be notified. This is the data which I have analyzed. These are the outcomes. Hypertension, old cases, new cases. Old cases in the sense the patients who are already diagnosed and kept on treatment before coming to the periodic medical examination. Those are 112 in 24 and 92 in the 2025. And the new cases diagnosed during that period of 2024 is 241 and 291 respectively. This is the analysis. The incidence report in 2024, 241 and 2025, 291 new cases were diagnosed. Overall increase in 20.7% of the NCD burden, out of which dyslipidemia and visual disorders are more common. When comparison to both the years, the hypertension were reduced by regular follow-up, asking the patients to get regular follow-up at dispensaries and PTED screening. Diabetes and defective vision and diminished hearing, musculoskeletal disorders were some of the cases which were surging. PTED camps. These camps helps us to early detection, emergency care and preventive health care. In the PTED camps, we will measure blood pressure, ECG, BMI, random blood sugar, hemoglobin, visual testing and personal health counseling. Apart from this, awareness talks regarding use of PPE, pulmonary tuberculosis awareness, heat stroke awareness, pyrometry and respiratory camps also can be done along with the normal PTED examinations. These are few photographs I am showing of the PTED camps, awareness talks, eye testing for HEM operators and drivers. These are the PTED camps which are conducted in 2024 and 25, 7 and 9 of those. Incidence reports, in 2024, 185 of the employees were screened, and 2025, 404 employees were screened, among which musculoskeletal disorders takes a huge place in the screening. Interpretation and implications. Ergonomics and lifestyle modifications were required. The employees were counseled according to that. And sensory impairments and pulmonary and cardiovascular risks counseling has been done. Way forward. These are the 4 particular behaviors which are directly or indirectly causing to the non-communicable diseases: unhealthy diet, physical inactivity, tobacco use and alcohol consumption. For the prevention, we have to do annual health surveys, occupational health fortnights to screen the employees for a particular period of time, centralized disease monitoring at subsidiary headquarter level. This is the app which I have developed in my area with the help of the system manager. In this, we can see that database for PTED camps and eye examination camp. If we incorporate a employee ID, this is the name and details of the employee, and we have to incorporate what are the habits he is having, and any other remarks we can incorporate here. Coming to then it will take you to the general examination. We have to measure his height and weight. Then BMI will be automatically calculated. We have to record the BP of the person, pulse rate, ECG. Eye examination and color vision was recorded. Thank you.
In one of your slides, Dr. Surya, you had reflected that dyslipidemia, you had 27% of the employees had dyslipidemia.
Yes, sir.
Now, we all know that in PME, we do not have the employees in a 12-hour fasting state.
Yes, sir.
So, was the figure derived from directly from when the patient came to you for PME, or you called them in the next visit?
Sir, the data which was reflected, as per the raw data, I haven't filtered kept any filters. as soon as the patient comes to the PME, the data, the report which was recorded on that so-and-so date was kept in the presentation. But after 1 month, we'll ask the person to come for the follow-up. We'll give a review, we'll do the review PME, and again we will check the cholesterol levels, sir.
Sir, I think you are missing what is the average age of the patient you have detected. First of all, and when we are dealing with OH,
Yes, sir.
we should always document the length of service should
Yes,
be
sir,
recorded.
length of service.
And you have missed those things. That is the age group, the patient's which is suffering,
Yes,
and how much time he has spent with us.
Yes, sir.
This should be documented, sir.
Yes, sir. For that,
Otherwise, this if you study OH in our scenario, it will be a faulty results.
Yes, sir. For that, I have an answer, sir. For PTED camps, we will screen the employees of 51 to 60 years. Those are the age group which I have depicted in this presentation. And for, sir?
You have not given that.
Yes, yes. Understood, sir. Yes.
Then it is not taken.
Yes, sir. Thank you.
Thank you. Pawan.
नहीं नहीं जरूरत नहीं हेलो हेलो चेक हेलो हेलो स्टार्ट हो गया सभाय नमः गुरुभ्यो नमः माई सेल्फ डॉक्टर सी पवन कुमार डेप्यूटी मेडिकल सुपरिटेंडेंट मेन हॉस्पिटल कोरबा statutorily certified in AFIH and certified SHMS auditor. So coming to the vision of Coal India and the Ministry of Coal, which clearly envisages that the zero harm potential. So that is there is a vision which is envisioned by the Ministry of Coal, that is safety first and zero harm potential. And which is clearly mentioned in the DGMS technical circular in 2011 that we should have a safety and health policy, health and safety policy, in which Coal India Limited and its sister concerns, we are having a health and safety policy, occupational health and safety policy of Coal India Limited, which is being adopted by the SECL also as a sister concern. So, if you take the policy is written and signed by the highest authority of the company, like CMD of the company. So, in that signed document, we are having a statement that is comply all relevant statutes. Second point is there will be a progressive improvement in practices and systems related to occupational health and safety. And coming to the safety department and rescue department. So that is in case of safety department, the safety and rescue had evolved over years and over decades, and it had attained the highest level of excellence, including National Coal Mine Safety Portal, Project DZ Coal, and Internet of Things. So many things were connected by internet, and they are having a digital excellence. So my point is here to bridge the gap. I would like to bridge the gap which is existing between the Occupational Health Department and Safety and Rescue Department, which is for the first time has envisioned by the Ministry of Coal through the dated December 2023 document said that the medical officer, occupationally health trained medical officer, should be required to undergo training in safety, health management systems audit. So my concept is to make the old safety management plan into new safety and health management plan in true spirit. So to bring the health or the occupational health, which is traditionally been kept out of the core concept of the mining, to bring it into the internal thing of the mining, so that the safety management plan will be turned into safety and health management plan in true spirit. So this will be the golden link. So this is the rescue and health integration. The missing link is nothing but, so I am also a part of the safety and health management plan, audits were done. But most of the time, these audits were mostly safety-centric. Most of the time, not clearly mentioning the occupational health requirements. So, I would like to make the integrated hazard identification and risk assessment control should be done with the mines manager or their representative with the occupational health representative. Then only it will be then there should be a requirement of a real-time data link. Whatever the safety and rescue department is getting the data, the relevant data with respect to the occupational health has to be integrated with the occupational health center so that it will make a integrated workplace environment. So there is a digital environment will be there. So already the safety and rescue department is at excellence. So if I want to link with the occupational center, I have to first of all upgrade the existing occupational health center. So here the compliance, it is not only about compliance, it is about predictive intelligence. I have to intelligently predict what will happen. So there is something called as heat map. Heat maps will be there. So we will see what is the heat map. And I would like, the main concept is to link the mine working environment to the mine worker's profile so that we can intelligently, digitally can predict what will happen in the coming next 10 years or 5 years. So as on date, Southeastern Coalfields Limited is trying to open the initial public offering. So this will definitely help my company in the reputation and investor attractiveness. So this is a deemed dashboard between the mines safety and rescue with the occupational health so that the occupational medical officer can get the heat maps like this, where actually the heat and noise test on this current period of time or 7 days back or 1 month back, where actually the risk is more, hazard is more. So here, so before going to the depth, we should have a SWOT analysis, that is a strength, weakness, opportunity and strength. Yes, I am having the opportunity of the strong visionary leadership under my CMD, SECL, Sri Harish Dohan sir, and we are having already statutorily aligned that we are having the statutory workforce on my hand, and also we are 100% digitally ready, my company is ready, and definitely I am having some issues with the in-common manpower gaps and infrastructure variability is there. So already Coal India Limited Occupation Health Services Wing had created so many directions and issued directions time to time, and this is one of the direction which had clearly mentioned what is required in a OHC. So I am having a paper also. A document is with me. So if I take a rough manpower and infrastructure analysis within SECL, so this is my infrastructure and manpower. I am having statutory FIH, DH and ILO and SHMS auditors on my hand, and definitely I am having a variable manpower gaps in the case of technicians. And this is the critical infrastructure requirement. So this has been collected from different subsidiaries, including the last purchasing price and jump contract number, and whatever the subsidiary and the total value has been clearly mentioned. And we are ready with the data. And whether this is really possible in SECL, whether this is possible in SECL, yes, it is definitely possible, because my friends worked in different subsidiaries. For example, you take the ECL Kalla Hospital, Eastern Coalfields Limited Kalla Central Hospital is now ready. It will be the first hospital in total India which will be integrating the DICOM with the PACS integration, and in tomorrow or day after tomorrow, they are going to read the digital X-ray as per the ILO standards and DGMS, DG-FASTLY guidelines. So this will be the first hospital who is actually ready. So yes, we are having an audiometric room in WCL, Rajiv Ratan Central Hospital. My friends had made the modular gypsum-based acoustic panel system, and they are creating excellent results, and they are as per the maximum permissible ambient noise limits, British guidelines that is 30 decibels and American guidelines 25 decibels, they are ready. And even digitalization, whether it is possible, it is possible. In Main Hospital Korba, Southeastern Coalfields Limited, they had made an in-house software, and the third-party software is present in so many other subsidiaries. SECL, WCL, other subsidiaries are already having external quality assessment for the laboratory, and in-house manpower capacity when it is coming to BCCL Central Hospital, ECL hospitals, they are already having the structured departmental approved courses they are doing. And CIL OHS have given a guideline to utilize the services of the specialist in the empaneled hospitals. Definitely I can use them. So this is the model formula, and these are my recommendations to transform to administrative approval and digital health integration is required. So these are my references. These are my references for my study. Thank you.
As a part of AI and ML, can you suggest some measures for improving the acceptability of PPE in mining workers?
Sir?
To improve the acceptability of PPE in mine workers.
BP, sir.
PPE.
PPE. Sir, training, sir. Training is very much important, sir. Training. Structured trainings are very much important to change the behavior of the person who actually is using the PPEs. For example, if you take the masks are most of the times they will be not using the persons. So if I'm explaining what actually the risk will happen in less time, and then I think they will definitely accept.
Training is okay. Now, how do you know that a person is using or utilizing the PPE while at the workplace?
Sir,
there should be when we are talking about AI and ML, we should have a real-time monitoring.
Yes, sir. Real-time monitoring.
It has been found that in certain industries, they use sensors in helmets and all.
Yes, sir.
So these things can be incorporated also.
Sir. Yes, sir. Thank you, sir.
And you have mentioned regarding the rescue along with the safety.
Yes, sir.
How you are going to incorporate rescue with these health centers?
Sir, mines rescue starts from the accident. So if there is an accident, number of times accident has happened and they came to know that this is one more new hazard. So this is one more risk. So this is one more new risk rating. So depending upon the rescue, what actually the cause of the rescue, why you want to do the rescue for the particular person, what actually had happened, if you can understand, if that data is getting to the occupational health medical officer, I think occupational health medical officer can understand what are the newly evolving risks and hazards and what are the new risk ratings. So definitely it will be helping for me, sir, if I am sitting at the occupational center. Sir. Okay, sir. So I had asked in the morning, sir, photo is from which hospital? Sir. So that ECL hospital is having complete DICOM compatible, sir. That will be the, as per my knowledge, it is the first of the kind in India. Sir.
We move to the next speaker. We move to the next speaker. Any discussions can be sought after later.
Dipti.
Good afternoon, everyone. I am Dr. P.C. Dedipti, Deputy MS, Main Hospital, Korba. Today, my topic for presentation, role of occupational health surveillance in early detection of non-communicable diseases. Introduction, non-communicable diseases are emerging leading cause of morbidity and mortality worldwide. In India, nearly 2/3 of deaths are attributed to NCDs such as hypertension, diabetes, cardiovascular diseases, chronic respiratory diseases, and obesity. Traditionally, occupational health focused mainly on occupational diseases. However, today the workplace has become a critical platform for early detection of NCDs. A holistic screening approach ensures comprehensive evaluation beyond disease detection, improving prevention and workplace safety. Early detection of risk factors, primordial prevention, detection of undiagnosed hypertension, diabetes, obesity, cardiovascular diseases, visual defects, and hearing defects. Prevention of complication, reduction in sickness absenteeism, improvement in quality of life. Methodology, a retrospective record-based occupational health surveillance study was conducted among 300 employees using medical records from past 5 years to assess burden of NCDs and related risk factors. Health records maintained at Occupational Health Center, including PME reports, specialist referrals were reviewed. Exclusion criteria, workers with known history of hypertension, diabetes, cardiovascular diseases or other chronic NCDs and currently treatment were excluded to focus on early detection among apparently healthy individuals. At our OHC, PME includes BP monitoring, RBS, visual screening, spirometry, audiometry, ECG, chest X-ray, routine blood investigation. Based on documented findings and risk groups, workers were stratified into low risk, medium risk and high risk groups to identify individuals requiring closer surveillance and preventive interventions. Observation, holistic occupational health surveillance detected NCDs, risk factors and functional impairment among asymptomatic workers, revealing a hidden disease burden, increased cardiovascular consistent with the iceberg phenomena. We categorize workers with newly diagnosed NCDs into hypertension, pre-hypertension, diabetes mellitus, pre-diabetes mellitus, cardiovascular diseases, visual impairment, hearing impairment and overweight. Risk stratification, which usually include the total number of workers, was 300 and we categorize the risk category into low risk, moderate risk and high risk. Low risk was healthy workers, moderate risk at risk and high risk was diseased workers. The clinical discrimination, BP for the low risk and RBS was normal. For the moderate risk, we categorized into pre-hypertension, pre-diabetes and there is a risk factors of their lifestyle. And high risk was newly diagnosed hypertension, diabetes, BMI more than 30. And the number was for the low risk was at 81, moderate risk was 126 and high risk was 93 with percentage of 27, 42, 31% respectively. This is the risk stratification of 300 workers in the representation of bar diagram. Of the 300 workers screened, 73% were either moderate or higher risk for non-communicable diseases, while only 27 were classified as healthy. Burden of hidden disease, iceberg quantification. The finding of the present study demonstrate the iceberg phenomena of disease, where 31% of the workers constitute the visible, whereas larger proportion, 42% were in the pre-disease state, representing the submeasured portion. This indicates a substantial hidden burden of NCDs among workers. Why focus on NCDs in the workplace? Most of the workers spend 1/3 of life at work. Lifestyle risk factors like sedentary habits, stress, shift duties, poor diet, tobacco use, and lack of exercise are common. Thus, the Occupational Health Center become the first point of structured occupational health surveillance. Occupational health programs play a vital role, not only early detection of NCDs, but also in prevention. Primordial prevention aims to prevent the development of risk factors through workplace wellness initiatives, while primary prevention focuses on controlling existing risk factors to prevent disease onset. Functional impairment detection through surveillance. Occupational health screening additionally identified previously undetected refractive errors requiring corrective glasses, early noise-induced hearing impairments among workers exposed to high noise areas, dyslipidemia associated with ECG changes suggestive of early cardiovascular risk, mild to moderate reduction in lung volume, almost lung dust-exposed workers. These findings indicates the presence of subclinical functional impairments that requires monitoring and preventive information. Occupational relevance. Non-communicable diseases and or not merely lifestyle disorders in industrial settings, they are significantly influenced by occupational risk factors. Workplace exposure, shift work, heat stress and sedentary, they might affect on the biological effects. The outcome was non-communicable diseases like diabetes, hypertension and obesity. This is the occupational health relevance and preventive action cycle. Records review, we categorized into risk stratification and targeted preventive interventions, workplace preventive measures and outcome. Role of occupational health physician. Occupational health physician plays a vital role by conducting systematic occupational health surveillance, risk stratification, health education and lifestyle counseling, ensuring compliance to treatment, coordinating with management for wellness management programs. Conclusion, this study highlights that NCDs are significantly prevalent among workers and are influenced not only by individual life factors but also by occupational exposures. The findings reinforce that NCDs in industrial workers are not merely personal health issues but occupationally modulated conditions with direct implications on safety, productivity, absenteeism and long-term workforce sustainability. Early identification through structured occupational health surveillance, risk stratification and targeted workplace intervention can substantially reduce disease burden and prevent complication. Therefore, integration PME with comprehensive occupational risk assessment is essential for effective NCD control in mine settings. This is our occupational team. In industrial medicine, prevention of non-occupational disease is not just clinical responsibility, it is an occupational safety mandate. Thank you.
In your study,
Sir.
You have reflected that NCDs are more than 70% of the population, the study population.
So we exclude, the exclusion criteria is also there, sir. I can diagnose here only newly detected cases, sir. Only newly detected people.
Now what further course of action you took?
Sir, for the low risk cases, low risk category, annual health checkup was maintained, sir, and and for moderate risk, lifestyle modification and 6 months health checkup. And for risk people, already diagnosed people, the regular follow-up, health promotion and health awareness programs.
Because we have seen in our industry that when you ask those people to come for regular follow-up, they seek attendance for that day. And this is a major issue across all mines. Management do not allow attendance to be given.
Also the
but as being a doctor, you require to have a follow-up of these patients.
So
how do you manage in this?
It is one of the limitation of this occupational health surveillance study, sir. Regular follow-ups means we want to promote the health education in worker place only, sir.
Actually, as per you have mentioned that on the role of the occupational health physician, that is number 3 and 4 and 5. These are in your part. After this study, you are supposed to take up that part. You see, the 3, 4 and 5.
Yes, sir.
The counseling, compliance of treatment and management of this part. These 3 factors you have to implement.
Yes,
so
sir.
you have to look after those things. That how far you are successful with this?
Sir, for coordinating with management for wellness management program, the empanel hospital camps we can conducted in our occupational health center by empanel hospital doctors for a spirometry, for a pulmonology department and ENT department, and general awareness for mainly mental stress awareness programs for through third parties, empanel hospitals.
Thank you.
Thank you, sir.
I now request all the speakers of Chairman's Award to come on stage and request our judges to felicitate them. Dr. Kartik Thokala, Dr. Satyajit Roy, Dr. Arijit Banerjee, Dr. K.C. Suryanarayana, Dr. C. Pavan Kumar, Dr. PC Deepti.
I can understand this chairman's awards कि how MBBS के दिन याद आ जाते कि इतने वाइवा होते थे, यहाँ तो स्टेज पे वाइवा देना पड़ रहा है, बट इतना सीरियस होने की जरूरत नहीं है. Now we have 3-4 very exciting talks. Very little schedule change because our one guest speaker has a flight. Please. So now we all know that artificial intelligence is deeply dominating the whole world. Recently we have seen such a AI Impact Summit, and lot of things were health was also included in that. So next lecture we have on this artificial intelligence protecting India's strategic workforce in preventive healthcare, especially for PSU. Then we will have a talk on fatty liver disease. Then we will have robotics in surgery, what we are seeing in Chhattisgarh. So please stay with us for next few sessions, which are very impactful sessions. करतल ध्वनि से हमारे इन सभी पार्टिसिपेंट्स का जो कि यंग डॉक्टर्स हैं कोल इंडिया के, एंड दे हैव ट्राइड देयर बेस्ट डूइंग स्टडीज एंड पुटिंग देयर इन एनुअल कॉन्फ्रेंस.
I request Dr. Ashok Singh sir to felicitate our judges. Moving on to next session, I welcome Dr. Vineet Sikka sir, Group Head Growth and Strategic Alliance, Apollo Hospitals, Chennai. He will be delivering a talk on protecting India's strategic workforce, AI-enabled preventive healthcare for PSUs. To chair this session, I would like to invite Dr. Amit Soni sir and Dr. Sudha Ram ma'am on stage.
Good evening. I'd like to welcome Dr. Vineet Sikka, Vice President, Growth and Strategic Alliances, Apollo Hospitals, Healthcare Strategy and Institutional Partnerships. He has 18 plus years across hospitals, health tech, and institutional healthcare. He leads Apollo's B2B and institutional healthcare partnerships with corporates, insurers, and public sector. Co-creator of large-scale technology-enabled workforce and population health programs. Expertise in AI-led risk stratification, preventive health, and value-based care models. He has a master's in healthcare management from the University of Aberdeen, IIM Indoor Certified, NABH Internal Auditor, and Six Sigma Green Belt. Welcome, sir.
Thank you. Thank you so much, ma'am, for that introduction. And first of all, I would like to thank all the participants just before me. I think after lunch, that was quite an impactful session for all those young leaders that we have in Coal India, talking about what innovations you are trying to do internally, which was very impressive. And that actually matches to a lot of core values of Apollo. And Apollo is a 43 years old organization. We are about to be 57 years later. You are already 50. So a lot of work that you have done so far. Apollo is equally complex. So I'll just take you through that and then we'll move into what we are doing in Apollo as well. So this is the overall ecosystem of Apollo that you see now. It has different layers. And as I could see in the previous presentations, innovation and technology is actually the core of any large organization. And Apollo is one of the largest hospital chains, not just in India, but in Southeast Asia. With different layers of our ecosystem, if you can see. There are some 20 odd entities that we have apart from hospitals who actually contribute to a lot of our ecosystem. And to manage such a large ecosystem, it is impossible to work without technology. And all these entities that you see of Apollo talk to each other in various segments. As you see on the extreme left, these are 3 innovation and research organizations which are Apollo entities, which collects all the data from various Apollo entities who are working on wellness, primary, tertiary, and secondary care treatments. We collect all this data, and that data only helps us build that layer of technology, and then above that, the layer of AI, which we are now using. So AI in healthcare is not new, by the way. We have been using it through technology while treating patients, and a lot of these learnings that have come from this data is now actually helping us create some new models. So what is it that we want to do? So preventive health, everybody's talked about. I'll not talk about NCDs more. I think everybody know about it, that it's a serious issue with us now. But more serious that we see right now, and we have published this in our national health report also, with Apollo doing health checks for the last 40 years. We publish that report every April. And these were the common findings. The NCDs obviously are now hitting people in 20s and 30s, not just in 40s and later. And we also see that a lot of individuals have fatty livers now, which are non-alcoholic. That's a new thing that I think for the last few years we are finding that very often in young people also. So these were the findings, and also 80% of the population is vitamin D deficient. So the first part of this, which is the standard health checks that everybody does in the country today, after that, the 3 steps that I'm talking about are where we are investing a lot of money also, and a lot of energy, and our teams are innovating as well. So the health risk assessment has been a very old tool, but personalized to a kind of individual at a different, what kind of age group he is, what is his family history. There is a designed health risk assessment that we do based on that characteristics of that male or that individual. Accordingly, there is an AI-powered predictive risk scoring, which comes and predicts for your cardiac events. So AI CVD is one of our latest model that we used, along with the pre-diabetes, another one that we use. These are the scores that are based on your health checks and your risk assessment together. And based on these 2 parameters, you can actually predict your cardiac health for the next 5 years, 10 years also. So this is something which has helped us kind of cover a lot of our prediction towards the future health of these individuals, young individuals also. CT calcium has also been one of the, earlier people used to do a lot of CT angiography also. That is an expensive test. Now CT calcium is a low dose test. The radiation is equal to an X-ray. So it actually gives you that calcium deposit in your artery, and gives a good prediction. And with using AI CVD, we are able to predict when can be the next heart ailment or episode that can come. Now, guided path to wellness. This is our entire program on mentors. So I think there was a last question to the last participant, that how will they manage once they get this information. I think health mentors through technology. So obviously it is impossible to follow up with people, and people like we Indians, and we don't follow a lot of our routines as well. So
without technology and that triggering system, I don't think manually we can do it. And if we have those regular triggers and some mentors and health and lifestyle managers who are managing it with the team, who actually want to reverse their communicable diseases like diabetes and all, it is possible. So that is the last bit that actually is very critical in reversing and the behavior change for lifestyle diseases. So this is one of the reports I just wanted to show. Then we move to what we do in terms of a new invention that I'll come on the next slide. But this is something that we are doing for all our large partners or corporates. With PSUs, we have not tried it yet, but this is one of the FMCG partner where we screened on the left side top, you will see 33155. So 3,155 people we screened with certain kind of health checks. In the previous slide, I showed you those 4 steps. And we were able to create this kind of data for that company. And this actually guides them further to create these wellness programs which are dedicated for that particular segment of employees. Another telecom company, we did the similar exercise, and that company is pan-India present, and we found a certain segment of employees in Rajasthan had a lot of kidney ailments. And we could zero down onto what kind of wellness program we need to run for them. Similarly, we have done it for IT companies also, and we are planning to work with Coal India team in the central office also to figure out a way to create a national-wide report for you like this. This is something we're trying. Now, with Apollo, one thing is critical. So we are very wide, and we have so many entities. There are different entities working with different kind of people. This is what we are trying to do for us also, and also for our clients, that we create one entry for anybody who wants to come to Apollo. So today we see that there are different apps, different companies are working on it. So we are trying to structure into one entry, and with a very easy way of employee and OTP, email and OTP verifications. If you see on the extreme right, there's a very simple interface which will allow you to put your Coal India email ID, and an OTP will go to your email, and you can simply log in, and you can get a web interface or an app interface, and you can get into the entire Apollo ecosystem of you want to book your health check, you want to book a lab test, or you want to order a medicine, or if you want to even book an OPD appointment in our hospital, you want to search a doctor, all those things are available through this interface. And how this interface looks like, I will show you in the next slide. So before I go to the video, so we have now developed an AI tool called Apollo Assist. So Apollo Assist is basically for patients also, for doctors who are referring patients to Apollo. A lot of our PSU partners today, all these doctors, they can search by doctor name also, and they can search by a specialty also. And they will be able to identify a certain list of top specialists of Apollo in different locations. A lot of people from Raipur or a lot of people from Bilaspur also come to Hyderabad for treatment, and various other major cities for treatment. So all that you can do from here. So I'll quickly move on. This is some kind of utilization that has already happened through this tool, but I will now move to the video. So just quickly. Oh, sound.
Faster, smarter healthcare is evolving. Faster, smarter, simpler. For over 42 years, Apollo has been India's trusted name in healthcare. Now, that legacy meets the power of AI with Apollo Assist, an innovation made in India, built for the world, turning complexity into clarity. Apollo Assist decodes the complex medical reports in seconds and helps navigate with the right care. That's world-class technology, delivered with Apollo's unmatched expertise. Not sure which doctor to see? Type one word, describe your symptom in detail, or even use everyday terms. Apollo Assist gets it. Whatever the language. Vaituvali, Kadupu Neppi, Pet Dard, and connects you to the right Apollo specialist. Booking healthcare shouldn't take time. It should save time. With Apollo Assist, just search, select, confirm. Your appointment is booked anytime, anywhere. Redefining efficiency in healthcare access. Here's the real game changer. Apollo Assist speaks 10 languages. From Hindi to Tamil, Bengali to Marathi, Punjabi to English. Type it or speak it. It just gets you. No need to carry a stack of reports each time. With Assist, simply upload your documents in any format. Securely stored, summarized for quick understanding, and instantly accessible to your doctor at every visit. Powered by AI, rooted in Apollo's legacy. That's Apollo Assist. Healthcare reimagined. Experience it now at apollohospitals.com.
So this is something which is practically going live, and in a lot of our cities it is already live. You can go to our website and there will be a tag on the right side, Apollo Assist. But what we are now doing is we are building it customized way with partner like Coal India and other large partners, where you can actually use it. Your retired employees can use it themselves. They don't need any help, and your serving employees and the doctors that are working with these employees for their treatment and care can use this for search of doctors directly, search of through specialty, through symptoms, anything. They can employees can even just upload their reports and they will get a recommendation which kind of doctor they should see. So this is now exclusively available for all our patients, but for corporates and B2B institutional engagements, we can customize it based on your needs. So thank you so much for giving me time. Happy to take any questions if there are any. Thanks.
Thank you, sir. Now I request our chairpersons to felicitate Dr. Vineet Sikka, sir. I request Dr. Shrutidev Mishra, sir, to felicitate our chairpersons. For the next session, I welcome Dr. Devinder Singh, sir, consultant, Apollo Hospital, Bilaspur, to talk on demystifying fatty liver disease. To chair this session, I invite Dr. Y.S. Parihar, sir, and Dr. M. Tikas, sir, on stage.
Do I have to stand on this?
No, sir.
This is too tall.
Good afternoon, everyone. And now we are going to a very important, nice topic after our good lunch. And I am privileged to introduce Dr. Devendra Singh for his topic on demystifying fatty liver. He is a senior consultant and HOD gastroenterology at Apollo Hospital, Bilaspur, since inception of Apollo Hospital, that is 2001. He is MBBS, DNB in General Medicine, DNB Gastroenterology, Sir Gangaram Hospital, Delhi, Fellow Society of Gastroenterology, Endoscopy, India, 2018. Over 20 years of experience in gastroenterology, senior consultant and HOD at Apollo Hospital, Bilaspur. Past President, IMA Bilaspur and ISG MPCG Chapter. Former Assistant District Governor, Rotary District 3261. Recipient of IMA State Branch President Award 2015 and Academic Excellence Award in 2017. He has published many papers nationally and internationally. With this brief report, I welcome Dr. Devendra Singh for giving his presentation. Thank you.
Thank you, Dr. Parihar, sir, for your kind words. My compliments to the organizing team, Dr. Mishra, who has been like a younger brother since my college days, Dr. Jain, Dr. Sarkar, for conceiving and putting up such a brilliant show here. Well, I have been assigned to speak about a ubiquitous kind of problem, that is fatty liver disease. And since there are so many unanswered questions as to how to go about it, I thought, why not demystify the whole concept? Well, this mystery called fatty liver, I'm sure about half of the people sitting in the hall also must be having some sort of fatty liver. Well, is it just fat or the proverbial hat vying for attention, ki zara nazar inayat idhar bhi? Now, what it is asking for? Well, it is asking for attention to systemic metabolic dysregulation, sorting out metabolic abnormalities involved. As we say, fatty liver, to be more precise, steatotic liver disease has several groups. I will be talking about this one, the metabolic dysfunction associated steatotic liver disease, which can be either a bland fatty liver or steatohepatitis associated fatty liver. Then there is another category which is MAT ALD, like MASLD, with someone who has been drinking significant amount of alcohol. Then there is another category which has no metabolic dysfunction associated, has simply alcohol-associated liver disease, and certain specific etiologies like drug-induced, monogenic, and miscellaneous, and few cryptogenic also might be there. But I'll be basically focusing on this part. Well, earlier it used to be too simplistic and was not inclusive of all. It used to be when once patient has more than 5% of hepatic steatosis and other secondary causes of liver disease, fatty liver disease have been excluded, then that person used to be called as NAFLD. But now this definition has somewhat changed. Now we have hepatic steatosis more than 5% of the cells involved. In addition, we have to have type 2 diabetes, other metabolic scenarios, metabolic dysfunction scenarios like type 2 diabetes, overweight or obese, and metabolic risk abnormalities. At least 2 out of the 7, like high waist circumference, blood pressure more than 130/85, plasma triglyceride more than 150, HDL less than 40, pre-diabetic state, HOMA score to be high, but higher than 2.5, and HSCRP more than 2. 2 out of these 7 have to be there to call it MASLD. Now, one thing which is always present in MASH is an ongoing chronic inflammation. Now, this inflammation drives the patient from simple steatosis to ballooning inflammation, and as it does so, the patient's liver progresses from no fibrosis through to F4 stage, that is cirrhosis of liver. Now, why are we so much concerned about NAFLD or MASLD? Because it is associated, now this was a study published in an article in the Nature journal, and it showed very clearly that it is associated with increase in all-cause mortality. That is the concern. And how does it cause? We'll come later. Now, the concerning thing is that the prevalence is increasing worldwide. Now this increase is in parallel with obesity and metabolic comorbidities like insulin resistance, dyslipidemia and hypertension. About 1/3 of the world population is having NAFLD. In our own data from Apollo Hospital Bilaspur, we have seen that there has been 300-fold increase in the incidence of fatty liver disease when we take into consideration the master health checkup cases. The ones in 2012 had just 18% incidence of fatty liver on ultrasound. In 22, the incident had risen to 56% of all MHC cases. Although the true prevalence is difficult to determine, but it is for sure that higher grades of fibrosis, that is F2 and F4, that is compensated cirrhotic stage, are constantly increasing. And this increase of hepatic decompensation, this will lead to incidence of increased hepatic decompensation, HCC, and death due to NASH. And it is likely to increase by up to 3 times by 2030. It is already a leading cause of liver transplant in women of all age and men more than 65 years of age. Let's come a little bit briefly to the natural history of NAFLD. Now, if we consider these 100 as this number, those having NAFLD, about 30% of human population would be here. About 90 to 95%, like majority will have simple steatosis and they will remain stable throughout their life. But a very small percentage of cases, without developing cirrhosis, they run the risk of developing cirrhosis of liver. It is associated with type 2 diabetes and cardiovascular disease in a bidirectional way. A small percentage, that is 5 to 10%, will go on to develop about non-alcoholic steatohepatitis, of which about 40% will have significant fibrosis, of which 30% will develop cirrhosis. 5 to 10% will decompensate, and 1 to 2% will develop HCC. This is a very huge number when we say. Let me simplify the whole magnitude of the problem. Now, if we consider world population to be roughly 8.1 billion, NAFLD population, that is 25%, I'm taking a little lower, less than 30%, I'm taking 25%. That means 2 billion people, that is 200 crore would be having fatty liver disease, of which NASH will be 20 crores. Fibrosis will be significant fibrosis will be having 6.5 crores. 2 crores will have cirrhosis, and decompensation will be 20 lakhs, and hepatocellular carcinoma in about 2 lakh per year. Indian population is about 17.75% of the whole world population, global population. So that way, we'll have annually 31 lakh people having cirrhosis and 30,000 hepatocellular carcinoma every year. This is a very big number, and our healthcare system is not geared to meet these numbers. Now, if there is such a big concern, that how should we get alarmed, and what should alarm us? The most important prognostic factor in NAFLD or MASLD is the liver fibrosis, and it has been clearly recognized as the main predictor of poor hepatic and extrahepatic outcomes. The other determinants of poor outcome are NASH, and the alarming thing is that liver-related morbidity, mortality, and non-hepatic malignancy is increased even in the absence of significant fibrosis. That is another concerning thing. So we always, when the patient walks into our chambers, we have a unique opportunity to transform the patient's life. And let's begin with the history, physical, and labs. That the lab should include a complete liver panel, counts, diabetes profile, autoimmune profile, transferrin saturation and Wilson disease profile to rule out other causes. I will not go into details of other examinations part. So once we have ascertained that the patient is having fatty liver disease, of which the ultrasound is the most common and easily available tool to find out patient has fatty liver. The liver enzyme per se have got very poor sensitivity and specificity, but ultrasound, if it has to see any degree of steatosis, it still has a reasonably good sensitivity and specificity. CT scan without contrast has got slightly higher sensitivity and specificity. It is getting discharged. MRI is certainly better. MRI PDFF is better in both forms of sensitivity and specificity, and is much better tool to confirm and quantify the level of steatosis. MR spectroscopy is even better if the cutoff is less, taken more than 33%. But liver biopsy remains the gold standard. However, there is a problem with liver biopsy. The problem with liver biopsy is it is a gold standard, but it is an imperfect one. It is invasive, painful, expensive because patient has to get admitted. Sampling variability is also there. There is observer variability, and expertise is not widely available to perform it. So for population, with the kind of magnitude the patient, this particular disease has, at population level, it is not relevant to perform. To match the results of liver biopsy, we have a set of non-invasive tools. There are a large number of tools, but I will be pointing only those ones which are doable and can easily be done in the clinic level. But an ideal NIT has to be safe, simple, and it should be reproducible as well, and should be inexpensive. There are online calculators available which easily interpret the level of fibrosis and make our life easier. Of the commonly available non-invasive tests which are available to diagnose and predict the fatty liver status, the two common ones are FIB-4 index in the a simple clinical or laboratory score, and among the imaging, it is the elastography, that is the fibroscan, to further test and find out the degree of fibrosis. I'll briefly go into the details of these two. Now, FIB-4 is calculated based on these: age, SGOT, SGPT, and platelet count. How do we interpret? This is available in Google, and anyone can actually access this. And if you have just these three parameters, age is always there, AST, ALT, and platelet count, you can find out whether this patient is likely to have significant fibrosis or not. So, how do we risk stratify based on FIB-4 score? This FIB-4, if it is less than 1.3, our Indian recommendation is even less than 1, then this patient is unlikely to have significant fibrosis. And you can safely ask the patient to relax, do some exercise, lose weight, that's it. There is no need of any medication. If the patient has more than 2.67, if the index is high, this patient is high risk and is very likely to have very significant fibrosis and should be referred to a hepatologist and should be investigated in detail. Maybe a biopsy would be required. But the ones who are having a FIB-4 index between 1.3 to 2.67, they are having indeterminate zone. Patient may or may not be having significant fibrosis. They should be put to other non-invasive tests, or they should be having fibroscan done. Now, this is the way fibroscan reports are generated. This is for the fibrosis, and this one is for the fat continuous controlled attenuation parameters. This is another machine doing the same thing. Here, as the fibrosis increases, the score goes higher like this. Similarly for the CAP. Now, fibroscan nowadays is widely available, and there are so many pharma companies also doing rounds, and they are taking fibroscan machines and doing camps everywhere. Now, before we do it and get it interpreted, there are a few little things we must know. It actually measures the liver stiffness. So this liver stiffness measurement is not a very simple thing to do that anybody at any time can be done, and anybody who walks into your clinic should be getting this fibroscan done. Because LSM is impacted by inflammation. So if SGOT, SGPT is high, you are likely to get a higher report, and there might be an unnecessary concern or panic in the mind of the patient or the physician as well. If liver is congested, if there is cholestasis, or the patient has recently taken food, these patients are likely to have a higher LSM values. So patient should not be tested for fibroscan if there is ongoing inflammation, congestion, cholestasis, or food intake is there recently. So because 1 milligram increase of bilirubin will increase KPA, that is LSM, by 1. HVP, that is hepatic venous pressure, increase by 2 centimeter will increase it by again 1. If AST value is more than 100, that is from 40 is the upper limit. If it is more than 140, then there will be an increase in 4 kPa. So you'll have wrong values. Let the SGOT, SGPT settle down, then only you should be doing fibroscan. CAP, that is controlled attenuation parameter for fat. It is impacted by steatosis and BMI. Patients who are extremely obese, in them also fibroscan should not be done. There are other modalities required. Timing of fibroscan is very important. Ideally, after overnight fasting, it should be done, and patient should off any amount of alcohol for last at least 4 weeks' time. Somebody who is ongoing or taking ongoing alcohol should not be asked to get this done. So, who should ideally be screened for significant fibrosis? The ones who have type 2 diabetes mellitus, medically complicated obesity, and those fatty liver disease cases with moderate alcohol use. And in addition, first degree relatives of NASH patients who have had cirrhosis in the past. Now, it is very important to know that which are the patients in whom fibrosis will progress faster. So there are certain adverse factors which actually lead to rapid fibrosis progression, like severity of comorbid diseases like diabetes or dyslipidemia, genomic profile. There are certain favorable factors also. The favorable factors are frequent monitoring. Those who get frequent monitoring done, in them it is less likely to progress faster. Like those who are adhering to a good diet, their lifestyles, those who have improved. But by and large, a rate of one factor worsening in a stable case still occurs in about 14 years' time. But in those who have developed steatohepatitis, in them the worsening will be rapid and it will happen in about 7 years' time. So we have to identify the rapid fibrosers in whom fibrosis takes place rapidly. A typical fibrosis, if you do nothing also, every fatty liver will progress. There will be ongoing inflammation, there will be ongoing fibrosis. But the slow fibrosor will have a rate of fibrosis of 0.1 to 0.2 stage per year. The rapid fibrosers will have 0.3 to 0.5 fibrosis stages per year. Progression of F0 to F3 will take less than 10 years in rapid fibrosers. And liver stiffness also will increase by more than 20 to 30% in 1 to 2 years' time. So these are the ones which should alert us, and we should be alarmed, and we should aggressively treat these people. So the key ingredients, what are the key ingredients of rapid fibrosis? Sustained inflammation, active stellate cell signaling, and ongoing metabolic injury by way of uncontrolled metabolic dysfunction. So annual increase of FIB-4 score of more than 0.3 is a matter of concern, and patients should be taken into aggressive measures. The pathophysiology of rapid fibrosis is persistent inflammation, profibrotic signaling, metabolic amplification, that is higher insulin resistance, lipotoxicity, and oxidative stress, and genetic susceptibility. Well, we do not do genetic testing in everyone except in research setting, but this is something which we must know. So how to identify rapid fibrosers, the ones who require urgent attention? Rising stiffness, persistent ALT elevation, worsening glycemic control, declining platelet count, and increasing FIB-4 score. And a typical worrisome situation is someone, a male who is in late 50s, diabetes with HbA1c more than 8%, a high BMI, ALT persistently higher, baseline stiffness 8.5, it jumps to 11.5 in 1 year's time. This trajectory is dangerous, and we must actually focus our attention to. How do we guide somebody who already has a F4 fibrosis? 6-monthly screening for HCC and esophageal varices must be undertaken, monitoring for features of decompensation, and because the rate of decompensation in these patients are likely to be 3 to 20% per year, which is very high. As we are aware that cause of death in fatty liver disease still remains maximum in cardiovascular disease situations, followed by non-hepatic malignancy, and then comes liver disease. So if you are taking care of any NAFLD or MASLD patient, you are actually reducing all-cause mortality. But if you are able to regress the cirrhosis, there is a 6-fold reduction in liver disease, liver-related events or liver-related mortality. So these are the various impactful factors for development of fibrosis. Android obesity is worse than gynoid obesity. Control of diabetes, aggressive control of diabetes, hypertension and dyslipidemia is also part of the care. Briefly coming to treatment, the treatment of NAFLD has to be a holistic approach. Weight loss is central to the treatment. We should choose a healthy diet. An ideal diet would be a typical Mediterranean diet, whose Indian equivalent would be to have whole grain, plenty of legumes, vegetables, some grilled fish and chicken may be allowed, but plenty of vegetables and legumes are the central to the type of Indian equivalent of Mediterranean diet. And control of other metabolic dysfunctions. Coffee has some role. Black coffee, particularly 3 to 4 cups of black coffee, has been shown to have some role, but still it is unproven. Weight loss, in fact, is the central mechanism, and it restores the balance of fatty liver sources and is extremely important and must be focused on. Any weight loss is beneficial. Even less than 3% of weight loss will also have the reversal of steatosis. But as you increase the weight loss, and more than 10% weight loss may even regress fibrosis to the tune of 45%, which is very encouraging. The Indian Association of Study of Liver Disease had actually given some guidelines. Guidelines for treatment are actually vitamin E pharmacotherapy must be initiated in all patients of fatty liver disease with or without hepatic fibrosis in non-diabetic adult and pediatric patients. Pioglitazone as a pharmacotherapy for NASH with or without fibrosis in both diabetic and non-diabetic patients should be prescribed. INASL also recommends saroglitazar for NASH with or without hepatic fibrosis, with or without diabetes. Although the evidence to support saroglitazar is weak, but pioglitazone and vitamin E are strongly indicated. Resmetirom is the new drug, and in fact it is the first drug to be approved by FDA as recently as March 24. This is given in cases of MASH with advanced fibrosis. It reduces hepatic inflammation and stellate cell activation. Dose is 80 to 100 milligram tablet daily, but it is not widely available in India and has to be procured from outside. Various other drug development is going on. Multifactorial approach is being employed, but still we don't have any single wonder drug. The newer weight loss drugs have also shown increasing promise and are being undergoing trial. Phase 1 and phase 2 trials have shown both semaglutide as well as tirzepatide showing very encouraging effect. There is decrease in body weight, improved lipid profile, improved glycemic control, cardiovascular parameters also improved, and there is global improvement in problems in the fibrosis. So, even tirzepatide has also shown very encouraging results, but it is still not part of the recommendation. But in future, in few years' time, I think this will be part of the recommendations. The treatment, in fact, has to be, if they keep the patient in center, primary healthcare provider, gastroenterologist, nutritionist, everyone has to actually work together, and it has to be a 360-degree approach for the well-being of the patient, because every aspect is equally important. To conclude, ladies and gentlemen, NAFLD or MAFLD is the ongoing metabolic storm, and it is likely to escalate further. Drug development is lagged behind. Diet, exercise, and management of comorbidities are the proven tools. Drug therapy is indicated in well-defined situations. Multidisciplinary care is advised. Liver transplant need of NASH-related cirrhosis is likely to increase many-fold, so we have to gear up accordingly. Thus, fatty liver is no more a real mystery, because disciplined and active lifestyle is the answer, because in the absence of a standard drug, the one which is available to us, that is discipline and a healthy diet and healthy lifestyle must be resorted to. Thank you very much.
Well, very nicely expressed the subject and very thorough. I think it is no more a mystery. Again, you said, very well said. I think the newer drugs, those are FDA approved newly. There is resmetirom. Is it available in India?
Sir, it is available through other countries, like through Bhutan it is being procured and it is being made available, because it is going to take some time.
If it is not available, what is the next drug you will advise for this one?
See, as I said, the drugs which are vitamin E should be prescribed to everyone, and the other, if the patient is diabetic, saroglitazar has to be given. If the patient is non-diabetic and is having significant fibrosis in diabetes and non-diabetic, both situations, pioglitazone is a drug which should be given.
Okay, pioglitazone is very much available everywhere, and we are using since so long. I think the large dose of pioglitazone is not advocated in this case. 7.5 milligram is
yes, very low dose has to be given, because higher doses are likely to cause chest pain.
You said about the biopsy of the for confirmation, but I think the MRI based that fibroscan will be better, as it is equivalent to biopsy. by
Sir,
reports.
MR elastography, in fact, is the next best test, second to biopsy, but it is not widely available. It requires some sort of, softwares which are not widely available. Even in Chhattisgarh, no one is doing MR elastography. So, but in bigger cities, it is available. It requires 3 Tesla machine. It requires, expertise to do it. Similarly, MRI PDFF again, which does not require any fasting stage. That patient just can walk in and get it done. So those are more specific and more sensitive than other available tests. But what is easily available to us nowadays, second to ultrasound, is fibroscan. Because I understand a lot of people are going around and doing fibroscan camps everywhere. But that has to be done carefully and interpreted very carefully, so that unnecessary panic is not created. And because it's likely to give high values if it is not done carefully.
But lifestyle management remains the base for all
We
these
will like
things.
to conclude the session, sir. We are
Thank you.
absolutely running short of time.
Thank you, sir. Thanks. Sir.
Thank you, sir. I would like to request our esteemed chairpersons to kindly felicitate our speaker, Dr. D. Singh, sir. Dr. Subodh Kumar, sir, to kindly come and felicitate our chairpersons.
Our next talk is by a very promising doctor, and you can imagine he has operated on my father also. My father's TKR is done by himself. So next talk is robotics, and he brings robotics in Chhattisgarh.
For the next session, I would like to invite Dr. Preetam Agarwal, robotic knee and arthroscopic surgeon from Sri Narayana Hospital, Raipur. The topic of his presentation is the present and future of knee surgery, precision and innovation with robotic knee replacement. Chairpersons for these sessions are Dr. Madhumita, Professor and HOD Anesthesiology, SIMS Bilaspur, and Dr. VL Dhan, CMS and AMO, Gevra. Ma'am, please. Sir, please.
Good afternoon, everyone. It's after lunch, so you might be sleepy, tired, but it's a very interesting topic this side. So please. So Dr. Preetam Kumar Agarwal, he is an orthopedic surgeon. He has done MBBS, MS, DNB and MCH from UK. He is a robotic knee surgery replacement surgeon, arthroscopy and sports injury specialist, head Raipur Knee and Shoulder Clinic, Sri Narayana Hospital, Raipur. Completed MBBS from Bombay, MS Orthopedic from MAMC, Delhi, DNB Orthopedic and MCH Orthopedics from UK. Fellowship trained in orthoplasty, Bombay, and shoulder arthroscopy, senior trainee at Nine Wells Hospital, UK. Pioneer of robotic knee replacement, minimal invasive subvastus knee replacement, partial knee replacement and reverse shoulder arthroplasty in Chhattisgarh. Active academician, presents papers at IOACON and DOACON. He is a PG teacher for DNB Orthopedics. He is a member of Indian Orthopedic Association, registered with Delhi and Chhattisgarh's medical councils. Okay, continue.
Thank you, ma'am. So, good evening. So, I'd like to first thank Mr. Sir and the Jain Sir for the invitation. So, I'll be talking about knee surgeries, knee replacement surgery. So, first of all knee patients, they don't need a knee replacement surgery. So, it's not like if a patient has a knee arthritis, he will need a knee replacement. So, we have a stepwise approach to approach a knee arthritis. So, if there is the cartilage injury is specific, they will preserve the knee. And if the patient is young, active, we try to preserve the knee with osteotomy surgeries. And we have the option of partial knee replacement surgeries, where we are not replacing the whole joint. And the end stage arthritis, we do the knee replacement. So I'll go step by step. So first is arthroscopic surgery. So when the cartilage defect is focal, like in this case, it's a focal defect and the patient is very active. So we're not going to replace the whole knee. What we'll do, we'll just fill up that cartilage defect with the normal cartilage. So that is called Oates procedure. So this is the Oates procedure, where we take the cartilage from the normal non-weight bearing part of the knee, and with special instruments, we put this cartilage on the defected part. So this is the patient at 1 year. He's active, he's doing all the activities, squatting, sitting, he's able to do running and his daily activities. So these patients, he don't need any replacement. So next, patient present with us with many sports injuries like multi-ligament knee injuries. It's very rare and very devastating. This patient has all four ligament injuries: ACL, PCL, MCL, PLC. All four ligaments are gone. So we do single stage knee ligament reconstruction surgeries. It's a very skilled surgery, and with advanced technology, we operate this patient, all four ligaments in single sitting, and within a year, he started doing all his activities. He's now playing sports. So this is a patient with a stiff knee. Many patients comes with like their knee is not moving. They had some previous fracture surgeries, anything, and knee is very stiff. Earlier, their surgery was done called quadriceps plasty, where there was an open surgery. Now we have shifted to arthroscopic arthrolysis. So with only 2 holes, we do the arthroscopy and we release all the adhesions, and the patient the movement will increase. This patient was very stiff after some previous surgery, and with the arthroscopy, you can see the knee movement is full. This is the post of day 1. He's bending his knee almost 130, 140 degree. So this is the magic of arthroscopic surgery. So this is 1 year follow-up. He's doing squatting, sitting. So this is the next thing is the knee preservation, HTO surgery. So now this is a boom in HTO surgery. What we are doing in HTO, we are not replacing the knee joint. We are preserving the natural knee of the patient. This surgery is indicated for patients who are very active, young, and they want to return to sports and heavy activities. And there only one compartment is involved. So what we do, we just correct the deformity. So what we do the osteotomy of the tibia, and we'll correct the alignment. So once the alignment is corrected, his weight bearing will shift to the normal cartilage, to the lateral side. So the patient, it takes three months to get recovered, but after 3 months, they can do all their activities. So that is the magic of a HTO surgery. Sometimes there is severe varus knee, so we have to correct both in the femur and tibia. So we do the plating in femur and tibia. But the knee joint, we are not doing anything. Only correcting the alignment of the knee. So next thing I want to speak about is partial knee replacement. So you must have heard about this surgery, UKR. So UKR surgery is like we are only replacing the 30% of the knee. We are not replacing the whole joint. In all the knee arthritic patients, they present to us, 50% patients, they have arthritis only in the medial compartment. Their lateral compartment is normal. So we don't need to replace the whole knee in that patients. We have to only replace that medial 30% of the knee. And the beauty of this surgery, you can see this is the implant that we use in partial knee replacement. So this is this component. This whole 70% part is the natural. We are not going to touch the ACL, PCL or any ligaments. So I'd like to show some example. Here you can see this medial part is involved and the lateral part is normal. So in this patient is a right candidate for a partial knee replacement surgery. So what we do in partial knee replacement, we do the exposure just like a total knee, but we are not replacing the whole knee. And this surgery is done with robotics. So partial knee replacement surgery should only be done with a robotics. So the success rate of partial knee replacement is very good with robotics. So I'll just like to show a few things. So this is the robotic surgery that we are doing, the partial knee. This is the navigation markers, and after some registrations, this is the robotic arm. You can see the robotic arm, all the bone cuts will be done by the robotic arms. So it has a very high accuracy. So after the bone cuts and preparation by the robotics, the final implantation that we have to do. This is after the bone cuts, you can see the lateral side we're not touching. Only the medial part we have replaced. So this is how this implant looks. This is the gold knee. We are putting the tibial implant. We are cementing it in the tibial. And then we'll put a plastic spacer, that is the vitamin E poly. It's a highly cross-linked poly. And then we'll put the femur implant. So the life of a partial knee replacement is as good as a total knee replacement surgery. And the function-wise, the patients are far better. They can do more activities than a total knee replacement. So if the patient is a right candidate for partial knee replacement, we should consider this surgery. So this is how this post-op looks like. This is the partial knee replacement. And this is the bone cuts. This is the normal cartilage and this is normal ligament. So this patient started walking same day, and he's not using any walker, any stick, and the recovery is much better. This is one more case, partial knee replacement. The patient can able to do cross-leg sitting very easily. He's doing full knee movement, and he can stand in his operated leg. So that is the beauty of a UKR surgery. One more patient, see, he can able to do squat after a partial knee replacement surgery. So next comes the knee replacement surgery. So when all these treatment modalities that are not able to do, like HTO, cartilage repair or UKR, when the patient has a tri-compartmental arthritis, that means all the three compartments are involved, then we have to do a total knee replacement surgery. So here comes the role of robotics in total knee replacement. So we started the journey of robotic knee replacement 3 years back in Sri Rana Hospital. And can you have sound? And this is the robot we are using. It's called the Cubis robotic system from South Korea. And this is the most advanced robotic system. It's a CT-based robotics. So we do the CT scan of the patient before surgery. So we do the planning. Before going to the OT, we plan the surgery. How the patient, every knee is different. So we plan according to the size of the knee, how many bone cuts, and what we have to do. So this is the robotic machine. This machine will come and it will do the bone cuts. So it is very precise. The bone cuts, the precision is less than 1 millimeter with this robotics. So about robotic knee replacement, along with that, the surgery approach is very also important. How you are doing the exposure of the knee. So we do a subvastus knee replacement surgery. Subvastus means we are not touching the quadriceps muscle. We are just elevating it, retracting it. the most common knee replacement that people do is parapatellar, where they split the quadriceps tendon. So if you're preserving the quadriceps tendon, we are preserving the quadriceps tendon, so the recovery is better because the post-op rehab is very fast and the movement is also better. And so knee replacement surgeries, this I'll skip. So why we need robotic knee replacement? We are doing manual surgeries since last 60 years. Knee replacement surgery started in 1960s in UK, and still it's evolving. So the problem with manual surgery is there is some issue that the precision is lacking and there is no planning part. The planning is very important. So with robotic surgery, we can do a CT-based planning. And we get a very high accuracy and precision with robotic surgery. So this is the CT scan, 3D CT scan of the patient, of a partial knee replacement. So before going to surgery, we have already planned that how this implant is going to be like, how much bone cuts we are going to do. So that's why here comes the robotic, the role of robotics. So this is the way we do the robotic surgery, and there's an optical camera. So we have to register some points in the knee, and once the registration is done, then the robotic arm will do its job. The bone cuts, the precision in bone cuts. So this is the robotic machine. So we have to drape it, to make it sterile, and we have to expose the knee joint. Then we have to do the registration. And this is the optical markers that the optical camera will see. And after that, we have to do the bone cuts with the robotics. So I'd like to show a few cases. We have done robotic knee replacement. So this is a patient, he's 73-year-old old, and he has a valgus knee. You can see valgus is, the limb is going out. It's very challenging to do a manual knee replacement surgery in a valgus knee. Very difficult to balance the knee. So this is the patient, this is a pre-op clinical video. The limb is going out, it's a valgus knee. And so we do the robotic planning, and this is the surgery is done. Now you can see the limb is straight now after surgery. And he's walking next day without walker. And the limb, this is called scanogram, the limb is straight now. So one more case, she's very young, 30-year-old female. She has a wind-swept deformity. Wind-swept is in rheumatoid arthritis, the one limb is varus and one limb is valgus. So here you can see this limb is varus and this limb is valgus. And there is severe bone deformities. So see how she's walking before surgery. This left side is in varus and right is valgus. And she's just 30. We don't have any option of HTO or partial knee in this patient. So we have to do a total knee only. So we did the total knee replacement in a single stage, and she's walking next day without any walker. So this is the patient, one more patient. See her knee, her whole condyles is worn off. So this is the primary knee replacement. Patient, we use a knee that is used in a revision knee replacement. So she was bedridden for around 6 months. Some has to hold to make her walk. And after surgery, she started walking. So this is one more case, very difficult knee, very deformed knee, and we did the surgery. And he is very happy. One more case, you can see the varus in the limb is deformed, and after surgery, the limbs are straight. So, more examples. So one more thing, after the knee replacement, some patient, they may need a revision knee surgeries after 20-30 years. So average life of a knee replacement surgery is around 20-25 years. So the revision surgery, I want to show this patient, she had a fracture after a knee replacement, and the plating was done for the fracture, but the plate also failed. So we did a revision knee replacement surgery. It's like a mega prosthesis that we do in tumor. We just replace the whole distal femur. The beauty of this surgery is after this mega prosthesis, the patient can walk from next day. The one more case with a periprosthetic fracture after knee replacement and a revision surgery. So we have many happy patients. So with the advent of robotic surgeries, now we have the results of knee replacements are getting better and better. And I think robotics has changed the results of knee replacement, and the patient satisfaction is getting better. And I think in future also, with the advancement in robotics, more and more, the results is going to be much better. So this is what I explained. So not all patients need knee replacement. If we can preserve the knee, we should try to preserve the natural knee. We can consider the STO surgery, alignment surgery, partial knee replacement. If it's a tricompartmental arthritis, then the last option is a knee replacement. So we also do hip replacement surgery. Khemka sir does all the hip replacements in our hospital. He started hip replacement 30 years back. He first started hip replacement in Chhattisgarh in 1994, and he do bilateral hip replacement in single stage. That is very rarely done. It's a very complex surgery to do a bilateral hip in a single stage. So the beauty of doing a bilateral is the patient don't need a surgery 2 times, and the recovery is better. The rehab is faster. So these are the revision hip replacement surgeries that is done by him. So one more interesting thing apart from the knee replacement I am just going to touch upon. So this is about the compound fracture of the tibia. You must have seen many patients, they have fractures of the lower limb tibia, femur, and it's compound, like it's grade 3B open, where there is open wound, vascular injury. And this patient, they suffers a lot. They underwent multiple surgeries, multiple bony surgeries, flap surgeries, like they got treatment for 2-3 years. Till then, they are not recovering. So Khemka sir has invented a new technique, and we call it a Khemka technique, and we published it. So what he has done, like in this patient, this is the first case he started doing this new technique 10-12 years back. So this patient was advised amputation because there are many fragments. No one can think of saving this limb. So what he did, he put some endus nail inside and put an external fixator from outside. And this patient, this is 1 year follow-up, and this is 3-year follow-up. All the fractures are healed, all the wounds are healed, and he is walking comfortably and the movements are full. So that is, this patient limb was saved with this surgery. So after this we make it a routine to do this Khemka technique in our compound tibia fracture patients, and we have a series of now more than 100 cases. So thank you. So any questions, ma'am?
Thank you, Dr. Pritam. It was such a fantastic presentation with so many videos and pictures. Even after lunch, we all stayed attentive. Being a professor in anesthesiology, we are doing so many TKRs and THRs in the hospital, government college. But the thing is, I wanted to ask you, what post-op pain management you do?
Very, very good question, ma'am. So pain is the most important part after knee replacement surgery. If the patient is having pain, very much pain after knee replacement, then he will not be happy. So in our hospital, we have made a protocol. So we use adductor canal block for all our patients after knee replacement. So it's a ultrasound guided adductor canal block that is given by the anesthetist, and we use intraoperative cocktails. So in cocktail, we use bupivacaine, and if the patient is non-diabetic, then you add steroid. And this is our protocol, intraoperative cocktail plus adductor canal block.
Okay. Usually we keep such patients in our ICU post-op, and we give epidurals with all those cocktail, bupivacaine or ropivacaine with clonidine or dexmet. Thank you. Thank you for such a fantastic presentation.
Thank you.
Any questions from the audience? Yeah.
Sorry, ma'am, no questions will be entertained. We are absolutely behind schedule.
One. Such an interesting subject. One question.
replacements. By the way, there's a lot of implants. And what type of implant do you think is the most suitable, economically viable for the normal category of patients? Regarding the type of implants.
So about the type of implants, you're talking about the knee replacement surgery. So in knee replacement that we are doing, there are different type of implants where once we preserve the PCL, that is called CR knee, one where we cut the PCL that we called a PS knee. So now the best thing is the CR knee replacement surgery. In CR, we're not cutting the posterior cruciate ligament. So you're preserving the posterior cruciate, so the results are better. And now we have the polys that are very anatomical. That is like a natural knee. The medial side of the knee is tight and lateral side is loose. So that is called medial constrained polys. So that is the standard implants. And now all the companies, they are making all the good implants. And the result, life is around 20-25 years.
Thank you, sir. Now I request our esteemed chairpersons to kindly felicitate our speaker, Dr. Preetam Agarwal, sir. Ma'am, please. Sir, please.
हैव अ क्लैप एटलीस्ट करतल ध्वनि से हम सब स्वागत कर रहे हैं, डल ना हो, क्योंकि जो नेक्स्ट टॉक है वो आपको थोड़ा रिलैक्स कर देगी और आप देखोगे क्या बिजिएस्ट ऑर्थोपेडिशियन कैन प्रेजेंट दैट टॉक। सो मैं मिस्ट्री रहने देता हूँ एंड नेशनल लेवल पे इस तरह के टॉपिक को बहुत अप्रिशिएट किया गया है।
I request Dr. U.S. Petha, sir, to kindly felicitate our esteemed chairpersons, Dr. Madhumita ma'am and Dr. B.L. Dhan ma'am. Sir, please.
Attention delegates, those who haven't yet collected the delegate kits that's available at room number 1001 in the hotel premises. All the delegates who haven't yet collected their delegate kits can kindly collect them from the room 1001.
Thank you, sir. Thank you, ma'am. Now, for the next session, I would like to invite Dr. Vinod Tiwari, sir, Director, Sanjeevani Hospital, Bilaspur, and the topic of his presentation is how to achieve highest level in professional life. Chairpersons for the same session are Dr. Sunil Khemka, Consultant Orthopedician, Sri Narayana Hospital, Raipur, and Dr. Nitasha Shoni, ma'am, Consultant Physician, Sri Ram Care Hospital. I request both of them to be present on the stage. Ma'am, please. Sir, please.
Give it to that person, Pawan, the one on the stage, give it to that person, he'll record all everything.
Hello. Dr. Vinod Tiwari is a very senior practicing orthopedic surgeon and he is one of my good friends. He is very active socially in all the public welfare functions. He is very active academically also. He is the Assistant National Secretary for IMA headquarters. He was past president of IMA also, past president Central Zone Orthopedic Association and Chhattisgarh Orthopedic Association. He was ex-chairman Trauma Committee, ex-member editorial board of Indian Orthopedic Association, very big thing. He was a fellow of Johnson & Johnson, represented India at AAOS, Orlando, USA, and he was chairman BCSPS Bilaspur, member governing body Super Specialty Hospital Bilaspur. He is a director and owner of Sanjeevani Hospital and Research Center Bilaspur. Now I invite Vinodji for your talk.
Thank you, sir. Good afternoon. Jai Johar. Respected Sunil Khemka sir, respected Nitasha ma'am, respected colleagues. ये पर्सनल एक्सपीरियंस है, कोई ग्रूज नहीं है, कोई इम्पोर्टेंट नहीं है, 20 मिनट्स के लिए है, इफ़ यू लाइक देन इट्स बेटर, नहीं तो 20 मिनट के बाद अपने हिसाब से आप डिसाइड कर सकते हैं। माई लाइफ माई रूल्स, योर लाइफ योर रूल्स। कुछ पॉइंट्स हैं जो कि हमें समझाता है कि कुछ कैसे किया जाए जो हमें अपने आप को इम्प्रूव किया कर सकते हैं। जैसे इंपॉर्टेंट पॉइंट है, टर्न योर वीकनेस इनटू पावर। पहले मुझे बहुत परेशानी होती थी, हिंदी मीडियम में पढ़ा था, इंग्लिश बोलने में दिक्कत होती थी। धीरे धीरे प्रैक्टिस करते गया, करते करते ऐसा हुआ कि हिंदी मीडियम में प्रेजेंट करने से ज़्यादा पावर आया, वाइब्स ये है इन्फ्लुएंस करते रहे और ये मेरा पावर बन गया। उसी तरह से सेकंड एग्जाम्पल से गंजा था, लोग थोड़ा सा हेजिटेट करते हैं कि अरे यार गंजा है, हेयर ट्रांसप्लांट करवाया, ट्रांसप्लांट करने के बाद समझ में आया पैसे खर्च करने के बाद ये बेवकूफ़ी है, नेचुरल स्टाइल ज़्यादा अच्छा है। तो ये अपना है, तो ये वीकनेस को अपना पावर बनाना। फिर नो शॉर्ट कट इन प्रैक्टिस। अभी सोचने वाली विषय है, जितने भी डॉक्टर्स हैं, कट प्रैक्टिस का ज़माना चल रहा है। कब तक और कितना, ये सोचना पड़ेगा। अगर वो टाइम आप डिवोट करेंगे फैमिली के लिए तो ज़्यादा यह है कि यूज़फुल रहेगा। हेल्थ और प्रोफेशन पे इन्वेस्ट करिए। आपका पैसा ज़मीन है दूसरे जगह में इन्वेस्ट करते हैं, ठीक है, लेकिन अगर आप जिसमें प्रोफेशन में हैं, जैसे बताया ना कि वो खेमका सर है, हमेशा कुछ ना कुछ इम्प्रूवमेंट करते रहते हैं, नए मशीनरीज लाते हैं, कभी रोबोटिक्स है, कभी कुछ है, हमेशा हर 2 साल में कुछ ना कुछ इन्वेंट करते हैं। तो जो अपने प्रोफेशन में इन्वेस्ट करेगा वो अपने हाईएस्ट लेवल को इजीली पा सकता है। उसी तरह से हेल्थ का है, हम लोग अपने हेल्थ के लिए कॉन्शियस नहीं हैं। हर तरह की बीमारियां हैं, डायबिटीज़ है, हाइपरटेंशन है, डिप्रेशन है, बहुत सारी परेशानियां हैं। पैसे आ जाएंगे एक समय के बाद, लेकिन उसको इन्वेस्ट करने के लिए आपका बॉडी साथ नहीं देगा। आप चाहेंगे अमरनाथ यात्रा करना है, ये है कि शरीर जवाब दे गया, नहीं जा सकते। कहीं पे भी जाना है, कैलाश मानसरोवर जाना है, नहीं जा सकते। तो ऐसे पैसा किस काम का? इसीलिए हेल्थ पे इन्वेस्ट करना बहुत ज़रूरी है। और अपने प्रोफेशन को पैशन बनाइए। हमारे अधिकांश कलीग से जितने भी हैं, उनको बहुत परेशानी होती है, उनको बोलते हैं यार कहाँ से डॉक्टर बन गया, है ना। जैसे ये रात में शाम को बैठते हैं दोस्तों के साथ, बोले यार हेडेक है, कहाँ डॉक्टर बन गया। तो नहीं बनना चाहिए, डॉक्टरी छोड़ दो, कोई परेशानी नहीं, किसी को बॉन्डिंग नहीं है, आप दूसरा प्रोफेशन चूज कर सकते हैं। अगर आप डॉक्टर बन गए हैं, इनबिल्ट डॉक्टर हैं, तो आप उसको एंजॉय करिए, उसको ये पैशन के रूप में लीजिए तो आपको अच्छा लगेगा। एंड नेवर कंप्रोमाइज विथ क्वालिटी। पेशेंट इज बेस्ट टीचर। वो आपको बता देगा कि आपने सही काम किया कि नहीं किया। वो बता देगा सर आपका ये, जैसे बोलेगा ना खेमका सर जैसे काम कर रहे हैं, जैसे बताएंगे तो बोलेंगे वो खेमका सर बहुत अच्छे डॉक्टर हैं। वो बता देगा कि उसका काम अच्छा हुआ है। सर्जरी सभी ने किया, मैंने भी किया, तीसरे ने भी किया, लेकिन वो बताएगा कि हाँ ही इज़ राइट, ही इज़ परफेक्ट। यानी उससे आपको बहुत कुछ सीखने को मिलेगा। मेक एनी मैनी फ्रेंड्स इज पॉसिबल। ट्राई टू इन्वॉल्व इन साइंटिफिक अपग्रेडेशन। कॉन्फ्रेंसेस में जाते हैं, जैसे कॉन्फ्रेंस किसी भी कॉन्फ्रेंस में तो इंजॉय करते हैं, ठीक है। मेरा फंडा क्या है, एक कॉन्फ्रेंस एक टेक्निक, कोई भी एक सर्जरी मेरे को सीखना रहता है, भले छोटा से छोटा टेक्निक हो, वो टेक्निक को इम्प्रूव करना है और वो टेक्निक में मास्टरी लाना है। वो मेरे लिए लाइफ टाइम वो है अचीवमेंट रहता है। और जहाँ पे भी हर आदमी को कभी न कभी ज़िंदगी में कोई अच्छा मौका मिलता है और उस मौके को जो चूक गया वो पीछे रह जाता है। तो हमेशा ये जहाँ पे मौका मिले चौका लगाना नहीं भूलना चाहिए। प्लेजर ऑफ गिविंग, हमेशा कोशिश करिए अपने कलीग को हेल्प करने की। सर ये एग्जाम्पल्स हैं, कभी किसी के लिए ना नहीं बोलते। हेमका सर ये बहुत बड़ा इनके ये है कि बड़प्पन है। कोई भी है कैसा भी मरीज हो, कितना भी सीरियस है, आप इनसे करिए, जैसे ही वो बोलेंगे ऑलवेज अरे विनोद हो जाएगा, कोई चिंता मत कर। कभी किसी तरह की हेल्प ऐसे करना है सर, क्या ये रहता है। तो ये जो चीज़ें हैं आपने कलीग के लिए किया हुआ, वो हमेशा साथ देता है और ये आपको हमेशा ध्यान रखना चाहिए। और ये बात ध्यान में रखिए कि देयर इज नो फ्री लंच इन द वर्ल्ड, आपको मेहनत करना पड़ेगा। फंडा ये है कि दिमाग में इतना ज़्यादा बोझ नहीं लेना है कि वो आपके सिर पे भारी हो। तो इसके लिए क्या है, पैर गरम, पेट नरम, माथा ठंडा, यानी डू एज मच एक्सरसाइज एज पॉसिबल। फिटनेस पे ध्यान देना है, पेट साफ हो, कम खाइए, डाइट लिमिटेड रहना चाहिए, उतना ही है जितना जरूरी है, वो आपको फिट रखेगा और दिमाग को ठंडा, कूल एंड काम रखिए। मरीज आपके पास आता है, आज के समय वीडियो बनाता है, कुछ भी गुस्सा आएगा कि बोले मेरा वीडियो बना रहा है और बोले ये मेरे को बदनाम करेगा। उस समय अगर आपने गुस्सा दिखाया, मैंने उसके ट्रैप में फंस गए। आपको आपके दिमाग को ठंडा रखना पड़ेगा, काम एंड क्वाइट रखना पड़ेगा। और जब भी सर्जरी की बात आती है, डॉक्टर की बात, तो सेकेंड गेसिंग की जरूरत नहीं है। वंस यू आर डिसाइडेड देन इट्स फाइनल। प्रैक्टिस मेक्स हिम एन परफेक्ट। ये परफेक्ट है, कहीं पे भी रहेगा, रेगुलर प्रैक्टिस जरूरी है। फियर ऑफ मिसिंग आउट, ये हमारे डॉक्टर्स में बहुत बड़ा प्रॉब्लम है। हमेशा ये है कि उनको लगता है कि मेरे तरफ देख रेख नहीं है, विज्ञापन मेरा आ रहा है कि नहीं आ रहा है, मेरे बारे में क्या चर्चा चल रही है, क्या चीज़ है, ये सब करने की सोचने की क्या ज़रूरत है। आप अपना काम करते रहिए, दुनिया क्या कर रही है इसके बारे में सोचने की ज़रूरत नहीं है। कोई भी काम को डू इट नाउ के कॉन्सेप्ट में करिए। रात को 2 बजे भी सर्जरी करना पड़े, आप उसके लिए वो है कि अटेंटिव रहिए, तैयार रहिए। कंपाउंड फ्रैक्चर आ गया, अगर कंपार्टमेंट सिंड्रोम है, कुछ भी प्रॉब्लम है, न्यूरोवैस्कुलर डेफिसिट है, आपने उसमें अगर एक्सक्यूज़ किया तो वो प्रॉब्लमेटिक हो सकता है। कौन सा मरीज कब देखना है, इमीडिएट अटेंशन देना है कि नहीं, ये बहुत इंपॉर्टेंट है। कंपैरिजन सिंड्रोम हमारे में ये भी एक बहुत बड़ी खराबी है। मुझे भी होता था, जलन होती थी कि नारायणा हॉस्पिटल इतना बड़ा है, संजीवनी छोटा कैसे हो गया है ना। बोले हरिहन जैन सर बहुत बड़ा ये गाड़ी खरीद लिए, वो BMW में चल रहे हैं और मैं मारुति में चल रहा हूँ, ये गलत है। बाद में समझ में आया कि हर में कोई ना कोई क्वालिटी है। अगर मैं फिटनेस में अच्छा मास्टर हूँ तो मैं क्यों कंपेयर करूँ कि मैं ये बड़ा बिल्डिंग बनाऊँ, बड़ा हॉस्पिटल बनाऊँ। कोई ज़्यादा पैसा कमा रहा है तो उससे ज़रूरी नहीं है मेरा फैमिली लाइफ बहुत अच्छा है, फैमिली के साथ मैं अच्छा टाइम बिता रहा था, वो ज़्यादा इंपॉर्टेंट है। तो यानी आप कंपेयर मत करिए। यू आर द बेस्ट ब्रेन ऑफ द वर्ल्ड। डॉक्टर जो है बेस्ट ब्रेन है, हर आदमी में कोई ना कोई स्पेसिफिसिटी है, कोई ना कोई स्पेशलाइजेशन है। कोई आर्ट में मास्टर है, कोई सिंगिंग में बहुत अच्छा है, कोई कुछ भी है। ये जैसे है डॉक्टर मिश्रा है, कितना बढ़िया शानदार वाइल्ड लाइफ फोटोग्राफी, देखिए कितना अच्छा है। तो ये बहुत अच्छी बात है, आप इंजॉय करिए। अब वो बोलेंगे मैं भी रोबोटिक सर्जरी करूंगा तो गलत है। गिव टू बेस्ट टू ऑल फील्ड्स। अगर आप किसी भी फील्ड में जा रहे हैं तो ऐसे नहीं है कि कुछ भी काम करते रहे, बेस्ट देना है। इम्पोस्टर सिंड्रोम है, हमेशा अपने आप में डाउट रहता है, मैं छोटा तो नहीं हूँ, मैं अच्छा सर्जरी तो नहीं कर सकता, लोग क्या कहेंगे, लोग मेरे बारे में क्या बोले। क्यों करना है, आप अपने हिसाब से काम करिए, यू आर द बेस्ट। मैं अगर पढ़ाई किया हूँ, कोई भी है, लव एंड बैली है, जो भी है, दूसरे ने भी पढ़ा है तो मैं उससे पीछे कैसे हो गया। तो ये सिंड्रोम से अपने को बाहर आना होगा। इमोशनल बैगेज, ये हमारे साथ सभी के साथ है, मेरे ख्याल से हर के लाइफ में आता है। पहले जैसे ही आप थोड़ा सा राइज करने लगते हैं तो क्या होता है, उपहास उड़ाते हैं। कैसे, नीताशा मैडम अरे कुछ नहीं कर पाएंगे, बोले वो आई हैं बिलासपुर में दाल नहीं गलने वाला है कि नहीं। थोड़ी देर बाद रहेगा तो उनके पास केस मत भेजो, बोले ठीक है उपेक्षा करना है, बोले उनके पास भेजना बेकार है, नहीं करना है। वो भी अगर परफॉर्मेंस अच्छा करे तो बोले उनका विरोध शुरू हो जाएगा। श्री राम केयर हॉस्पिटल भेजना बेकार है, वो वहाँ केस मरते रहते हैं, केस ठीक नहीं होता, वहाँ उनका विरोध शुरू हो जाएगा। और उसके बाद जब लास्ट में लगेगा कुछ नहीं है तो किसी तरह से बोलो कि वो हॉस्पिटल चल ना पाए, हर कोई कोशिश करेगा उसको दबाने का। और लास्ट में अगर वो ये है कि आप स्टेप क्रॉस करते हैं तब स्वीकार्यता आती है, तब आप है निताशा सोनी बनती हैं। उसी तरह से आपके लाइफ में एक डिफाइंड गोल होना चाहिए कि मेरे को प्रोफेशन में ज़्यादा जाना है, कि बिजनेसमैन बनना है, कि रियल या क्या बोलते हैं कि कहीं भी किसी भी सेक्टर में जाना है। एंड डोंट ट्राई टू प्लीज एवरीवन। हम लोग की एक बहुत बड़ी गलती रहती है, हर किसी को खुश करना चाहते हैं। कोई कलेक्टर आ गया उसको खुश करना चाहते हैं, एसपी आ गया, जजेस हैं, हमें क्या पड़ी है कि हर किसी को खुश करें। मेरा लिमिट है, मेरा टाइम है, जैसा मैं चाहूँगा करूँगा, मैं उनके हिसाब से नहीं चलूँगा, मैं अपने से हिसाब चलूँगा। तो ये आप ट्राई करना बंद करिए, एंड डोंट से यस टू एवरीथिंग। हर काम के लिए नहीं बनना, ये सर्जरी मुझे नहीं करना है तो नहीं करना है, रिफर करना है तो करना है, ये आदमी मेरे को पसंद नहीं है तो मैं इसका इलाज नहीं करूंगा। तो ये कॉन्सेप्ट लाना पड़ेगा। एंड डोंट वेट फॉर टाइम, इंजॉय राइट नाउ। क्यों सर, हमेशा अपना रहता है, जब भी मौका मिलता है हम लोग निकल जाते हैं बाहर, इंजॉय करो। सोशल मीडिया डॉक्टर्स के लिए बहुत बड़ा प्रॉब्लम है और आजकल उसकी इंट्रैप में बहुत सारे डॉक्टर फंस भी रहे हैं। तो सोशल मीडिया स्क्रॉलिंग आपके कंफर्ट के लिए है, समय निकाल जब मिले तब करिए, उसी में इंडल्ज होने की ज़रूरत नहीं है। ये व्हाट्सएप वार हर जगह चलते रहता है, छोटी छोटी बातों में लड़ाई झगड़ा, बस मार काट शुरू हो जाता है। उसमें ऐसे लगेगा सामने वाला तलवार निकालेगा, दूसरे गर्दन पे वो अटैक कर देगा। तो ये व्हाट्सएप वार से बचना है। मोबाइल फ़ोन इज़ फॉर माई कन्वीनियंस नॉट फॉर अदर्स। रात को 2 बजे मेरे पास फ़ोन आता है, बोलता है डॉक्टर साहब आप क्लिनिक में बैठे हैं क्या? इतना गुस्सा आया कि मोबाइल से वहीं से मारो उसको। मतलब 2 बजे बोल रहे हैं कि क्लिनिक में बैठे हैं क्या? तो वो अपनी कन्वीनियंस चीज़ें आपसे काम करते हैं। तो ये है बी सेलेक्टिव ऑन व्हाट काजेज यू सपोर्ट, जंपिंग, वो ये सब चीज़ें हैं आप फॉलो कर सकते हैं। टाइम मैनेजमेंट बहुत इम्पॉर्टेंट है। पूर्व योजना पूर्ण योजना, यानी वंस यू आर प्लान्ड इट इज़ टू बी एग्जीक्यूटेड। पहले से योजना बनाइए, योजना बन जाता है, वंस इट इज़ प्लान्ड देन यू हैव टू गो फॉर टू एग्जीक्यूट इट। मनी मैनेजमेंट में अभी बड़े अच्छे डिस्कस करेंगे। एक फिक्स डेली रूटीन होनी चाहिए। सर जैसे एक्सरसाइज करते हैं, ये बहुत सारे लोग डॉक्टर्स हैं, फिटनेस फ्रीक हैं, वो एकदम से डेली रूटीन रहते हैं, वही अपना काम अच्छे से कर सकते हैं। अवॉइड टॉक्सिक रिलेशनशिप। कुछ लोगों को लगता है ना इसका चेहरा देख के मुझे पसंद आ रहा है, कुछ का चेहरा पसंद नहीं आता। तो जिसके साथ टॉक्सिक रिलेशन है, लगता है फ्रीक्वेंसी मैच नहीं कर रहा है, तो उसको अवॉइड करिए, ज़बरदस्ती उसके साथ रहने की ज़रूरत नहीं है। प्रॉपर शिफ्ट शेड्यूल होना चाहिए, और अगर लोग कुछ भी उल्टी सीधी बात कर रहे हैं तो उस पर ध्यान देने की ज़रूरत नहीं, आप अपना काम करते जाइए। अब इम्पॉर्टेंट आता है पैसे की बात। हाउ मच इज़ टू मच, बहुत इंपॉर्टेंट क्वेश्चन है। It's not too much when basic needs are secured, you have a safety buffer, money buys time, peace and choices, help others without hurting yourself. तो ये है not too much. It start becoming too much when you are chasing at a cost of health, family or sleep. Enough keeps moving even after your life is comfortable. Money owns your decision instead of supporting them. Fear of losing it, or it is bigger than joy of having it. तो then it is too much. एक क्वेश्चन है, इसमें मनी के स्टडी के जगह में आप मनी भी चूज कर सकते हैं। अल्टीमेटली समझ में ही आता है, बाप बड़ा ना भैया, सबसे बड़ा रुपया, पैसा होना सबसे इंपॉर्टेंट है। Enough is when money stops solving your problems and start creating them. Means satisfaction बहुत इंपॉर्टेंट है। हम बोलेंगे सेटिस्फाई कब करेंगे, तो समझेंगे जब हमारे बेसिक नीड्स से जो कंफर्टेबली फिल अप हो जाए, और 50 to 60% ऑफ इनकम कवर्स योर नॉर्मल लाइफ कंफर्टेबली, यू आर डूइंग वेल। आपके पास इमरजेंसी फंड होना बहुत ज़रूरी है। हेल्थ इंश्योरेंस बहुत इंपॉर्टेंट है। मेरे ख्याल से बहुत लोगों के पास, हमारे पास हेल्थ इंश्योरेंस नहीं रहता, कब क्या प्रॉब्लम हो जाए नहीं जानते। तो डॉक्टर्स इग्नोरेंट रहते हैं, हेल्थ इंश्योरेंस बहुत ज़रूरी है। ये मेरा वीकली बैलेंस मॉडल है। क्लिनिकल टाइम है, स्लीप है, एक्सरसाइजेस बहुत इंपॉर्टेंट है, फैमिली टाइम है, लर्निंग, स्टडी बहुत इंपॉर्टेंट है। अगर आप डॉक्टर हैं तो स्टडी इज़ मस्ट। कम से कम कोशिश करिए आधा घंटा रोज पढ़ने का, ये बहुत इंपॉर्टेंट है। अगर आपके पास जो बेसिक है, चिल्ड्रन एजुकेशन है, रोटी कपड़ा मकान, ये सब है, रिटायरमेंट प्लानिंग है, तो वंस फ्यूचर गोल्स आर मैथमेटिकली सिक्योर, एक्स्ट्रा इनकम हैज डिमिनिशिंग रिटर्न्स। ये अगर हो जाता है तो आप बढ़ाते जाइए। एक फ़ोन से 4 फ़ोन हो सकता है, एक ये कार से 10 कार हो सकता है, एक ये मकान से 10 मकान हो सकते हैं। वो उसमें एड बस होते जाएगा, सेटिस्फैक्शन नहीं आएगा। मनी इज हायर बट स्ट्रेस, वर्क आवर्स एंड यह एक्सपेक्टेशन आर आल्सो हायर। If is raised just upgrades anxiety, not freedom, you are past enough. सिंपल फ्रीडम टेस्ट है Can I say no to a bad job? Toxic patients are unfair demands. If yes, you are financially strong. If no, even a high income isn't enough. कितना भी पैसा कमा लीजिए हमेशा कमी रहेगा. इन्वेस्टमेंट हमारे लिए बहुत इंपॉर्टेंट है डॉक्टर्स के लिए, जो हमेशा इसमें हम लोग ये है कच्चे हैं. इन्वेस्टमेंट स्टडी बहुत अच्छा होना चाहिए, आपके प्रोफेशन में इन्वेस्ट करना चाहिए. कई सारे ऑप्शंस हैं, बहुत सारे ऑप्शंस मैं अडॉप्ट भी करता हूँ. आप लोग भी इस पर स्टडी करिए और ऐसे जगह इन्वेस्ट करिए जो आपको फाइनेंशियली स्ट्रांग बनाए. मनी क्या दे सकता है, क्या देता है? अगर बोले पैसा क्या देता है, ये आपको सिक्योरिटी देता है. पैसा बहुत इंपॉर्टेंट है, इससे कंफर्ट मिलता है, बेटर हेल्थ केयर मिल सकता है, बच्चे को कहीं भी पढ़ा सकते हैं, फॉरेन में पढ़ा सकते हैं, उसको यह है कि एजुकेट कर सकते हैं, टाइम फ्रीडम मिल सकता है, एंड डिग्निटी सोसाइटी. पैसा अच्छा है, आपका मान सम्मान बढ़ेगा. क्या नहीं दे सकता? तो ये हेल्थ नहीं दे सकता. हेल्थ आपको खुद बनाना पड़ेगा. पैसे से आप हेल्थ बाय नहीं कर सकते, पीस ऑफ माइंड नहीं मिल सकता, रियल रिलेशनशिप नहीं मिल सकता, रिस्पेक्ट नहीं मिल सकता, एंड पर्पस ऑफ लाइफ नहीं मिल सकता. सो पिक योर लैन. सभी का अपना अपना लेन है, अपने को चूज करना है. प्रोटेक्ट योर फोकस लाइक योर लाइफ. यू जस्ट नीड टू डू द राइट थिंग एंड डू इट कंसिस्टेंटली. बी थैंकफुल टू योर इंसेस्टर एंड गार्जियंस. हम लोग डॉक्टर बन करके बहुत बड़े अपने आप को थोड़ा घमंड आ जाता है. हर किसी का डॉक्टर या कोई भी प्रोफेशन बनने में बहुत सारे लोगों का इन्वॉल्वमेंट रहता है, डायरेक्टली या इनडायरेक्टली. उसके लिए हमें थैंकफुल होना चाहिए. लिव पर्पसफुली, ट्राई टू हेल्प दोज इन नीड ऑफ इट, मेक इट एटलीस्ट वन हॉबी. डोंट क्रिटिसाइज और बी जीलस टू यूर कलीग्स. ये बहुत इंपॉर्टेंट सीखने वाली बात है. आप किसी के पीछे बैक बाइटिंग कर रहे हैं, एडवर्स कमेंट कर रहे हैं, तो ये जरूरी नहीं है वो जाके बताएगा आपके कलीग का यह नुकसान है यानी आपका नुकसान है. इसके लिए आपको बचना चाहिए. इंजॉय द लिटिल मोमेंट्स एंड बी चीयरफुल. हाउ टू डू गुड, मेक गुड मनी. पैसा कमाना बहुत अच्छा है, लेकिन कैसा पैसा, कौन सा बोलेंगे कि अच्छा पैसा है? डूइंग गुड वर्सेज हैविंग ए गुड लाइफ, इसमें आपको कंपेयर करना है. प्रॉफिट वर्सेस सोसाइटल गुड, ये दो तरह के हैं. सोसाइटी में आपका नाम हो रहा है, अच्छाइयाँ पता चल रही है, और आप अपने लिए पैसा कमा करके ये तिजोरी में रख रहे हैं. दोनों में कंपेयर करना है, समझना पड़ेगा. मेकिंग मनी इज, अगर वो है पैसा बना रहे हैं, उसके साथ अगर वैल्यू भी जुड़ते जा रहा है, नीड्स भी यह फुलफिल हो रहा है, अनटेकिंग ए रिस्क, रिस्क भी लेते जा रहे हैं, तो ये अच्छा पैसा है. हेल्पिंग सोसाइटी अगर उसके साथ कर रहे हैं तो आपका पैसा अच्छा है, यानी कंट्रीब्यूटिंग इन टाइम, इफोर्ट, स्किल एंड मनी, क्रिएटिंग पॉजिटिविटी एंड हेल्पिंग द हेल्पलेस. अगर ये कर रहे हैं तो ये अच्छा पैसा है. प्रॉफिटेबल गुडनेस, अच्छाई तो हर जगह होती है, लेकिन कब बोलेंगे कि प्रॉफिट वाला अच्छाई है? सम प्रोडक्ट्स एंड सर्विसेज कैन मेक मनी एंड बी गुड. जैसे डॉक्टरी प्रोफेशन है, आपको नाम भी मिलेगा, आपको भगवान का दर्जा भी मिलेगा, पैसा भी मिलेगा, सोसाइटी में इज्जत भी मिलेगी. तो ये क्या होगा? ये प्रॉफिटेबल गुडनेस है. रॉन्ग पॉलिटिक्स टू से प्रॉफिट. पॉलिटिक्स करके पैसा कमा रहे हैं, या टेररिस्ट ऑर्गेनाइजेशन है, या लीकर माफिया है, पैसे तो कमा रहे हैं लेकिन ये बैड प्रॉफिट है, गुडनेस नहीं आ सकता. मस्ट एजुकेट पब्लिक अबाउट दिस थिंग, हमें बताने की ज़रूरत है. एंड फाइंड योर बैलेंस, आपको दोनों के बीच में बैलेंस लाना है. अगर इसमें हम देखेंगे गुडनेस के बाद में, तो ये लेफ्ट साइड है, लेफ्ट अपर साइड, अन्ना हजारे, मदर टेरेसा, इनके पास पैसे कम थे लेकिन अच्छाइयाँ ज़्यादा थी, नाम ज़्यादा था. इसके कंपेयर में थोड़ा सा हम देखेंगे तो डॉक्टर्स हैं, राइटर्स, इंटरप्रेनर, टैक्स पेयर है, गुडनेस क्रिएट कर रहे हैं, पैसा भी अच्छा मिल रहा है, यानी हम लोग बहुत अच्छे पोजीशन में हैं. उसके नीचे आ रहे हैं तो इसमें प्रॉफिटेबिलिटी बढ़ गया लेकिन गुडनेस कम हो गया. इसमें टोबैको, जितने भी नशा करने देने वाले हैं, टेररिस्ट ऑर्गेनाइजेशन है, इनके पास पैसा लेकिन अच्छा नहीं है. और अगर इस तरफ टेररिस्ट या ड्रग एडिक्ट है तो केवल पैसा ही पैसा है, लेकिन कोई अच्छाई नहीं है. तो सक्सेस अगर बोला जाए तो सक्सेस मल्टीफ्लॉन्ग्स है. आपको कई तरह की चीज़ें देखनी पड़ेगी तब आपको सक्सेस मिलेगा. पैसा भी होना चाहिए, इंडिविजुअली भी आप अच्छे हों, दूसरे को हेल्प भी करना है, आप में सेटिस्फैक्शन भी हो, सोसाइटल बेनिफिट हो, आपके रहने से सोसाइटी को फ़ायदा हो, सेल्फलेस हो, आपका स्टेटस बहुत अच्छा हो, आपका सेल्फनेस बहुत अच्छा हो, तब बोलेंगे आप सक्सेसफुल हैं। और लास्ट में यही है कि जो हिट है वही फिट है। हम लोग इग्नोरेंट रहते हैं, कोशिश यही करते हैं कि हेल्थ के बारे में ध्यान नहीं देते, हमेशा पैसा कमाने में या फिर बाकी चीज़ों में रहते हैं। ये कोई काम आना नहीं है। सिंपल सा फंडा है, आप अगर 65 साल की उम्र पे जब आपके पास पैसे हों, आप कोई मेडिसिन नहीं ले रहे हैं, आप मेंटली फिजिकली फिट हैं और आपके पास लगता है कि किसी चीज़ की कमी नहीं है, तो आप फिट हैं और आप तभी आप हीरो बन सकते हैं। थैंक यू वेरी मच फॉर पेशेंस हियरिंग। थैंक यू।
हेलो।
सर का ये रूप मैंने तो पहली बार देखा, वरना मुझे पता है कि रोज 4-5 मेजर सर्जरी करने वाला डॉक्टर सारे मोटिवेशनल स्पीकर को फेल कर देंगे। सो ग्रैंड क्लैप फॉर डॉक्टर विनोद तिवारी सर। आई थिंक इसमें क्वेश्चन आंसर तो नहीं होगा, सर से इन्वेस्टमेंट टिप्स जरूर लोग बाहर ले सकते हैं। आई रिक्वेस्ट अवर चेयरपर्सन टू फैसिलिटेट अवर स्पीकर डॉक्टर विनोद तिवारी। And don't see the attendance. Recent reel posted on this SECL website, because this all session is going live. 3.3 thousand pupils are watching this. 3,500 लोग देख रहे हैं इसको।
Thank you, ma'am. Now I request Dr. G.P. Gupta, sir, to kindly come on the stage and felicitate our chairpersons. Sir, please. Thank you, sir. Thank you, ma'am. For the next session, I would like to request Dr. Avinash Gupta, Consultant Neurologist, Apollo Hospitals, Bilaspur, to kindly come on the stage to present his session on approach to seizure disorder. For chairing this session, I would like to invite Dr. U.K. Behra, ex-CMS ACCL, and Dr. Subodh Kumar, Area Medical Officer, Kusmunda Area ACCL. Sir, please. Sir, please.
Following this session, we are having the free paper presentation. So all the free paper presentation participants be ready for the session. Immediately after the session, we'll conduct the free paper presentations.
Everybody, welcome to almost the end of the day. And just now we had a very good motivating lecture. Hope you are all motivated. Now, we shall be listening about how to approach to seizure disorders. Seizure, as you know, is a excess brain activity by, electrical activity in the brain, excess electrical in the brain. But this disease is not a new disease. The approach may be new. This disease even finds a place in Vedic literature in the name of apasmar. Apasmar means a disorder of unconsciousness, a type of unconsciousness. And subsequently also, there have been mentioned in Charak Samhita, Sushrut Samhita. That is what I mean to say is that for Indian culture, this disease is not new. Now we shall be listening from Dr. Gupta, the recent approach. To introduce Dr. Gupta in short, he is DNB in neurology, DNB in medicine, and MBBS of course, and he is from Bilaspur, Apollo Bilaspur. Now he is a consultant neurologist with 6 years of experience at Apollo Hospital, DNB Neurology from Narayan Hrudayalaya, Bangalore, and DNB Medicine from Balaji Hospital, Delhi. His expertise in stroke care, epilepsy, movement disorders, and neurocritical care. He is skilled in EEG, nerve conduction studies, and neuroimaging interpretations. He is SELS and BLS certified, active member of IMA and API. With this introduction, I think you will enjoy and learn many things from Dr. Avinash. Thank you, Dr. Avinash. Please.
Thank you, sir. First of all, I want to thanks to the organizing team for giving me opportunity to speak here. So my talk is basically approach to a patient with the seizures or epilepsy. So as you all know that seizure is very common, as sir told, it is previously very mute, but nowadays very common in OPD practice. What is seizure? Basically, it is a paroxysmal event due to the abnormal excessive hypersynchronous neuronal activity in a brain. Then what is difference between the seizure and epilepsy? If you'll see, epilepsy is basically a recurrent episode of seizure, which is usually approximately 12 hours apart, which is not provoked. What do you mean by provoked? Any particular culprit is called provoked. But if it is an unprovoked 2 episode, a gap of 12 hours, that means it is an epilepsy. So comes to the classification of epilepsy, the ILA classification, previously they gave a basic classification in which the main aim of the seizure classification is depend on the onset of the epilepsy, whether it is a focal onset, whether it is generalized onset, whether it is an unknown onset. So again they have divided the focal into whether the level of awareness was present or unaware. Then further classified into subset like a motor and non-motor. This is the very basic classification we given in the 2002-2004. Later on they found that lot of seizure classifications, lot of seizure manifestations are there which we cannot put into a particular types. So they gave an expanded version of ILE classification. In this expanded version, they divided them into same onset of epilepsy, like focal, generalized or unknown. But in the subset, like in the motor and non-motor, they further differentiated into various subset. Like in the motor, they find that automatism, like the patient, some patient with temporal lobe epilepsy, they have a typical lip smacking or chewing like movements. Atonia, once the patient come with any type of seizure, focal or generalized, they have a atonia, means loss of tone, sudden loss of one muscle tones, arm or leg, or a generalized loss of tone. If a person is having generalized loss of tone, they will have a fall history. Clonic movement. Clonic means, as you know, the clonic means repeated, recurrent, jerky movement. That is a very recurrent. And the next one is epileptic spasm, means sudden loss of the flexion of a neck muscles or truncal muscles. Sometimes a hyperkinetic movement, like in the frontal lobe epilepsy, the patient will have a sudden thrashing movement, repeated jerky movements. Myoclonic is the same like a repeated movement, but it is irregular, whereas a clonic is a regular movement. Tonic, sudden severe contraction of a limbs. Similarly, these are the motor movements. Then where, like that motor, there are non-motor onset also, which include like autonomic features. Some patients have autonomic features like excessive sweating, piloerections, some goosebumps kind of picture, and can be have a gastric symptoms also. Sometimes behavior arrest, patient will have a mute. Whenever you are talking, suddenly he become mute. He will not respond to any answer or question or anything. Sometimes associated with cognitive function. In the cognitive, the patient have sudden loss of intellectual disability. He will not able to do some calculations. He will have some impaired comprehension. Other non-motor include emotional ability, apathy and all. Then sensory symptoms. Similar to the focal onset, they have a generalized onset, similar motor and non-motor symptoms. In generalized, you will have a typical and atypical non-motor absences. So they also, the newer classification have also changed some of the old terms into a new terms like unconscious become a impaired awareness, partial become seizure, focal, simple partial become focal with awareness, and previously complex partial, now it is focal impaired awareness. Then dyscognitive become focal impaired awareness, psychic change into the cognitive seizures, secondary generalized tonic-clonic become a focal to bilateral tonic-clonic, and the most important is arrest, freeze, pause, interruption, behavior arrest. This last one is very common in the children's present with the absence seizures. They will sudden brief staring spells, loss of consciousness for 2-3 seconds. These are basically a focal onset in which you can see only one limb is having a tonic posturing, whereas the generalized you can see both the limb has a tonic posturing along with the flexion of the neck muscles. So as I told, the focal is divided into with aware and without awareness, whereas the generalized is not having a such aware and unawareness, because in almost all the cases of generalized epilepsy, patient will have a loss of awareness. So I told you generalized have two other classified like typical absence and atypical absence. So these both atypical and typical are more common in young children. In typical, they have a brief sudden pause and staring up episodes. Sometimes the eye fluttering can be occur, head nodding, or sometimes autonomic behavior. The main difference is in the typical and atypical is typical is very short duration and rapid recovery will be there. And EEG you will find a 3 Hertz specific sharp and spike wave discharges. Whereas in atypical, you will have a brief long duration as compared to the typical absences. And the EEG is showing abnormal atypical finding of 2.5 to 2 Hertz sharp and spike wave discharges. Generalized eyelid myoclonia. Eyelid myoclonia is basically a sudden repetitive jerky movements of the eyelid and associated with the deviation of the eyeballs to up gaze. And it is most common associated with the young patient or more common during the bright light or using a mobile light, they will have this kind of symptoms. Sometimes this can also be associated with the absence seizures. That term is called as a G1 syndrome. So why there is an expanded version of classification? What is the need? So after this expanded classification, we find that it helps to choose the seizure type easier for seizure that did not fit into any previous classifications. They also clarified what is mean when a seizure is said to be in a particular type. And it also gives a proper transparency of terminology to a non-medical communities. So what are the consequences of poorly controlled seizure? So basically once a patient having a seizure, there are a lot of things happen in his life. It results in decline in the socioeconomic status, some medical comorbidities, some depressions, anxiety can occur, sometimes cognitive and medical memory disturbance, and also leads to the financial burden. We can also find sometimes sudden unexpected death in epilepsy, increased risk of status epilepticus, seizure-related injuries, seizure-related drowning or aspiration, sometimes suicidal tendency also. But this mortality is more common in a person with a repeated episode of seizures. A single episode or newly diagnosed seizure have less morbidity and mortality. So treatment protocol, treatment goal, the main aim of any clinician is to treat seizure completely. Seizure remission is must, and that too without much side effects. So coming to the type of remission, we have 3 types of remission. The first one is a spontaneous remission. We have seen that usually in the childhood epilepsy, which usually occur in the young age below the age of 20 years, they spontaneously remit sometime at the age of 25 to 30 at a juvenile adult age group. Sometimes remission occur after epileptic surgery, resection surgery. And the third one is remission with medicines, in which the seizure freedom for the past 10 years without medication during the 5 years. So total of 10 years seizure freedom with the medicines of 5 years and 5 years without medicine. So there is a study done by the Quen et al. 2000 and Chen et al. 2018. They found that the resistance, treatment resistance, they found that once you start monotherapy, approx 40 to 50% of the patient will develop a seizure remission. Rest 13% will develop a remission after the second monotherapy. And few person, approximately 35 to 37%, they will have a seizure persistent even after a polytherapy. So what is the reason behind that? There are a lot of reason behind that. I will tell that later. So first of all, I want to tell that what are the definition of treatment resistance. Treatment resistance mainly defined as a failure of adequate trial of two tolerated, appropriately chosen and used anti-epileptic drug, whether as a monotherapy or in combination to achieve sustained seizure freedom. So means at least two well-tolerated medicines should be given, and there is a relapse of the seizure, that means that seizure treatment resistance. So how to manage a drug resistance epilepsy? First of all, whenever you are using a medicines, whenever you are diagnosing a seizure, first of all, we have to confirm whether the diagnosis is correct or not. For that, we have to classify that seizure into a particular group, so the diagnosis accuracy is must. Second, compliance of the patient is very important, because if the patient is taking 1 year and suddenly he stops, he thinks that now my seizure is gone, and he relapses within 3 months. So compliance is very must, at least for 3 to 5 years. Co-medication changes, is there any, sometimes the patient feels that this is very costly brand, we have to change into generic brand. And because bioavailability of aid is very important, so we should not change the medicine brand also. If the patient is having everything is okay, diagnosis is okay, compliance is okay, and medicine is not changed, even though if he is developing a seizure, so we have to think, we have to check whether is there any possibility of epilepsy surgery. Because if a patient is having focal seizure, the chances of remission is more if he is fit candidate for the epilepsy surgery. So why there is too much diagnostic challenge in epilepsy? See, in our rural areas in India, it's very common, 50% approximately seizure is underdiagnosed. Lot of things, the rural patient don't want to expose himself that I am having a seizure. If a female of a reproductive age group or marriage age group is having a seizure, the father don't want to reveal because of her marriage. So lot of things, unawareness, sometimes the seizure occur in the night. So they avoid that thing that this is a seizure. So once you diagnosed, confirm that this is epilepsy and seizure, we have to start with the first monotherapy to the full tolerable dose without any side effect. If the patient is having a seizure remission, we have to continue with the same medicine. If the patient is having a seizure, even after the first monotherapy, we have to switch to the second monotherapy. And then we have to see whether the treatment goal is achieved or not. If not, that is treatment resistance. So we have to start video easy. We have to check for is there any possibility of surgery which can give benefit. We have to give other therapies like vagal nerve stimulation, ketogenic diet. We have to give a polypharmacy at last to give a maximum quality of life, long-term seizure control, minimize the AED side effects, and maximize adherence. So coming to the anti-epileptic drug from the past, over the past 150 years, we have a lot of anti-epileptic developed from 1910. Initially, we have only phenobarbital and phenytoin. Now in the 2013, we have a lot of new medicines like lacosamide, clobazam, perampanel, and carbamazepine. So we should know the mechanism of action of each and every medicine, because whenever you are using a polytherapy, we should use at least 2 different mechanism of action medicine, so that the side effect will be less and maximum benefit will be there. So if you'll see the mechanism of action, valproic acid is a broad spectrum, but we should not use valproic acid as a first line in so many cases. They have typically meant for some cases like idiopathic generalized epilepsy, because side effect of valproic acid is too much. They can cause liver toxicity. In young female, they have weight gain, hirsutism, they have a teratogenic effect in reproductive age group. So each and every anti-epileptic has a serious side effects. We should keep in mind, and we should tell the patient during the prescription so that they should know the side effect, and if they can consult immediately if they are developing any side effects. So after the treatment, the most important question is when to discontinue therapy. So different guidelines says 1 year, some guidelines says 2 years in children, 4 years in adulthood. The most important thing in our practice, at least 1 to 5 years of seizure control with medicine. Generalized epilepsy has a better response after discontinued therapy compared to the focal epilepsy. Patients who are having MRI normal, EEG normal, no history of family history of seizure or neurological normal examination can have a better response. And once you are stopping the medicines, we should tell the patient that the chances of recurrence of seizure is more common within the first 3 months. So in that first 3 months, we should teach them they should not drive, should not do too much electrical, high risk area, swimming, and any high hilly area should avoid it because that causes life death. So anti-seizure medicines, adverse effects should be more considered during the pregnancy. So in pregnancy, we have a very limited options like lacosamide, lamotrigine is the safest medicine, and should avoid the sodium valproate as whenever it is possible. So considering in the selection initial treatment, as I told, first we have to diagnose the seizure confirmly, then explain the patient what are the medicines are prescribing, what are the side effects, what are the mechanism of actions, so what are the comorbidity, age, reproductive constitution, and cost. All should be considered while giving a treatment. So to summarize, epilepsy is a heterogeneous clinical condition characterized by recurrent unprovoked seizure, their complications and cause. Epilepsy accounts for significant proportion of the world disease burden, approximately 4th ranking after tension type headache, migraine and Alzheimer's. Diagnostic misclassification have strong impact on personal and societal reflection of the disease. Epilepsy strongly affect patient independence, psychological health and emotional adjustment. Epilepsy impair all aspects of health related quality of life. So early diagnosis and treatment is important. We have almost 30 types of AEDs available, and we know approx 30 to 35% within the epilepsy continue to experience seizure even after trying several medications. Each anti-seizure medication offers different safety, efficacy, and pharmacokinetic profile. Selection of AEDs should be individualized based on the patient-related and drug-related factor. Thank you.
Thank you, Dr. Avinash, for your nice talk. But as we belong to Coal India, I would expect 2 lines from you regarding his disease with his relation to Coal India workers. Most Coal India workers go underground or near moving objects. And it is always a dispute between the trade union and the doctors for doing the medical examination, whether this person should be fit. They want that after treatment or after 6 months or 1 year of remission, they insist that he should be allowed for normal duty. So what is your opinion?
Sir, first of all, we should know what are the cause of the epilepsy. Because most of the SECL workers, they have usually a alcohol withdrawal seizure. Almost 50% of the patient I encountered with the alcohol withdrawal. So alcohol withdrawal person, if the patient is having like alcohol free for 6 months, and with medicines, they can do a job. In railway, they have with 3 years of seizure free they want. So if the patient is having a seizure, they will not allow them to do any job. In only they used to do a job. But for me, at least 6 months of medicine and should know what are the exact cause of that seizure.
Since we are behind our schedule, I will thank you all and end this session.
Thank you, chairpersons, and thank you, Dr. Avinash Gupta sir. Now I request our chairperson to facilitate our guest speaker.
Now I request Dr. Devender Tudu sir to kindly felicitate our chairperson. Sir, please.
There's an important announcement. There's a change in schedule for tomorrow morning. That is 2nd of March, Monday session. The first session starts at 8 a.m. sharp. All the case presenters, you're requested to be present in the hall at 7:45 a.m. You miss the time, you miss the chance. So all the case presenters who are there in the hall at present or not there, they are all advised to come at 7:45 with their presentations for tomorrow morning. Thank you.
With a very heavy heart, I wanted to tell that we have received a very bad news right now. Dr. Parthasarthi Manna from ECL, who was a working CMS and was going to retire on 31st of March, has just passed away in Apollo, Kolkata, Apollo Hospital, Kolkata. So I request everyone to please stand up and mourn for the departed soul for 1 minute. Thank you. Now we will be starting with our free paper session, for which I would like to invite our first speaker, Dr. Sushila Kunte, Deputy CMO, Pench Area, WCL. To judge this session, for chairing this session, I would like to invite Dr. M.T. Tikas sir, ex-CMS ACCL, and Dr. Sunil Kumar sir, Area Medical Officer, Johilla area. Sir, please. Ma'am, please.
The time limit set for this session is 6 minutes. There will be no questionnaires. There will be no question answer session. Only 6 minutes for the presentation.
A very good evening to respected chairperson and all dignitaries. My name is Dr. Sushila Khute. The topic of my paper presentation today is LNG-IUS, a novel alternative to hysterectomy in benign gynecological condition, a prospective observational case series from Coal India Hospital. As per the statistic data from National Family Health Survey 2019-2021, in India, hysterectomy is the second most common surgery performed among women after cesarean section. And the most frequently reported reason for this is the excessive menstrual bleeding and pain. In this map, we can see the prevalence of hysterectomies in different parts of India. Like in Chhattisgarh and Madhya Pradesh, it is about 61 and 62%, whereas in South, the prevalence has increased to even more than 80%. So this data really raises a concern about the potential causes of unnecessary surgeries and lack of awareness regarding the alternative options available in present scenario. This slide also features the clipping from various news outlets, which also covers the issue extensively. And because of this, the Ministry of Health and Family Welfare, they issue a guideline to address these unnecessary hysterectomies. Coming to the burden of AUB, in India, its prevalence is about 49.9% in perimenopausal age group. Now, what exactly is the AUB? Any bleeding pattern which is not consistent with the normal menstrual cycle, like if the duration of the cycle is less than 21 days, more than 35 days, if the volume of blood loss is more than 80 ml per cycle, and if it lasts for more than 7 to 8 days, it all comes under AUB. As per International FIGO Palm Coin classification, AUB is categorized into structural and non-structural causes. Coming to the introduction of LNG-IUS, it is a progesterone hormone, levonorgestrel, releasing intrauterine system, which releases 20 microgram of LNG daily in the endometrial cavity for about 5 years. And because of this local action and 4-time decrease in the serum progesterone level, it has been found to have no significant systemic changes in the blood pressure, lipid profile, or carbohydrate metabolism, etc. And it is also approved by US FDA in 2009 for the treatment of heavy menstrual bleeding. Coming to the objective of my study is to find out the effectiveness of LNG-IUS in the management of abnormal uterine bleeding over 6-month follow-up period and its role in avoiding hysterectomy. Coming to material and method, our study design is a prospective observational case series which was conducted in Badkuhi Central Hospital WCL and Korba Main Hospital SECL in Gynec department. Sample size was 21 cases between age group 35 to 55 years who come under my inclusion criteria. And the study period was between January 2020 to December 2025. This table shows the inclusion and exclusion criteria of my study. Inclusion criteria includes Paris women who have failed with the conventional medical therapy. This 3D pie chart shows the age-wise distribution in my study patient. Among this, the majority of patients were between 40 to 45 years. This bar graph shows that multiple comorbidities also coexist in my study patient. Among this, the majority of the patients were anemia, hypertension, followed by obesity, diabetes, and thyroid disorder. This bar graph shows the type of AUB distribution in my study patient. Among this, the majority of the patients were adenomyosis, followed by endometriosis and fibroids. And all these 21 patients, after excluding the exclusion criteria with proper counseling and baseline scan and investigation, LNG-IUS was inserted within 7 days of the menstrual cycle and follow-up was done after 6 months. So here is the follow-up of my studies. The first follow-up is of PBAC score. This bar graph shows the comparison of mean PBAC score, which is a pictorial blood loss assessment chart, which is a validated tool to assess the severity of bleeding in female. This was 152 ml pre-insertion, which signifies a heavy menstrual bleeding. After 6 months, it decreased to about 37.8 ml, which represent a clinical decrease in the severity of bleeding of about 75.1%. This bar graph shows the comparison of mean VAS pain score, which is 8.8 pre-insertion, which signifies a severe dysmenorrhea in a patient. After 6 months, it decreased to about 1.8, which represents a clinical decrease in the severity of pain of about 79.5%. This slide shows the comparative table of different clinical variables pre-insertion and 6-month post-insertion, which is found to have decrease in the mean endometrial thickness from 14.4 mm to 7.2 mm, increase in the mean hemoglobin level from 7.8 to 10.1, and decrease in the mean PBAC and VAS score as discussed before. So all the outcomes of these clinical variables, they are statistically highly significant as the p-value is found to be less than 0.001. This bar graph shows that 19 out of my 21 patients, they were avoided hysterectomies, whose percentage is about 90.5%, which signifies the high success rate and high patient satisfaction rate of LNG-IUS insertion. This is the final result, which shows all the clinical variables that are statistically significant. Coming to the discussion, my study findings are in concordance with both the Indian and the international studies, like Kriplani et al., Malik et al., Harshikan et al., or Chen et al., which is a systemic review and meta-analysis. Finally, I'd like to conclude my topic with this take-home message. Our study demonstrates a significant reduction in the menstrual blood loss of about 75.1%, pelvic pain 79.5%, and endometrial thickness 50%, and increase in the mean hemoglobin level by 2.3 gram per deciliter after the LNG-IUS insertion. And this LNG-IUS also emerged as a safe, cost-effective, and reliable alternative to hysterectomy across all the AUB spectrum, and it is suitable for a women in peripheral and resource-limited hospital. Over 3 decades of global success and strong evidence-based support, LNG-IUS stands as a comprehensive uterus-preserving solution for long-term management of AUB. These are my references. Thank you.
Thank you. There is one question. Had you have follow-up of these cases afterwards? Any change in the endometrial or local site?
Yes, the endometrial thickness has decreased.
There is no, in follow-up, have you got any malignant, pre-malignant conditions in these cases?
No, sir. In that my exclusion criteria, I had already excluded all this.
After insertion of this stent?
Before insertion, the baseline
Afterwards?
scan and investigation I had already done, and I had ruled out everything. In my exclusion criteria, it is written key. First, we have to rule out all the malignancies, atypical endometrium, everything we had ruled out.
After the effect of Mirena. Mirena. After the effect of the Mirena. After insertion of that. Afterwards.
After there is no need.
There was no follow-up.
There is no need, sir.
Okay.
There are evidences who says there is no need.
Okay, thank you.
Thanks.
Next case presentation will be topical steroid abuse in India. Speaker Anu Neha.
Everyone, I am Dr. Anu Neha, presently serving as Deputy MS at SECL headquarters. It is my privilege to present my paper titled Topical Steroid Abuse in India. What are steroids cream? They're formerly known as topical corticosteroids. They work by calming the immune system, thus decreases the inflammation. They relieve itching, reduces redness, eases swelling, and calms the irritation. When they are used in eczema, psoriasis, dermatitis, allergic reactions, and insect bites. Strength, they are categorized in 4 categories: very potent, moderate, and mild. Types of steroids are categorized in 3 categories: corticosteroid, anabolic steroids, and sex hormones. Corticosteroids are further subcategorized in mineral corticoids and glucocorticoids. Glucocorticoids work by reducing the inflammation, and mineral corticoids regulate sodium and potassium levels. And then comes anabolic steroids. Anabolic steroids are synthetic versions of testosterone. They are basically used for hormonal issues but abused for muscle building. Sex hormones naturally occurring estrogen and progesterone in the body. Based on the route of administration, corticosteroids are again categorized in oral, topical, inhaled, and injectable forms. In oral, the example comes as In oral, we use as prednisone and dexamethasone, and topical clobetasol and betamethasone. And injectable, we use in muscle pains, inflammation like hydrocortisone and methylprednisolone. And inhaled, we use in inhalers, like example is budesonide and fluticasone. Topical steroid abuse. Abuse occurs when it is used as inappropriately for high potency for too long, too often without medical guidance. We use high potency steroids for longer duration when they are meant for shorter duration. We use it every day for weeks and months. We mix it with the fairness creams. We use it for the cosmetic purposes where they're not meant to be used. Why abuse happens? Abuse happens because it is freely, easily available OTC accessible without prescription, and lack of awareness among public because they are unaware of the potential side effects of the steroids, and misuse of unapproved indications. They are used when they are contraindicated, like in acne, fungal infections, and melasma. And the fourth one comes as unsolicited recommendations from family, friends, and pharmacists. What is the damage which occurs after prolonged misuse of steroids? In skin, we see as skin atrophy, that is thinning of the skin, stria, permanent stretch marks, and telangiectasia. And in face features, we see as steroid-induced acne, perioral dermatitis, and topical steroid-dependent face, also known as red face syndrome. In mast infections, we see as tinea incognito. When we use in fungal infections, it suppresses the immune system and thus increases the susceptibility and thus increases the recurrent chances of fungal infections. Then comes topical steroid withdrawal. When steroids are stopped abruptly after prolonged misuse, the skin and the whole body can react severely. Intense rebound, redness, burning sensation and stinging, swelling and oozing of the skin, severe itching and skin shedding, nerve pain described as zingers by patients. It not only affects the skin but overall mental and physical well-being. It causes insomnia, fatigue, anxiety and depressions in patients with topical withdrawal. And how do we manage topical steroid withdrawal? Recovery is possible, but it takes time, patience and medical supervision. We need to taper the drug. We need to treat the underlying disease. We can use antibiotics, oral antihistaminics, cold compresses, bland emollients, and medication. Prevention: how can we prevent using the steroids safely? Use only when prescribed. Before using, we need to see the instructions given by the doctor, as in case of strength and duration of how to and when time to use steroids. Avoid cosmetic use. Never use steroids for fairness, acne or skin glow unless specifically indicated by your dermatologist. Read labels carefully. Avoid triple combination creams and always check ingredient list before applying any product to sensitive skin areas. Never stop abruptly. Discontinue only after consulting your dermatologist to avoid severe rebound symptoms. Seek psychological support. TSW can cause lasting anxiety and depression. Counseling and mental health support are a valid and important part of recovery. Thank you.
Okay, thank you. Have you any study on this issue? How many cases you have studied at
Sir,
your
this
station?
is basically my studies on OPD cases that I have seen on daily basis, dermatological cases, like fungal infections and melasma, on patients that are misusing steroids over that. That is, all my studies are based on daily OPD cases, dermatological cases.
Do you have any long-term follow-up of these cases for long-term use of the local steroid?
Sir, sorry, sir?
Long-term use of local steroid, have you any follow-up of these cases?
Sir, in long-term use, you want to know,
Yes.
know the side effects of what? Steroids.
Have you any study on this issue?
How I have studied?
Yes.
Sir, on daily basis, if you are using steroid, on fungal infection, it is called tinea incognito, is going to cause tinea incognito. On daily basis, I am seeing dermatological cases in OPD. In that, we come to know the uses, indication, contraindications, and how the patient is using for long duration and causing misuse of steroids.
What is the dreaded most complication you have seen up to now?
Sir, tinea incognito have seen rebound redness after stoppage of steroids. Abrupt stoppage of steroids, I have seen rebound redness, itching, burning sensation in patients of melasma specifically.
Okay, thank you.
Thank you, sir.
Next next study will be presented by Dr. Vinita Lal. Letrozole in the female infertility.
Good evening, chairpersons and dignitaries. I'm Dr. Vinita Lal, Senior Specialist from Badkui Central Hospital. I'm going to present on letrozole and infertility in PCOS in Coal India Hospital. So causes of infertility are female factors and male factor. Female factor most common is ovulatory dysfunction accounting for 27%. Next is tubal factor 17%. Next is endometriosis 9%. Then uterine factor 5% and unexplained infertility is around 17%. Anovulation, this main causes of ovulatory dysfunction is anovulation, and polycystic ovarian syndrome is the most common cause of anovulation. So WHO classification of anovulation are of 3 types. Type 1 is hypothalamo-pituitary failure. Type 2 is hypothalamo-pituitary dysfunction. PCOS is predominant this type. In this, serum estradiol is increased or normal. Serum FSH is normal and high LH is there, and the incidence is more than 90%. Type 3 is ovarian failure. In this, serum estradiol is decreased and serum FSH is increased. The incidence is 10%. So clinical approach to ovulation induction is to finding the cause of anovulation. In PCOS, ovulation induction is the cornerstone of management. Initially, clomiphene citrate was the traditional first-line therapy. Now the latest guidelines support letrozole. So the options for ovulation induction in PCOS are: first is lifestyle modification, which includes moderate amount of exercise, adequate sleep, stress management, healthy diet, and health supplements. Next is oral agents, which includes letrozole and clomiphene citrate. Next is injectable gonadotropins, and last is ovarian drilling and assisted reproductive techniques. So the goals of ovulation induction is to induce monofollicular development, start with least invasive and simplest treatment option, maximize rate of singleton pregnancies, and minimize risk of OHSs. Letrozole is a wonder drug for ovulation. It's a 3rd generation aromatase inhibitor. The aromatase enzyme is responsible for the conversion of androgen into estrogen in ovaries and peripheral tissue. So letrozole, it causes decrease in estrogen production, thereby removes negative feedback on hypothalamus, thereby increased FSH secretion and increased ovarian follicular development. So the advantage of letrozole over CC. Clomiphene citrate is a selective estrogen receptor modulator with a long half-life of 5 to 7 days, and that of letrozole is short, around 2 days. Anti-estrogenic effects of letrozole are low, thereby the endometrium is thick and a favorable cervical mucus is there, and uterine blood flow is increased in case of letrozole, and the risk of OHSs and multiple pregnancy is low with letrozole. The dosing regimen is from 2.5 mg per day, can be escalated up to 7.5 mg per day, and started from day 2 to day 6 and max up to 10 days. So the outcome was studied in Badkui Central Hospital, WCL from 2019 to 2025. Total 47 PCOS patients underwent 102 ovulation induction cycles, and they were prescribed letrozole 2.5 to 7.5 mg from day 2 to day 6, and 39 patients delivered clinically healthy babies. And monitoring of ovarian stimulation is done by transvaginal ultrasound scan, and number and size of follicles is measured, and also the endometrial thickness. Trigger is given when the dominant follicle reaches around 18 to 20 mm in size, and injection HCG 5,000 to 10,000 units is given. Luteal phase support is given from day 16 to 25, and dydrogesterone 10 mg is given. Fetal safety, there is no increased risk of major and minor fetal congenital anomalies with letrozole. The International PCOS guidelines, as well as the Reproductive Endocrinologic Society, they prefer letrozole over clomiphene citrate. So the take-home message is, in oligo-ovulation with PCOS, letrozole is the drug of choice. It's safe, effective, and patient-friendly. It has a superior outcome with better safety. It's ideal for Coal India hospital practice. Letrozole is not just evidence-based, it's institution-appropriate. Our goal is not just ovulation or pregnancy, but restoring balance, supporting a healthy body, a confident mind, and a hopeful spirit. Thank you.
Okay, thank you. What about out of 47 cases, you got success in 39 cases?
Right.
What about those cases, those who were not pregnant because of this one?
So some of the patients, they had this letrozole resistance. So they were referred for like injectable gonadotropins therapy or need for assisted reproductive techniques was required in those patients.
Which was the previous drug we were using?
Pardon, sir?
Previously, what we were using in place of this one?
Sir, those patients were prescribed letrozole for 6 cycles in an increasingly escalated dose schedule, because initially letrozole 5 mg was prescribed for 5 days and 3 cycles were monitored. Then a gap of 3 months was given, and again dose escalation was done up to 7.5 mg per day for 5 to 10 days for such patients. In spite of that, they had luteinized unruptured follicle. So that means they had this letrozole resistance. The other supportive lifestyle modifications were also advised for these patients, and also PCOS-specific drugs like myoinositol, D-chiroinositol, they were also prescribed along with metformin. But still, there was those patients needed assisted reproductive techniques, so they were advised to consult.
Was there any scope about increasing or stepping up the doses of the letrozole?
Pardon, sir?
Was there any scope to step up the doses again more of this drug, letrozole?
Sir, actually, by the guidelines, if we go with the guidelines, the dose escalation can be done only up to 7.5 mg per day. Beyond that, if the patient is not ovulating, ideally it should be combined with either injectable gonadotropins, or they should be induced with injectable gonadotropins alone. And for injectable gonadotropins, the risk of OHS is a bit higher. So in a setup like ours, so that requires more monitoring. So since the risk of OHS is higher, so such patients can't be managed at our setup.
Okay, thank you.
Okay, thank you, sir.
So, next paper will be presented by Dr. Ranjit Kumar, Occupational Health Hazards.
Good evening, everyone, respected chairpersons and all the delegates from CIL. I am Dr. Ranjit Kumar from CCL Hazaribagh, and I am here to present on topic Occupational Health in Coal Mines, Strategies for Worker Safety, Disease Prevention and Sustainable Mining. Coal mining plays a vital role in supporting infrastructural development, energy production security, and industrialization. Despite technological advancements, mining remains one of the most hazardous occupations worldwide. Miners are exposed to several physical, chemical, ergonomic hazards that significantly affect their health and quality of life. The concept of healthy mines, healthy nation reflects the understanding that economic strength cannot be sustained without safeguarding the health of its workforce. Healthy miners are essential for safe and productive mining operations. An effective occupational health system reduce occupational diseases, improve productivity, lower compensation and healthcare costings, enhance worker morale, and support community. Prioritizing miners' health becomes a stabilizing force for industries, reinforcing the idea that healthy mines contribute directly to healthy nation. Some common occupational hazards in mining industry are physical hazards, chemical hazards, agronomic hazards, and psychosocial hazards. This is some common prevalent occupational health issues in coal mines as per Research Journal and DGMS portal. Maximum comprising of respiratory issues followed by musculoskeletal and then mechanical injuries, and the least are some other health concerns like skin allergies, dermatitis or burns cases. This pie chart shows some common occupational health issues in miners of Hazaribagh area that I noticed since 2025 till present date, where maximum cases I encountered were of respiratory cases, followed by psychosocial, then musculoskeletal, and rest were other mechanical injuries. Strategies to prevent and promote occupational health. First is hazard identification and risk assessment. Regular workplace monitoring, dust and noise measurements, and health risk assessments are fundamental to prevention. Engineering and administrative controls like proper ventilation systems, dust suppression technologies, mechanization, job rotation, and safe work procedures. Availability of personal protective equipments, proper selection, training, and compliance regarding PPE provides protection in the hazardous environment. Occupational health surveillance. Periodic and regular medical examinations, lung function tests, audiometry, and biological monitoring enable early detection of occupational diseases. Health promotion and worker education. Programs and camps on nutrition, fitness, tobacco, and alcohol cessation, stress management, and mental health awareness improve overall well-being. Now, the role of policy management on occupational health professionals. Strong occupational health outcome depends on effective policy and its enforcement, commitment on mine management, integration of occupational health into mine planning, and multidisciplinary occupational health teams. Occupational health professionals play a key role in risk assessment, health surveillance, training, emergency preparedness, and research. These slides are some awareness regarding emergency response and PPEs amongst mine workers in our area by the medical team of CIMECON Hazaribagh. This is the medical examination cum health checkup of employees that we took on, and this is the emergency responsiveness and life-saving training to employees of CIMECON Hazaribagh. This slide mainly shows the training session where we included the students of our DAV school that is in our area, where maximum students are the wards of the CIMECON employees that work in mines, so that even the wards get awareness regarding first aid and occupational health issues, and they can help in any way to their guardian. Occupational health sustainability and national development. Sustainable mining compels balancing economic growth with worker health and environment protection. Occupational health contributes to sustainability by ensuring a stable and healthy workforce, reducing long-term disability, supporting national healthcare systems, aligning with sustainable development goals, particularly good health and decent work. Challenges and future directions. Despite progress, challenges remain, including informal mining, inadequate resources, underreporting of diseases, lack of emergency training and awareness, breaks in medical records tracking, and emergency risks from new technologies. Future efforts should focus on digital health monitoring and smart mining techniques, mental health integration into occupational health programs, stronger health surveillance system and patient data recording, routine medical examination of active workers and recently superannuated workers. So the conclusion is that while there has been significant advances in improving occupational health and safety in coal mines, there still exists challenges in direction to work upon. There is need for advanced suppression technologies for minimizing dust exposures, safeguarding working environment, compelling proper personal protective equipments for workers and its proper use, occupational health regulations and its enforcement. Development of standard health infrastructure in mining regions and introduction of complete digital medical surveillance would create better lasting impact on miners' health. Training and promoting awareness with combined efforts from safety and medical department will bring better sense of position and works of safety behaviors in mines. The vision of healthy mines, healthy nation underscores that occupational health is not an isolated workplace issue but a national priority. Thank you.
Okay, have you got your own study? Have you got your own study on this occupational health in your area?
Sir?
Have you got your own study on this issue, occupational health hazards, in your own area?
Yes, sir. Actually, I joined 1 year back in Coal India, and since then, the records that I encountered, I presented that in the histogram, sir.
Okay, thank you.
Thank you, sir.
So next presentation will be by Dr. Shiva Brahma Prasad, role of platelet-rich plasma in wound healing and clinical experience in 4 cases.
Good evening, respected doctors and dignitaries. My topic for discussion is role of platelet-rich plasma in wound healing and our clinical experience in 4 cases. So what is PRP? PRP is defined as an autologous concentration of platelets suspended in a small volume of plasma with plasma concentration of about 3 to 7 times higher than the baseline value. To be effective, the minimum platelet count should be at least 1 million per microliter in the PRP. So what is its role? PRP contains high level of biological dose of growth factors that help in tissue regeneration and repair. Regarding the background, these are the basic stuff. The alpha granules of the platelet contain 7 important growth factors that plays a crucial role in tissue regeneration and repair. So coming to the mechanism, once activated, platelet release about 70% of growth factors in the 10 minutes and next 95% in 1 hour. Once activated, the platelet release the growth factors. These growth factors bind to the transmembranous receptors of the target cells, which includes mesenchymal stem cells, osteoblasts, fibroblasts, endothelial and epidermal cells. Once these are activated, they release, they help in cellular proliferation, matrix formation, osteoid production and collagen synthesis, thereby provoking tissue repair and regeneration. So methods of PRP preparation. There are 3 methods. One is the standard method, that is called by name itself PRP method. The second Buffy coat method, and third commercially available kits. But the principle of all these methods is the same, differential centrifugation. So now we are discussing about the first method, the PRP method. In the PRP method, about 20 to 60 ml of whole blood is collected and then centrifuged at a speed of 3300 RMP for 3 minutes. This is called as soft spin. With this soft spin, the whole blood is separated into 3 layers: an upper plasma layer, middle RBC layer, middle WBC layer called as Buffy coat layer, and the lower one is the RBC layer. And in the next step, we take the upper plasma layer and again centrifuge it at a higher speed of 4400 RMP for 4 minutes. This is called as hard spin, that results in production of a plasma that is rich in platelets in its lower 1/3 of this tube. This upper 2/3 is discarded. This is the final product. The lower 1/3 is used for the PRP injection. Similarly, in Buffy coat method, after the first step, both the plasma layer and the Buffy coat layer, these 2 layers are taken and again goes through the hard spin, similar to the above one, that results in the PRP that is rich in both platelets and WBC. This is called as leukocyte rich PRP. The other one is the leukocyte poor PRP. So 20 ml of whole blood gives around 4 to 5 ml of PRP. These are the commercial available goods, similar thing. Factors affecting the PRP: amount of blood drawn and the speed of the centrifugation. Clinical appliances: in orthopedics, it is used in early osteoarthritis, tendinopathies, and partial tears of ligaments like ACL and rotator cuff partial tears. In spine cases, it is used in lumbar disc degeneration disease, facet joint arthropathy, SI joint dysfunction, and paraspinal muscle pains. In wound, it's almost used all types of wound. The main thing is it prevents the need for skin grafting in many cases. Dermatology used in androgenic alopecia, acne scars, anti-aging rejuvenation therapies, and hyperpigmentation treatments. Our clinical experience, we used PRP for 4 cases, 2 are diabetic ulcers, 2 are non-healing ulcers of unknown etiology. That resulted, our results are very encouraging. We have seen a healthy granulation tissue within 7 to 10 days, 30 to 40% faster healing rate, no need of skin graft in all our 4 cases. Patients were extremely satisfied. This is after 3 PRP injections with a interval of 7 days in between them. This is the second one. We had injected a PRP. Within a first dose, we have seen a profound formation of granulation tissue. This is a third and fourth case, a similar one. This at the time of injecting PRP. Advantages is 100% autologous, so very safe, minimal complication, outdoor procedure, highly cost effective. Limitations, there is no universal standardization procedures, various concentration of platelets produce various results. Results also vary in elderly and smokers. Contraindications, there is no much contraindications. If at all there can be related to platelet dysfunction, maybe chronic thrombocytopenia, septicemia, local infection and malignancies at the local site. Relative contraindications are mostly related to anemia like hemoglobin levels, decreased hemoglobin levels, and also use of steroids and NSAIDs. These are contraindicated 1 week prior and later to the PRP injection as they interact with the functioning of the platelets. Complication, not much complication, maybe pain and swelling at the local site. Conclusion, PRP is one of the most promising and safe regenerative therapies available today. It accelerates healing by leveraging the body's own biological potential. Our clinical experience and global evidences both support the same. So PRP can be considered as early choice of treatment in all the early orthopedic, osteoarthritic cases, tendon injuries and chronic ulcers. Thank you.
Okay. You have given PRP in the local site, in the wound.
Yes, sir. Yes, sir.
Any other local ointment or local any preparation you have used for this?
Yes, sir. I used for ACL tears, partial ACL tears, grade 1 partial ACL tears, and also used for tennis elbows, and also non-healing ulcers I am anyway giving. Especially I used in these 2 cases, tennis elbows and ACL injuries. And also sometimes I give for shoulder pains.
You got complete healing within 10 days.
Sir?
You said. How many days you got healing of that wound?
Sir, regeneration tissue, healthy granulation tissue will see within 7 days, sir. Very healthy.
Okay. Thank you.
Thank you, sir.
So next case presentation will be by Dr. Satraj Roy, a case of macrophage activation syndrome due to scrub typhus.
Good evening, respected chairperson and delegate. My topic is the scrub typhus induced the macrophage activation syndrome. First of all, my gratitude to the CIL and SECL for organizing this SEMICON. So, scrub typhus is caused by the Oriensa a rare trigger of the mass, and mass is a life-threatening inflammatory state and mimics severe sepsis with secondary hemocytophilic liquidity features. Case presentation, the initial features are 40 years old female from an endemic area presented with high-grade fever for 7 days with unconsciousness. Presented with hyperglycemia 420 without prior diabetes. There is features of hypotension and tachycardia. On examinations, there is in the backside of the patients, this rare S-church was found. The laboratory findings, there is a leukopenia, thrombocytopenia, hyperferritinemia, hypertriglyceridemia, and coagulopathy. The radiological findings, there is a pleural effusions in the both of the X-ray also. The confirmation of the diagnosis was done by the scrub typhus IgM serology and bone marrow biopsy done, which shows hemophagocytosis. And the final diagnosis is a mass secondary to the scrub typhus. The pictures of the bone marrow biopsy. The patient was progressed to ARDS. She required mechanical ventilations and ultimately developed MODS. and an acute kidney injury and hepatic dysfunction. Patient was treated with meropenem BD, TDS, doxycycline 100 BD, low-dose steroids, especially methylprednisolone, insulin infusion, lung protective ventilations, and CRTT. Outcome: it's a dramatic improvement within 72 hours with the resolutions of the fever, wind up by 5 days, and full organ recovery by day 12, and discharge the neurologically intact stage. The scrap typhus, we all know, it's caused by the Orion species transmitted by the larval mite. Clinical clues: the acute high-grade fever, headache, myalgia, S-chart, especially seen in this type of patient, rash, lymphadenopathy. And laboratory findings include the thrombocytopenia, elevated transaminase, and hyponatremia. Actually, this thrombocytopenia and elevated transaminase actually hit my mind that may be the case of the scrap typhus. The scrap typhus complication leads to the ARDS, AKI, hepatitis, encephalitis, shock, and macrophage activating syndrome. The diagnosis is by the IgM, ELISA, PCR, and IFA is gold standard. Treatment with the doxycycline, BD for 5 to 7 days. The MAS is a life-threatening hyperinflammatory syndrome. It's a severe immune dysregulation with uncontrolled macrophage and T-cell activation that leads to a cytokine storm and multi-organ failure. The common triggers are the infections like Epstein-Barr virus, dengue, sepsis due to related other causes, and scrap typhus. And obviously the rheumatological disorders and definitely the malignancy. The clinical pictures are the persistent high-grade fever, hepatosplenomegaly, cytopenias, and altered sensorium. There is maybe the bleeding tendency and rapid progressions to the renal failure. In these patients, the striking features were the very high ferritin level, thrombocytopenia along with the pancytopenia, the triglyceride level, and increased triglyceride, reduced fibrinogen, increased LDH, and the coagulopathy. So bone marrow biopsy was not mandatory for the diagnosis of MAS, but we have done it. The management is the treat underlying the trigger, IV methylprednisolone, if needed, IV immunoglobulin or cyclosporin may be used. And intensive care support is very much important. There are several evidences, studies done in the India and Asia and other studies. Like study the Jean et al. Published in the BMC Infectious Disease that showed that scrap typhus is associated with HLH. The patient presented with fever, cytopenias, liver dysfunction, and important thing is the ferritin. Another studies also showed that the scrap typhus can trigger the HLH like hyperinflammations. This study was published, but actually I have sent it for the publication. It's accepted in the Bengal Physicians Journal and published in the next coming 3 months. The take-home message: the scrap typhus can rarely trigger the MAS. Early serological diagnosis is crucial. Prompt conservative management can be the life-saving, and timely intervention can prevent high mortality. Thank you everybody for your presence sharing.
Thank you. For how many days you have kept patient on ventilator? Intensive care unit. You have taken that patient, and for how many days you have given ventilatory support?
Patient went from the ventilator on the day 5. Patient went on the ventilator. First 2 days, first day patient admitted and then deteriorated, rapidly progressing to the morts, and then goes to ventilator. 5 days it was wind off.
So steroid was the mainstay of your treatment?
Yes, steroid not sir. Actually we have targeted with all our resources, meropenem, prednisolone, and doxycycline. And definitely the doxycycline and steroid is the main armamentarium.
Okay, thank you.
I now request all the speakers for free paper to come on stage and request the chairpersons to felicitate them. Dr. Sushila Khunte, Dr. Anu Neha, Dr. Vinita V. Lal, Dr. Ranjit Kumar, Dr. Shiv Brahma Prasad, Dr. Satyajit Roy.
Is there any last case?
No,
sir.
Dr. Akash is
Sir,
absent.
he is not present
Okay,
here.
thank you.
Dr. Akash is absent, the last presenter. So we conclude today's session. Regarding tomorrow's session, there's a slight preponement of the schedule. We are going to start sharp at 8 a.m. The first is the case presentation. So all the people, all the delegates who are there for the case presentation, be present in the hall at around 7:45 a.m. Thank you.
कल जिनके प्रेजेंटेशन है, जैसा हमारी साइंटिफिक कमेटी बता रही है, अगर वो नहीं सुन रहे हैं तो उनके दोस्त अगर सुन रहे हैं तो वो उस ब्रोचर में पढ़ के उनको ले आएं। कल बहुत ही अच्छे प्रेजेंटेशन है. A very famous pulmonologist from Kolkata, Dr. Shubhankar is also have reached our venue. He is going to deliver his talk on this pulmonology. And two more interesting thing, our CIL HR director has already arrived. He is also coming tomorrow for this valedictory function. So please be on time. Again, I want to make one more announcement that today we have a cultural night at same pool ground, and कल की तुलना में आज कुछ ज़्यादा अच्छे महंगे बेहतरीन कलाकार आ रहे हैं. So please enjoy all those things.
अभिषेक आनंद सर, मेक योरसेल्फ वार्म अप कर लीजिए. वार्म अप करिए, खाली कमर नहीं हिलाने से चलेगा, आज सब हिलना चाहिए.
I request Dr. Suman Mukherjee sir, Deputy CMO, Badgaon SECL, to felicitate our chairpersons.
Dr. Suman Mukherjee sir is facilitating our chairperson for this session, and by this we are ending this scientific session here, and get ready for a mega cultural eve, and beware tomorrow morning scientific session. Thank you all. Thank you for coming here and gracing this ceremony. Thank you again.